So, as we often do, we will start with the national anthems and then we will proceed. Can we play the national anthems? Thank you. We can take our seats. We are going to have a word of prayer. I want to invite Hajat Leila Naluima to give us a word of prayer.
Good morning, everyone. Let's sum ourselves for prayer. In the name of God, most gracious, most merciful, Lord Father, we thank you for this day. We thank you for the gathering, and we thank for everyone who is going to be part of this. May we deliberate for the good of the nation and for the good of the stepchild in the healthcare sector. Thank you very much, everyone. Amen.
Thank you, Leila. So we are going to dive straight into the Charwazi Memorial Lecture, and I'm going to invite Dr. Rachel Aikoru to take over this session. Thank you.
Good morning. It's on. Good morning. I think today is better than yesterday. It's not as cold as it was around this time. And as is our culture, we would like to know who's next to us. So the mics, please. We would like to have a small round of introduction of who's around us, who is sitting where, and then we can kick off. I think the person who won't introduce himself today will be our first presenter for today. So the mic will jump some tables. Kindly mics. So I'll start the introduction as the mics are being brought. I'm Dr. Aikoru Jane Rachel. I'm a GIT surgeon. I have a passion for pancreatitis, teaching and doing, and managing. I work in Mulago, and I always like saying I'm a female surgeon to press the message home. Please take charge.
Good morning, everyone. I'm Dr. Kanyika Andrew Marvin. I'm a medical officer and research associate at Mengo Hospital. Thank you.
Hello, colleagues. I'm Kintuluwaga, consultant surgeon, breast and endocrine surgery.
Morning, everyone. Dr. Julius Luyimbazi. I'm a urologist, Lubaga Hospital.
Good morning, brothers and sisters. I'm Nalong Barbara Nabaiga, in charge transplant theatre, Lubaga Hospital. Thank you.
Good morning, everyone. My name is Nalima Leila. I'm Assistant Nursing Officer in charge of Uganda Cancer Institute Operating Theatre.
Yes, hello, everyone. Professor Eric Senon, I'm proud to be here. I've been inspired and I look forward to becoming a professor. Almost all the room is for professors. I'm currently an intern doctor at Lacho Hospital. I have passion for global surgery and medical education, in particular simulation training. Thank you.
Good morning, everyone. My name is Diana Inomugisha. I'm a nursing officer at Mulago National Referral Hospital. I previously worked as the overall in charge for the 16 theaters, and I'm happy to be here.
Good morning, everyone. I'm known by the names of Gwang Oscar, a general surgery resident, Makerere College of Health Science. Thank you.
Good morning, everyone. My name is Nsubuga Yakobo. I'm a 5th year medical student from Guru University. I'm happy to be here.
I'm Flavia Were, Assistant General Secretary of Asou.
Morning, everyone. I'm Sister Professor Ajiko Mary Margaret, consultant surgeon working at Soroti Regional Referral Hospital.
Good morning, everyone. My name is Dr. Asaba Mugisha Irene. I'm a plastic surgeon based in Mulago. Thank you.
Morning. I'm having problems still with my leg. Morning, everyone. I'm Jacqueline Mabujano, Senior Consultant Surgeon working in Mulago Hospital, Accident and Emergency Unit.
Good morning, I'm Patrick Chamanywa, happy to be here. Thank you.
I'm Nasa Kakembo, a pediatric surgeon and senior lecturer at Makerere University. I'm a member of Asou executive for the Central Region.
Podoi Joseph, and my name senior consultant surgeon and urologist, Soroti Regional Referral Hospital.
Good morning, I'm Christine Namlindwa, Public Relations Officer, Uganda Cancer Institute. Thank you.
Good morning, Galukanda Moses, President-elect Asou.
Good morning, Nasali Goretti, Surgeon at Nagalama.
Salome Maswime from Cape Town, honorary member of Asou.
morning, everybody. Greg Beelman from University of Minnesota, General Surgeon.
Good morning, Jen Rickard, University of Minnesota, Trauma and Critical Care.
And yourself?
Sorry, I had forgotten to introduce myself. I'm Dr. Edward Kakungulu. I'm a general surgeon at the Uganda Cancer Institute.
Thank you very much. Thank you for the brief introductions. So, many of us may wonder what this is all about, what Chalwazi Memorial Lecture is all about. It's not about a doctor called Chalwazi Memorial, but it's in memory of him. Okay? So, the reason, it's an annual thing that we always have in Asou, and it's the reason as to why we have this memory is not because he was a doctor of many fasts. It's not because he was, it's not because he had academic excellence, which truth is he had and beat many odds. It's not because he was great at sports. It's not because he went to SMARC or went to Royal College of Surgeons in Edinburgh. And it's not because he was the first to enroll for a fellowship at the Royal College of Surgeons or the first president of the Association of Surgeons of East Africa. But we celebrate an icon that we do not want to just learn in history. We want to remember because it gives us inspiration as surgeons, as aspiring surgeons. Like someone has stated, is a professor to be. You know, these are inspiring moments. We celebrate and remember because of his immense contributions to the medical field, some of which I may mention, like starting the Masters of Medicine in Postgraduate Training in Uganda, being the mastermind behind the establishment of the Uganda Cancer Institute, being the chief investigator at the Cancer Institute on projects like the Burkitt's lymphoma, liver cancers, Kaposi sarcomas, and you know, recently there's been a wave of transplants. We are hearing of corneal transplants. Those who didn't know about it, we have had kidney transplants. And this Dr. Sebastian Chalwazi had a dream that liver transplant could happen in Uganda. And the dream is alive as it is. I know many things are going on. We have heard of the in charge of liver transplant in Rubaga. So the dream is not so far away. It lives on. That's why we still keep having these lectures. And so today, Thursday, the 28th of April, we would like to invite a renowned leader in the medical field, Dr. Jackson Orem, who is the senior consultant medical oncologist at Uganda Cancer Institute. Why it's important to have him is, you know, when I give this background of Chalwazi and the Uganda Cancer Institute, we see how close dreams came into being. So we present the executive director of the Uganda Cancer Institute. He has done a lot in that place, from seeing it expanded from an 80-bed to a 365-bed capacity as of now. And he has championed the establishment. He's currently championing the establishment of regional cancer centers so that there's decentralization of cancer care in Uganda. He has got the gist of how to push agendas, and that is through going through the health policies, having health systems in place, having cancer research, and making sure medical education is achieved so that, you know, everyone is on board, all the stakeholders are on board. Dr. Orem is passionate about cancer care, and I request the House to put hands together as we invite him to give us a keynote. You're welcome, Dr. Rem.
Hope my slide will come. A very good morning to all of you. It is my privilege and pleasure to be here this morning speaking in an audience of eminent surgeons, surgeons in the making, medical fraternity members from all disciplines who are here. And I want to take this opportunity in a special way to congratulate Asou for making this annual lecture in the memory of Professor Sebastian Chalwazi. I was here last year, and I participated in something similar. And I hear very clearly what the person who introduced me stated about the role of Professor Chalwazi, not only in surgery, but in medicine in general in Uganda. And I want to really thank the Association of Surgeons of Uganda for keeping that candle burning so that we don't forget the immense sacrifice, the immense role he played in developing surgery, but in particular in developing medical profession in the country. So when I was asked to give this lecture this time, I decided to reflect on some of the sentiments that I had last year. One of those sentiments actually came from the family of Professor Sebastian Chalwazi, and it came in the way of, I would say, a regret that there was something that was promised to them and it has never been fulfilled. And that really bothered me so much. I was told, or I heard, that there was a road that was supposed to have been named after him, and the family has waited, I think, for donkey years, and they did not see that happening. And that was supposed to have been done by the university. So I want now to ask for your indulgence that behind the scene, the Uganda Cancer Institute has contacted Kampala Capital City Authority, and the city authority has actually granted that one of the roads within the Mulago complex is going to be named after him. So I want to bring this good news to Asou, and I want to ask so that we can sit together and think of an appropriate moment so that that road can be unveiled. I already know where it is. Actually, it leads very directly to the new site of the Uganda Cancer Institute, to let the cat out of the basket. Next slide. So I decided to structure my lecture such that I give ample background to the contribution of Professor Chalwazi in the development of the discipline of oncology in the country, not only in the country, but in the East African region. And I decided to glean from that the important Oh, very good. Thank you. To glean from that some important attributes, and then what can be of importance to us in the current era that we can use in order to leapfrog some of the new developments, not only in oncology, but in surgery generally, and in medicine in particular. I should disclose here that I nearly actually became a surgeon, and some of my best, I would say, experiences were in surgery, and I became a physician by, I don't want to say by mistake, but by coincidence. So I don't want to go into that. So I feel very comfortable in the company of surgeons, and I'm really so happy and privileged to be here. As you all know, Professor Chalwazi was a pioneering cancer researcher, and he came back after his training from Edinburgh, and his focus was actually in development of cancer research in Uganda. And at the time when he returned, his main interest was actually in chemotherapy. And I'm going to give you a background why that interest actually occurred to him, despite the fact that he was a surgeon. And he had chosen particularly an enigmatic disease called Kaposi sarcoma as his flagship, which he wanted to study. His return coincided with a lot of interest that had actually developed in Makerere and Mulago in particular, because of a well-researched database that was unveiled by Professor Davis, and that was the Kampala Cancer Registry. So what Professor Davis did was to enumerate cancers actually within Kampala, and then combine it with the well-documented archive of Sir Albert Cook from Mengo Hospital. And that archive showed, together with the analysis from the Kampala Cancer Registry, that cancer was alive and well in Uganda, and very common, especially in those in the age bracket of 40 to 50 years, and very similar to what was being seen in the Western world. So that meant that actually cancer was a problem here in Uganda, just like it was in the Western world or in Europe, and where Sebastian Chalwazi had just returned, and cancer research was actually very, very important and was actually a growing area. And he came during that time and with that enthusiasm, and Kaposi sarcoma was the lead disease that actually he was passionate about. From the same findings of Davis, another very eminent surgeon by the name of Dennis Bucket actually went back and started looking at a very common tumor that was occurring in children but was not well understood. And he documented the frequencies of this tumor and also described the fact that it had very high doubling time, and it was actually associated with simultaneous occurrence in different parts of the body. And that time, the occurrence of malignancies in that fashion, or any disease in that fashion, would be taken as something which is multicentric. So there was the concept of multicentric disease. And of course, from the background that Professor Chalwazi had, multicentric disease also was being looked at as systemic occurrence of disease. So these two terminologies were actually being used simultaneously. And the fact that there was a disease that was occurring in that manner meant that actually both Professor Chalwazi as well as Dr. Dennis Bucket had something in common in the multicentric nature of these two diseases, and that is Kaposi sarcoma as well as Burkitt's lymphoma. Of course, the two hypotheses that then came out of that, number one was that because of this occurrence of Burkitt's lymphoma, it could actually be related to infection. And then that was the line that was taken by Dennis Bucket. And then on the side of Professor Chalwazi, his focus was the fact that any disease that was occurring in that manner could actually be amenable to the newly discovered or newly introduced mode of treatment called chemotherapy. So that was his focus. And of course, to cut a long story short, the hypothesis driven by Dennis Bucket later on would lead to the discovery of the virus called Epstein-Barr virus, which all of you know as the first cancer-associated virus of all. And then, of course, as I had already said, the move towards treatment with chemotherapy was the line that Chalwazi took. So as I said, Chalwazi's interest in the concept of multicentric disease was mainly now looking at Kaposi sarcoma. It expanded also to liver cancer and Hodgkin's disease. These are the diseases that he was actually very interested in. You can see from that, you know, despite the fact that he was a surgeon, he was actually in practice a physician. His main focus was looking for potential cure for these cancers, and this was because at that time, as you know very well, the most effective method of treatment of cancer, apart from surgery, was the new modality of radiotherapy. But that was not available here in Uganda. So by emphasizing the use of a systemic approach, what Professor Chalwazi was doing was to be pragmatic, to get something that can actually be used in the absence of chemotherapy here, rather radiotherapy here in Uganda. So you can see from that he was a very pragmatic person. Of course, as I already stated, the discovery of Burkitt's lymphoma and then the description of the different cancers by Davis meant that actually Mulago was a very good place because of the variety of malignancies that were actually found in the hospital. But despite that, there was lack of infrastructure as well as what it would take for a person who has just returned from abroad, like Sebastian Chalwazi, who has seen the infrastructure as well as whatever it takes, including the organization of research. Those were actually lacking in Mulago, despite the fact that cancers were in plenty and opportunities for doing clinical research or clinical trial was actually beckoning. And of course, with the description of buckets as a disease and the fact that it was also showing a lot of promise in the clinical trials on chemotherapy, that at that time was actually still a new modality for treatment of cancers. There were so many people who were interested to come and be part of what was going on here in Kampala. And the fact that the main hospital did not have the capacity to actually accommodate this research interest meant that there was actually need for a dedicated area where these researches could be done, and in particular on cancers. And this coincided by a trip that was made by a very powerful team from the National Cancer Institute of the United States, who were actually moving throughout Africa. They were looking for the most suitable venue where they can also anchor their research and using the model of diseases that were available here in Africa. And in particular, that was actually mainly because of the discovery of Burkitt's lymphoma in Uganda. So they first went to Kenya, they went to Nigeria, I think they went to Ghana as well. But when they came to Uganda, the presence of luminaries like Chebestan Jalwazi, Dennis Burkitt, Professor Ian McAdam, and many others, very eminent Makerere academics, there was no way they could think of another place. And it was on the insistence of Professor Chalwazi that an opportunity has actually come for developing that capacity for conducting clinical trials. And to cut a long story short, the Uganda Cancer Institute was born. So Uganda Cancer Institute was born as a result of the enthusiasm as well as the farsightedness of Professor Chalwazi. Of course, Professor Chalwazi did not think short-term. Actually, he was thinking that whatever was being established at the Uganda Cancer Institute should actually live for posterity. He thought that this should be a long-term investment, and not only for treating cancer in Uganda, but it should be for the region and for Africa. And as a result of that, he offered hospitality to all the collaborators who would come to Uganda, to the Uganda Cancer Institute, students, etc. And he was very keen at development and identification of talents, especially among the young. And so we can say that he actually provided leadership in as far as training is concerned. And I think it is no surprise that the development of the Masters of Medicine program was actually on the back of his attitude towards mentorship as well as development of leadership among young people. Of course, this can be also reflected in the way he looked at actually cancer management. And this he coined in 1974 that cancer was a common problem in Africa, and because even at that time, there were others who were actually still thinking that this was not the case. So he opined that cancer was a common problem in Africa, contrary to the notion that it was a disease of the developed world. And this, despite the fact that the data of Davis was showing that actually the frequencies of cancer in Uganda, in Kampala, were similar to the frequencies of cancer in the West, or in England for that matter. So for emphasis, this is what Professor Chalwazi was saying. And he did not only stop there, he also actually mentioned the fact that the hallmark, in as far as we are concerned at that time, was the mortality. You know, it was like a hopeless situation. But he was looking at it from a different perspective. What he had in mind was the fact that chemotherapy can actually be administered. That means treatment can actually lead to the decline in this mortality rate. So he was very optimistic that actually cancer was a curable condition. But not only that, the other point which he mentioned, which is also very important, was about the absence of control of symptoms at that time. And he coined the terminology that it was an agonizing death, you know, at that time. So I think we can, from this, say that Professor Chalwazi was looking at management of cancer from an holistic perspective. He was very optimistic that actually effective treatment can happen. And then secondly, he was also actually optimistic that we can provide good symptom control. And I think that is what we now call palliative care. Unfortunately, after his demise, we forgot about this. And as you know very well, in most of the developing world, for a very long time, actually there was only the one-sided kind of notion of treatment of cancer here, that you can only control symptoms, which I don't believe in. I think we can effectively treat cancer holistically here as elsewhere. And that was actually what Professor Chalwazi stood for. Of course, he did not stop there. The other area which he kind of emphasized very much during his time was the fact that it's not enough just to see a patient in a clinic and then say bye-bye, the patient goes away. He thought that patients must be followed up to where they come from. And there must be a feedback mechanism to know what is going on for each and every patient that comes to his clinic. And in order for that to happen, he enlisted the support of people in the area of public health. So he actually recruited in his team a group from the School of Public Health, a gentleman by the name of Aloysius Kasule, as well as there was another professor who was actually working with this gentleman, and made them to track all the patients who are seen at the Uganda Cancer Institute, to the extent that they created a database and a cohort of all those patients. And he knew what was going on about those patients every time, and there was actually a very rich collection of data on that. So we would say that that was the beginning of our community cancer program. Of course, he was also very much multidisciplinary in his approach, and I think Professor Galokande should pay attention to this. Professor Chalwazi practiced across disciplines, and he wanted actually the Department of Surgery to be aligned with the rest of the other departments within the medical school. think the signal is weak. Yeah, that's what it's saying. So, at the time, when he was looking for someone to take charge of the Uganda Cancer Institute, he actually came across Professor Charles Olweny, whom you all know very well. And Professor Charles Olweny had just returned from his training from the United States, but he was based in the Department of Medicine. The position for leadership of the Uganda Cancer Institute was based in the Department of Surgery. So Professor Chalwazi made it possible for appointment to be given for Professor Olweny in the Department of Medicine through the Department of Surgery. So that shows you that, Professor Chalwazi was already thinking long-term. He was already thinking that all these barriers about oncology can actually be brought down in the sense that surgical oncology, medical oncology, pediatric, name it, can actually work together as one. And I think that is a very beautiful example of multidisciplinary approach in oncology. He was a person who emphasized documentation, and not only that, but also publishing of results. He was keen on this, and his topics or his research were actually driven by this. There is nothing that he did that was not good enough to be documented and then to be published. And that is shown by the areas which he chose, and then by the quality of the journals in which he published. And you can see for yourself on the slide, those are very powerful journals during that time. He was not just going for anything, he was going for the best. Of course, I've already spoken about talent identification, and I mentioned to you about Professor Charles Olweny, whom he quickly identified and decided to make him head the Uganda Cancer Institute. He identified another physician, Professor Edward Katongole-Mbide, who again also became the head of the Uganda Cancer Institute. I don't know why actually the surgeons were not coming forward to go and lead the Uganda Cancer Institute, but I leave that to you. And I think really the way Professor Chalwazi was looking at things was that all these are actually physicians and all these are potential oncologists. So there is no difference whether they are in the Department of Medicine or they are from the Department of Surgery. So long as they are all passionate about cancer care, there was no big deal there. And of course, it is told that his residence in Kololo was actually a beehive of students. Even outside of the school hours, they are trooping at his home, trying to find out, asking him one or two things. So you can see what type of person he was in as far as identification and nurturing of talent is concerned. This is a very interesting slide that I actually want you to pay attention to. It was in 1979, during the war of liberation here in Uganda, when Professor Chalwazi and Professor Olweny actually made an observation of the occurrence of Kaposi sarcoma in a very different way, in that they were seeing a lot of young people and many females coming up with Kaposi sarcoma, which was different from what they were used to seeing, this disease of the extremities of older men and children, but now manifesting in women and younger people. So that was an intriguing observation that they made. And of course, immediately they decided that this is something that they needed to actually report. And they decided to host a conference on Kaposi sarcoma here in Uganda to review the characteristic of the disease and understand what was going on because of this change in the presentation of disease. Immediately, of course, the natural place to run to, because of the collaboration that was already going on, was the National Cancer Institute of the United States. But unfortunately, this proposal was not acceptable because in the United States, they were asking themselves, we don't see this disease here. This is not our problem. This is the problem of Africa. So for that matter, goodbye, we do not have the funding for this. But good enough, when they went to WHO, they actually got the funding, and they came, and that conference actually did take place here in Kampala. And it was very interesting. There was actually a shift that was seen in the presentation of Kaposi sarcoma, and this was actually published. And before the day closed on that conference, there was, of course, as you know very well, in 1981-82, there was the outbreak of HIV. And the hallmark of the disease was Kaposi sarcoma. And this time, the National Cancer Institute got in touch with them and then said, can we have a look at the conference book that you had in Kampala? Of course, they did actually oblige. And what I'm trying to say here is that could it be that actually we would have been the first to describe HIV? Uganda should have been the place where HIV should have actually been pronounced as a problem rather than somewhere else. And I think if we have people of the caliber of Professor Chalwazi, and I'm very sure in this audience we have those type of people, we need to get back to the kind of thinking mode and analytical, critical thinking that we had in surgeons like Professor Chalwazi. Of course, let me now summarize, given this background that I've given you, the key attributes that really come out of this. Number one, there was very evident mark of excellence in all that Professor Chalwazi did. Then number two, leadership. Number three, team spirit. And number four, pragmatic approach. I would say Professor Chalwazi combined all the three attributes of a good academic doctor. That is being very astute as a clinician, being adept at research, and then being a good educator. I do know that a good number of us actually practice academic medicine. There is no better example of practicing academic medicine than what has been exemplified by Professor Chalwazi. Then, of course, the attribute of collegialness, collaboration, and being open to new ideas, new people. And I think this is also something that we can actually learn. Then, of course, the question we ask is, where are we in as far as all this is concerned? I can answer that question by saying that the Uganda Cancer Institute, which I would say is the living legacy of what Professor Chalwazi stands for, is still very much alive. And we are building capacity. And as you heard earlier, we are now the East Africa Center of Excellence in Oncology. We want this to grow, and we want to make sure that this goes without saying that this is the work we are following in the footsteps of Professor Chalwazi. As I told you, he looked at the Uganda Cancer Institute not just as a project that at a certain point was going to end. He looked at it as something that was there to stay. We do have many opportunities of doing projects. Do we look at the projects that we are doing as something that is just for a time, or as something that actually is supposed to live on and to serve humanity? To me, I think this is a very important attribute that we need to actually reflect on, at least some of us who are involved in projects. At times, actually, I joke and say that if there is a project that was ever done by a researcher at Makerere University that has gone through all the stages of what a study or what a project should do, that project is the Uganda Cancer Institute. Because it must have been planned as a research, and then after that, it must have gone through being executed, and then after that, there must have been some results, and after those results, there must have been some policies influenced, and I want to leave it to you to judge whether this has all been fulfilled. Because as you can see, the Uganda Cancer Institute is now part and parcel of fight against cancer, not only in Uganda, but also in the entire Africa. And I want to say all this credit must be given to the farsightedness of Professor Sebastian Chalwazi. And then, of course, what remains to be done, I think we must move into being a fully comprehensive in as far as our services are concerned. We must have a well-coordinated discipline of oncology. And then, of course, the community approach that I was talking about must actually be the emphasis. And in as far as the discipline of oncology is concerned, I want to say that surgery still remains the backbone of the practice of oncology. And the fact that perhaps we are still very weak in this area, to me, is something that the Association of Surgeons of Uganda need to think about very, very seriously. So as I conclude, I think Professor Chalwazi has given us the blueprint for an effective 21st century public servant. We don't need to go very far. We don't need to look at other people. We have an example. And of course, the Uganda Cancer Institute is the enduring legacy of Professor Chalwazi, serving the public of Uganda and beyond. So you can say that despite the fact that he is not here now, what he has done is still actually serving humanity. What a legacy. So the call to the Association of Surgeons of Uganda, which I want to repeat, is to take interest in this legacy of Professor Chalwazi, especially the area of collaboration. And I want to really state that the doors of the Uganda Cancer Institute is very much open. We want to collaborate with the Association of Surgeons. I was telling Professor Galokande that our facilities are available to be used by the association because we have really a common cause. And finally, and very finally, I want us to develop a very strong department of surgical oncology at the Uganda Cancer Institute. Thank you.
Thank you, Dr. Rem. You just got it out of my mouth. I had noted down that the surgical oncology at Uganda Institute should move at the same pace as the medical oncology, for us to be at the peak of oncological excellence in East and Central Africa. Thank you very much. And for Asou, we have been given a blank check. What we write in it depends on us. So let's take it by the horns. I'd like us to do a simple exercise as surgeons of Uganda, just to say this after me. I have been inspired. I have been inspired. I am going to be impactful. That's a promise to yourself, because you know we have one life to live and we have to make impact for the next generation and other generations to come. We have the ability. Thank you very much. I would like to call you Professor Rem. They say it's only about professors. And before we close this session, I thank you very much for your attention. I would like to invite you back to the podium to have this captured for memories. You're welcome back.
Sorry, we are going to invite our president-elect to give a vote of thanks to our lecturer, but also we would like to take a group photo with him so that we can be able to close the lecture. Yeah.
Good morning, ladies and gentlemen. Thank you for making the time. Thank you very much, Dr. Rem. I've listened to a number of Chalwazi lectures. I don't know about you, but it looks like each time there's something new that pops out. And I think you are a brilliant historian, if you didn't know. We appreciate, I mean, you've always been open. You've always been open to surgery, walking into UCI, but we thank you again for opening the door once again. We also congratulate UCI for the decentralization that's going on. I'm sure all of you may know, or if you don't, there are 4 centers that are being opened up: Gulu, Mbara, Mbale, and Arua. And of course, that is going to be very impactful in terms of improving access, because our theme is access, yeah? Improving access to care. And of course, I was whispering to him there that do you have the human resource to man all these 4 centers? And his answer was an emphatic yes. And clearly, those are opportunities for surgery as well, the surgeons. So to do our part and take our role. Thank you very much again for the wonderful talk. And for those who are not here, we are glad that we have the recordings and it will be shared widely once again. Thank you very much.
Everyone is invited. Kindly come in front. So then we go to our next one. Thank you so much. So I hope our guest lecturer is still with us for the next session. So the next session is about surgical bioethics and professionalism. And I want to welcome Dr. Joseph Epodoi to take over the chair of this session. Thank you.
Ladies and gentlemen, I'm overjoyed this morning to be here, to be at the pulpit. I would welcome our audience and the virtual participants to this session. We are going to have 2 virtual presenters and 3 amongst us here who will present, I would call it live. Without much ado, our first presenter, well, these presenters have a very high-powered lineup. The first presenter is a surgeon and lecturer at Makerere University College of Health Sciences. Since 2009, she heads up a GI unit at Mulago Tertiary Referral Hospital, which specializes in gastroenterology and hepatopancreaticobiliary diseases. She specializes in minimal access surgery and both diagnostic and interventional endoscopy. She's a fellow of the College of Surgeons of East, Southern, and Central and Southern Africa, and a member of the World Association of Laparoscopic Surgeons. She's a member and patron of the Association of Laparoscopic Surgeons of Uganda, that is Asou, and has been conducting laparoscopic surgery for the last decade. She's involved in training of undergraduates and postgraduate trainees in the Department of Surgery of Makerere University. And she's currently also pursuing a PhD in bioethics and has a passion for good clinical ethical practice in the field of clinical surgery and surgical research. Incidentally, I've known her for the last 30 years. When I look at all the people in this room, all that profile only matches the only Dr. Olivia Kituka. You're welcome, madam.
Thank you, Dr. Epodoi. I'm privileged to be introduced in a way that I don't even recognize myself, like many of you have been feeling when you're introduced, by someone very distinguished as Dr. Epodoi. 30 years, I'm not sure if it was 30 years, I'm sure people are doing some maths, but well, it's been a long time. I don't know if the presentation is ready, but I'm going to take us away from cutting patients to the other things that go around our work and their ethical issues. And many of you have had ethical challenges in terms of how you deal with problems that come out following surgery, how you communicate issues, communicate what you're going to do, and how you communicate what could go wrong, and how you communicate the various options that the patients have. And this is usually an area that surgeons find difficult to handle. but we are going to go head on into it because it is part and parcel of our practice, just as even medical practitioners, but even more so in surgery. My PhD is looking at informed consent among patients who are undergoing emergency surgery. And many of you have had to do this, I presume you do this, to get informed consent for a patient who is very sick. You're either going to get it from the patient himself, or you're going to get it from their next of kin, or whoever is available. And you've got to, this is not always very easy, especially in our accident and emergency units, as you see, as we may have seen in the various places we work. So let me get a hang of this. I don't know if it's working. Okay. Let's go back. So by introduction, many of you, when you talk about ethics, it sounds something amorphous. I think I also found it amorphous at the beginning, but it took a while. And when we we're talking about ethics, we're looking at certain 3 principles. And that is respect for persons, justice, and beneficence. This came about from a Belmont report following a lot of unethical things that were being done during the Nazi time, and a lot of strange research was going on, and there was a lot of unethical practice in the name of furthering science and medicine. And following that Belmont report, there are 3 principles that were brought up that were to be considered whenever you're trying to do anything and see if it's ethical. And that was respect for persons, justice, beneficence. There's a 4th principle that sometimes is added, that is non-maleficence, which is above all, do no harm. Of course, as surgeons, we do some kind of harm, but at the end of the day, it is a balance between whether that is causing a benefit eventually or is very risky for the patients. So as we're looking at these ethical issues, we're looking at it in terms of in terms of informed consent, which is taking place in our emergency units. One thing you do appreciate that you don't usually have time in an emergency setting, and decisions have to be made rapidly, and yet it is within that kind of framework that you have to consider those 3 things. And we are in many of our emergency units are not only low-resourced, as in you have not enough human resource, but you also find that they are crowded, the patients, there's no privacy. At some point, even there's no dignity for those patients. And yet you're going to be seeking for their consent and their permission in such a setting. And we did a study trying to establish how these practices are conducted in 2 tertiary teaching hospitals. In this case, we used Mulago Hospital, which is a public hospital, and then Nsambya Hospital, which is a private mission. I think I'm told not-for-profit is no longer the term, but anyway, private mission hospital. And we wanted to compare these practices in terms of the kind of setting of a public hospital, but also in the setting where there are financial costs involved, because much as the private hospital is not for profit, there are costs that are involved in care for the patients. So it was a qualitative study, and we conducted key informant interviews, and we did direct observation of the staff. I tried to look for images of Nsambya Hospital, Accident and Emergency Unit, and I could only get, well, there were empty beds. It doesn't mean that they don't work. it just also gives you an idea of the differences in the volumes of patients. So the one you see there is what is typically what Dr. Jackie deals with all the time. That is the reality. Patients on the floor, there are all sorts of their policemen, depending on who has brought the patient. And this was conducted over that period. And the data we collected, we analyzed using in vivo statistical analysis programs, qualitative analysis program. And when we observed the staff, of course, we had to do the observations without them knowing that we were observing them, because we didn't want them to be influenced by our presence. And we did note that I had to get, first of all, I had to get a research assistant who was going to observe them, but innocuously would blend in and not be noticed that they are being observed. Of course, we had to get, in terms of ethical issues, we had to get permission from the in charge of the unit to do it, but we could not tell the rest of the participants who were being observed that we were observing them, because we didn't want them to have their behavior modified by our presence. And we looked at those various domains, looked at communication skills, looked at how the disclosure of information was, and then we looked at the voluntariness of the decision, if it appeared as if the patient or their next of kin was able to give voluntary consent, and then also if the patient or the next of kin understood the information that was given. And this graph that comes in is now just a summary of all those different domains. The blue being the private, and the orange being the public hospital. And the higher, you'd see, we used a Likert score for each of those domains, and it was the best of 5. And then we got an average. And when you look at how these different domains were performed, you could see that the good ones were in domain A, which was the issue of greeting and communication. And then the bad ones came into the area of disclosure, which is in the middle of the graph, the B area, and then also in the part of understanding. So just for you to note, we did observe these participants at 4 different times at each of the institutions, because we knew that there are differences, there are variations in how this is going to be done at night, in the morning, on a Monday morning, on a Sunday evening. So we chose different times to try and capture the variations that will come across the different periods. And in summary, the best done was voluntariness and communication using simple language, which was encouraging. Most people, it was good to know that the patients, and it was evident that they were able to make a voluntary choice. And that, but then the worst done were, or those that were poorly done, most times did not greet any of the patients, I think. And greeting, in this case, we're talking about greeting the patients, introducing yourselves. People just would come and talk to the patients. This was happening at both institutions. And then also the disclosure. With disclosure, we're talking about risks, benefits, alternative options, and all this was not very well done, especially disclosure of risks. Again, also the assessment of understanding was really more like assessing recall. So we expected the doctor to give the information and then ask the patient or the next of kin to say what for example, I'm going to do an appendectomy, I'm going to remove your appendix and explain everything, and then say, so what are we going to do? Can you tell me in your own words? And then the patient would say something like that. And that was hardly done. We went on to do the key informant interview. This was going to try and help us inform why the behavior that we noticed, we observed, was being done. And those were we interviewed, as I said, 16 people, and that was the distribution in terms of the sex and the category of participants. And this was the information we eventually got. There are many themes that we got following the responses from the questionnaire that we gave them. And as far as knowledge and perspectives of informed consent, most people knew everything about that. We looked at processes and procedures and how they actually practice the informed consent, and then their disclosure issues, and then ethical considerations and the benefits they felt they had with informed consent and the challenges they faced. And those were the different codes or responses that were being given. And when you looked at knowledge and perspectives, these are just some statements that were given by the emergency staff, but generally they were well informed. They knew. And they knew the key elements which we talked about in terms of giving the diagnosis, the benefits of the procedure, the complications. At least they felt they gave information about the complications, but we observed that they didn't like to give about information about the risks. And the benefits. And when it looked at disclosure, it was, they felt that it was good to disclose it, communicate face-to-face with the patients, and elaborate all those treatment options, and more importantly, to involve another person, even if the patient was able to communicate, because they felt that this decision-making required help for the patients who sometimes may not have had the capacity to consent if they were very unwell, or they were in a lot of pain or having other challenges. And they would reach the extent of even calling other family, friends, and carers to get the consent. But the other issue that came up was this was in the private hospital. At the time of consent, the disclosure included providing information about the financial costs. So there were other ethical considerations about capacity to consent, and when the consent was being done, it was being done as the patient is being wheeled into the theater. And they thought that the benefits of the consent was that there was respect for the patient and they were protected. There were challenges about inadequate knowledge, communicating risk, language barriers, and time constraints. And in conclusion, we found out that all the emergency staff had adequate knowledge. However, there was inadequate disclosure many times because of time constraints. They felt they had to do things quickly. And in some cases, even the participants, the people who were giving the consent felt they lacked the knowledge about the procedure. For example, nurses were the ones giving consent about a procedure which the surgeon was going to do, and they didn't really have enough of that information. Then they felt they should have been guiding policies of consent, and they had challenges communicating risk. And the documentation, they felt that whatever they communicated should actually be documented. So it's clear that I have been told this and this about a particular procedure. Thank you.
I think by now you can agree with me that this is a very wonderful presenter, and I have more of them in line. Our guest speaker, our overseas participants from the UK, from the US, and from Soroti, you are really welcome. Before I continue, it will be very unfair for me to acknowledge the presence of Professor Sam Luboga. Professor Sam Luboga, you're welcome. In 1990, around October there, in the anatomy class, you gave us the first exam. It was called the zero test. And I remember I got 3%, somewhere there. That was the beginning of my journey in the world of medicine. And I'm now in the world of surgery. Without much ado, we're going to the next presenter. The next presenter we have is Dr. Eric Senuni. He's a primary trauma care provider and instructor with special interest in simulation-based medical education. He's an intern doctor at Lacho Hospital. And is currently an advocacy chair at Incision Uganda, and is enthusiastic about global surgery, searching for opportunities to do a PhD eventually. He told us that he's an aspiring professor, I think, of urology. You're welcome, sir.
Wow. Hello, everyone. Kopango. My name is Eric Otim. I bring you greetings from the land of Odi. That's the USA, United States of Acholi. It's a pleasure to be here. And I must say, informed consent is simplified, given the fact that Prof. Who spoke before me digested it all. My work is quite simple now. I'll take us through a case report of uninformed consent shift of a patient who initially, consented for expiratory laparotomy for gastric perforation, but eventually, while on operating table, the patient shifted and declined the initially provided consent. That's the team, not necessarily who operated, but the ones that wrote the paper. Well, at this point in time, we all understand that informed consent is paramount. And when it comes to surgical care, it's fundamental. No way we're going to run, surgeries and conduct any surgical procedure, whether minor, elective, or emergency, without informed consent. So you acknowledge the paramount part that informed consent plays in terms of ethics and in terms of, legal requirements. And you must acknowledge, like Prof. made mention earlier, that informed consent in emergency situation is really quite challenging. It's a complex process that if not tackled well appropriately, there are going to be gaps in fulfilling all the requirements of informed consent. So like I made mention earlier, our case is of a previously provided informed consent that later was denied. So it was a case of a 44-year-old male who was referred from a peripheral facility, came around midnight. Can you imagine? As all of you were sleeping were for night duty. A patient came in, and he was a known patient with chronic gastritis. The issues of self-medications are real. He was treating it with over-counter medication. Importantly, he was also a known chronic drinker, not of water, but alcohol. And he was a smoker. The patient presented with 2-day history of progressive abdominal pain and swelling, and this was accompanied by multiple episodes of non-projectile greenish shell vomiting, and he had failure to pass stool for the same duration. Well, the clinical evaluation, those of you who are keen, you remember steeplechase. What's the spot diagnosis? Well, I'll keep it at that. But the surgeons will tell you that's a surgical abdomen. Let's go in. It's quite clear that it's actually peritonitis, secondary to gastric perforation. You can recognize the A under the right hemidiaphragm and the gross haziness that shows you that there's peritonitis ongoing. Importantly to note is that still this very patient was in septic shock at the time of presentation. So the initial interventions included resuscitation to optimize the patient and make the patient fit for surgery. It should be noted that informed consent was first thought at the point of resuscitation, that's at the emergency unit, and the patient was fully explained in Acholi. The patient was an Acholi, of course. So upon giving the consent, the patient was transferred to operation room to call out the emergency, expiratory laparotomy. There we are in the theater. Doctor was again trying to reconvince the patient. Patient said, "Pamito ni kibara. I don't want the surgery." Doctor was trying to explain again that imito kibara wik ibima be, that you have to operate you to be well. But it was unfortunate that the patient still declined the initially provided consent. And the reason was simple. He said, "I would like my parents to be around if I'm to be operated. I don't know what the consequences will be, but I need my parents around." But remember, he was a 44-year-old, above the cutoff age for consent, not assent. So it brings various questions. Subsequently, you need to note that we actually lost the patient. The patient was transferred to HDU for further resuscitation, but the point of focus of the sepsis wasn't removed. So it was quite automatic that the patient couldn't survive. He didn't see the following sunset. It was quite unfortunate. So coming back to the theme of this conference, advancing access to safe, I bought the word timely and affordable surgical care. There is timeliness in informed consent when it comes to emergency surgical procedures. And to us, time matters a lot, and it's a constraint, it's a factor if we are to really have appropriate information given the patient. And I'll ask ourselves, I'll ask us all, what do you think went wrong? Was it that the patient was incapacitated? Was it about poor communication? But we explained in Acholi. Was it about limited time?
2 minutes.
Above all, could account for the decline of the informed consent. Could this be satisfactory enough? That's an informed consent, and the patient will sign, and yes, they will be operated. I don't know if the lawyers will forgive us, because I don't see any specification of the procedure that was going to be done or the possible risks. So I conclude by reminding us that we actually need proper communication skill training in context of informed consent, with also refresher trainings to address the different dilemmas that are facing the process of informed consent. To the public outside there, you should understand that in case you are incapacitated, your surrogate decision maker should be around. It's upon all of us. And we need to establish and functionalize institutional ethical committees to help overcome such dilemmas. Thank you so much.
Thank you very much for that wonderful presentation from the northern part of the country, and reminding some of us the phraseologies in that part of the country. We also those cartoons. So sometimes if you have missed a photograph of a particular scenario, get a cartoonist among your team to draw something, and it can act. That's what we have seen here. The next two presenters are actually online. The immediate presenter will be Dr. Senyondwa John Baptist. He's going to present whether cadaveric anatomy dissections are still relevant to surgical training. A tale of diversifying surgical training in low-income settings. Dr. JB, are you online?
Yes, I am. Can you hear me?
Yes, sir. We have the honor to host you here today at Protea in Entebbe. And before us, we have overseas delegation. We have acclaimed academicians in the house and professionals in different areas. And the media has ably put on their machines to cover you. You're welcome, sir.
Thank you, Dr. Podoi, for the introduction. I am John Baptist Senyondoa. I'm a general surgeon working at the Children's Children's Hospital in Entebbe. I'm glad to be online virtually, present this important work. I don't know if the slides are up. I would like to recognize my teachers, Professor Moses Galukande, Dr. Bellman from the University of Minnesota when I visited there, and every other person who has taught me in the journey to become a surgeon. I don't know if the PowerPoint is up and running. Is the PowerPoint on, or I can share it?
Please go ahead and share.
Okay.
We are able to see now. Please proceed.
All right. So I'll be presenting this topic: are cadaveric anatomy dissections still relevant to surgical training? And this is a tale of the diversing surgical training programs we have currently. So I'll take you through the introduction, the objectives of the study, how we conducted this study, the results of this study, and then finally conclusions. Okay, so starting it off, for a surgeon, we know that anatomy remains one of the crucial subjects that they need to conceptualize, because as engineers of the human body, we kind of use landmarks and features to define our incisions, define our approaches. And although it is a cornerstone, there's a very big growing difference in opinion over the role of cadaveric anatomic dissections, especially in the postgraduate setting. And with the merging medical specialization, where we have people training to be neurosurgeons as postgraduates, people training to be ENT surgeons, orthopedic surgeons, should they still be broad dissections or should they be focused? These are very important questions that we sought to answer with this study. And the other question that we didn't really dive deep into was, should these anatomy dissections be taught by specialized anatomists in a classroom, or should they be clinical teachings? And therefore, we decided to set out to do the study with the following objectives. One, we wanted to determine the perceptions of the professions that are surgeons about the dissections as a means of teaching or learning anatomy. And two, wanted to determine whether these anatomy dissections should be specialized to the student's specialty of training. So this was a cross-sectional study, mixed methods. We collected both qualitative and quantitative data, and we enrolled surgeons who are in practice and residents who are in training. In total, we had 24 participants in this survey, all who gave informed consent to participate in this study. And this is what we found out. All our participants had had cadaveric anatomy dissections in their postgraduate training. And all of them, I mean, most of them, the majority, 83%, were inmate surgery, with an inmate surgery background, and 88% of our participants had trained at Makerere University. The participants' ratings of these dissections were, most of them, majority of them, it was very good that they had these dissections, and it was their rating, their perceptions. The other staggering numbers were divided between them being unnecessary, very good, and unsure, as you can see by this graphic representation of the data. And then when we assessed the participants' perceptions on whether these dissections made them better surgeons, it was still controversial because the difference between those who strongly agreed and those who disagreed was insignificant. The majority of them agreed that they made them better surgeons, and a few of them disagreed. And when we asked the participants about the relevancy of these dissections in teaching anatomy on postgraduate level, the majority of them agreed that they're actually relevant to them learning anatomy dissections, which is kind of confusing given the prior report that we got. When we asked the participants about the perceptions on whether the dissection should be focused the specialty of training, the majority strongly agreed, as you can see, about 35%, and the graphic representation here. This other bigger proportion, which is about 25%, strongly disagreed. So, in conclusion, this survey still highlighted the controversy around whether these anatomy dissections are still relevant and whether they should be focused in terms of training, whether someone should dissect, if someone is doing neurosurgery, should they only dissect the head and neck versus them dissecting every part of the body. And we found that probably the anatomy dissections may parallel the specialty of the trainee. And in overall assessment, the dissections are still considered to be relevant to the training of surgeons, much as there's still bias about, imbalance about the responses, as we saw from the prior presentation of the data. So we recommend a further experimental study because this was largely a pilot study to further describe the approach for best teaching anatomy in the surgical resident and the approach to teaching it. That's it from me. Those were my references. And thank you so much for listening to me.
Thank you very much, Dr. J.B. Senyondwa, for two things. One, you have kept time. Two, you have been very eloquent. And you've saved us a lot of time here. Well, we've all seen that cadavers, dissection of cadavers has become controversial. But in the 90s, when I first met Professor Luboga, cadavers became our friends. Those days we were actually dissecting without gloves. And that's the passion we had for cadavers. Thank you very much for that presentation. The next presenter is equal online. We have Dr. Harvey Lekuya. He's a neurosurgeon. Dr. Lekuya's presentation was supposed to be yesterday, but all the same, we shall listen to it in the next 10 minutes. He's going to give us about metagenomic sequencing of skin microbiodata of the scalp, predicting the risk of developing surgical site infections following cranial surgery of traumatic brain injury. So you can see here, there's a lot of physiology, there's a lot of cerebral volvulus in this topic, but it's going to demystify it in the next 10 minutes. Dr. Harvey Lekuya, you're on the floor. Thank you very much. The audience is still the same as previously. You can proceed, sir.
Thank you, Mr. Podoi. I hope everyone can hear me well.
Yes, you are very audible.
Okay,
proceed.
thank you. So the topic is about metagenomic sequencing of the skin of the scalp, predicting the risk of surgical site infection during following trauma surgery in general and head trauma in general in particular. So this is basically to make it simple. It's the microbiome, what we call the normal skin that we have on the scalp, because we always operate on the skin and everywhere on the body. But I found out that the skin of the scalp was particular because of the density of the microorganism around it, and also the air. Everything was like so different that I found out like why we never thought about it. That this one of the chapter of infection outcome, I was just looking at different reasoning why we all kind of having an infection in the head trauma surgery. So these are the authors, the many different disciplines, then because of the particularity, because also it's a study group, we have several interests in the same topic. So as we can say, surgical site infections following TBI is up to 3 to 16, depending on the denominators and then also how people try to define it. But if someone survives head injury, the story is not yet there. Maybe you had surgery and happy, but still several outcomes still waiting. But the most frequently reported is infections. So we know that this infection, if it's not well tackled, so death can occur. So I don't want to go back to this rocket science story. It's always a mystery for surgeons. We like microscopic story, but you'll bear with me to listen to this basic science, like how we see our skin. Even if we scrub it, we clean it. Sometimes we clean. We have many procedures of cleaning, putting alcohol and so on. But just know it's not enough to do that because there are layers of the skin where microorganisms they are there. Sometimes we just clean what is superficial, but we don't go there and remove the real coat. So that means bacteria, they are still there, whatever we do. So when we do surgery, what happens, we make a breach through. Like this diagram just shows you the skin microbiota. Microbiota in general, it means everything in general, like bacteria, and they may be commensal bacteria or sometimes fungi and viruses. So they are there, they are in the real equilibrium. So when you make a skin break with your knife, the sharpness of your knife, don't think like it's just innocent. It's just dragged down from that line, things going down. And deep as you go, you also drag them down. And then this skin breach can bring you a story like infections, if it's happened, and then death. So that we all know that the skin microbiome, it's in a very good equilibrium to protect us. It's also like a kind of barrier to prevent other microorganisms to come. But at the same time, it depends which type of skin microbiome do you have. When I say skin microbiome, is also including other proteins and so on, but microbiota is always basically the germs. So here it's interaction between you, the person, the host, and the microorganism. If there is some disequilibrium or something happening, then the surgical site infection goes. So how did we do our research? Very, very basic research, as you can see. So you have a scalp of someone, you want to operate, do maybe TBI surgery or whatever. We pass through the scalp, and you can see the airline there. There's a lot of things happening, yeah? And then we have the outcome. So what we did is how to think of going to this. We know there's this one. And then we go through, we do what we call sequencing. We do the abundancy, we do the all the metrics of the metagenomics, and to differentiate different phylum and so on. And then we see those who go to develop infections, like this picture, just put it, it's one of the old paper I have, and those who will not develop infections. And that's the question of our research. I just make it simple so that everyone understands. So we have a normal skin, we swab in a method. I just put here a cross-sectional, but it's a perspective normally, just to simplify for this paper, because in the original paper it's a perspective because I put more data of what happened, but here I just simplify it so that we see the discussion when. So initially we have a cohort who are being operated. I took the sample, as you see. This is how we did it, the airline. We choose where, when you have a wound on the left, right, we choose where the normal skin is before you go to theater. So we scrub it. I think that was done. Some people were finding me crazy, say, what are you doing to scrubbing people's head like this? But it's for what? It was difficult to explain what we were doing through. And then when we pick it and we do it sterilely and then keep it and then we used to log as many as possible. We have like a bunch of all the patients we recruited. So because we didn't know who are going to develop infection and not, and how we're going to pre-select later based on our groups of study. And then we kept them as they go. We kept them in the -80 in the deep freezer. So what are we measuring? It's easily, we go to the extraction of DNA of the skin, and then we look at the different film, what's abundant, up to we stop at the genus level. Species, there are some cases we put on the paper. So the analysis was done basically between those who develop infection, call them SSI group or non-infected. So you will see this one. So we did graphical visualization and so on. Those are the metrics when you do metagenomics. It's quite not familiar, but when you want to talk about metagenomics, you have to use the metrics, the way they quantify the difference between the two groups. So the result in the new paper that we submitted has 12 who have been infected, and then 45 who were not infected, because we try to clean up those who had a large wound and other cause of infections already, maybe from the contamination of remote infection. So we basically have this cohort like this. So now, if you went to the safari, everyone went to go to the safari, you basically try to look at what you call the big five. You want kind of seeing the elephant, you want to see the lion. So metagenomic, there's also some kind of big five that you want to see in the skin. And those big five, they are not equally distributed when
2 minutes.
Patient develop infection and so on. So what we found out is those who have infections, they have the film of actinobacteria, which was really increased. And then with those who didn't develop infection have this one. This it was like it's something will trigger us. And what is this imbalance? I try to looks like predict infection when someone has this. So this also made a bit too much color, I know, but that's our graphical comes like this. So you can see the swinging between those who get infection and those who didn't get infection. So the kind of proteobacteria, they kind of diminish. It's kind of, they kind of protect you. When they diminish, then you have a lot of actinobacteria, and then you kind of have an infection. This is like so we went ahead to do what we call alpha diversity, and then it takes about the richness, diversity of the microabundancy. So all this also shows that infected group, it was more diverse. It's like you have a diverse group of microorganisms in their relationship. Then when you have infection and not correlated with the antibiotics, you're more likely to develop it. So this is another way of measuring it. We call it beta diversity. This is what the computer generated. But because of there are some outlayers, so when we remove the outlayer, this is what we have. It's really too directional in terms of our findings. So this PQI is used to using machine learning to show you how the direction of the bags are distributed in the body. And then the same thing, this, although it was not significant, we see that the 0 point was there, and then we see the 0 point is where we find the first yellow, the blue one, and then you see that those who got infected, it kind of slight higher, and then in the PICO graphic. So this is what we call another one, networking, how bags interacts in the body. So we found that the group who has infection after surgery, so those patients, we found out that there is a lot of correlation, there is a lot of interaction between the community of bags within one samples. So that means, and when we look at those who are not infected, they were not so much. That was really quite interesting for us to report it. And then remember, those swabs were taken before they had infection. It's not we did it after the infection. They got it before in the normal skin, and then they had a normal routine surgery. And within the stamp analysis, this is a way of seeing, and we identify a specific group of bags that protects, and then those who don't protect.
Dr. Havred, the jingle bells are ringing. Kindly conclude.
Okay, thank you. I think there's so much to say about this, about the female and children and so on. So I have to go to the conclusion. So our sample size was very small, and then, but of course it's still large. If I look at people doing skin microbiome in the world, it's kind of 5, but we went in the big number. Still association, what we found, there's an association between the abundance and the composition of the skin of the scalp with the surgical site infection. So that may be potential in the future. We should look around what kind of gel, which kind of preparation we can do to promote the protective microbiome, and then this, the whole hypothesis is when we have what's called dysbiosis, disruption of a kilogram of skin microbiome. Thank you. I think we have so much to say in the paper we'll release, and I'm happy waiting for questions. Thank you.
Dr. Have Lekuya, thank you for that wonderful presentation. I think what we pick up here is that there's a lot of technology, there's a lot of data analysis, which is a bit high-tech, which you have put in this presentation. We have now demystified the world of metagenomics. We have heard about biodata, phylum clusters, and we have had infected and uninfected networks of bacteria, and we have also seen some conclusions like microbiodata dysbiosis is a potential predictor of soft tissue scalp site infections. Thank you very much for that insightful presentation. Ladies and gentlemen, all this which has been presented here will be available at the organizer's desk. Our last presenter today is Dr. Alice Katerega. Dr. Alice Katerega is a third-year resident doing a Master's of Medicine in Neurosurgery at Makerere University Medical School. Her interests are teaching, research, and academia. And she has insights in doing fellowship in skull-based neurosurgery. I know the skull-based as having many foramina. I forget their names now. She loves being a mentor of students and serves on the executive committee of Incision Uganda. For leisure, she loves travel when she can afford to do so. So this morning, we shall hear about surgical errors, experiences from a cohort of residents. Dr. Alice, kindly, the podium is yours.
Thank you so much for that introduction, Mr. Epidoi. I will go right ahead and start my presentation. Good morning and welcome. Thank you for making time to attend the Asou meeting today. Let's see if I can get a hang of this. So our study is on surgical errors and surgery residents' attitudes towards disclosure of surgical errors. I'll make it short, sweet, and swift. Behold, the Leaning Tower of Pisa. I'll take you to Italy for a short while. This was a tower, a freestanding bell tower from the Cathedral of Pisa. And construction started in the 1170s. It took about 200 years to complete this tower. Is it an architectural wonder, or is it an architectural and engineering error? It's actually the latter. The foundation was made on shifting sand, and so it began to lean over a period of time that it was constructed. An architect once said that a doctor may bury his or her errors, but an architect can only advise a client to plant vines. I don't know if vines can hide that lean of 5 degrees. So coming back to our field, are errors our arch nemesis? Are they our Achilles heel? Do they keep us grounded? Looking at the background of errors, first off, the definition of a surgical error. This is an unintentional preventable injury that occurs to a patient during the perioperative period, and it's found that it's not an acceptable risk of the surgery or the surgical procedure and could have been prevented by systems in place or guidelines or protocols. Globally, we know about that 200 million surgeries occur. The US has been open with their data about surgical errors. There's a paper that was published from Johns Hopkins and noted that about 4,000 surgical errors occur annually. These are labeled as they're never supposed to occur in the hospital. What is the data in our context? Locally in sub-Saharan Africa and Uganda, I do not have that answer. But what I'd like to do is throw some light on the surgery residents' attitudes towards disclosure of surgical errors. So the research was conducted as a cross-sectional study between mid-2022 to the beginning of this year, and the site was at Makerere Medical School. We enrolled a number of participants. We actually utilized a list of the surgical residents from the Department of Surgery and sent out questionnaires in the form of hard copy and soft copies that were filled anonymously and self-administered. I need to reiterate that it was self-administered and voluntary, and that the identities of the participants were protected. Informed consent was obtained, and some of the variables we looked at were the type of surgical errors, what was the disclosure status, and what were the barriers to disclosure for the surgical residents. Looking at our results, we found that 42 out of about 64 participants who were reached out to responded, mostly in the fields of surgery, ENT, neurosurgery, and the male to female ratio was 5:1. So about 16% of the residents are female, which is half what we see in other areas. So we still have some work to do there. Otherwise, the age group was what we expected, 31 to 45 years of age. The majority, 90%, were from surgery. Only one had prior training and so identified as a specialist. What were the results that we gleaned? We analyzed our results using Stata 14 and found that the mean practice prior to enrolling into graduate studies was about 5 to 6 years. Out of those who had responded, 90% revealed that they'd ever had a significant surgical error in their practice, but only 40% had been within the past year. Of those who had noted the surgical errors, about 70% had disclosed. However, only 25 or so % had disclosed to the patient themselves. Many had found it more convenient to disclose to their peers, or perhaps they felt more comfortable to disclose to a peer or to a senior. 50% of those who were involved had actually offered a clear apology to the patient. These are some of the examples of the errors that were cited. Wrong site surgery popped up quite a number of times. Inappropriate suture material use. There was one that was highlighted as a misdiagnosis of a coagulopathy due to history taking, perhaps that was wanting. And one patient aspirated intraoperatively, perhaps due to a WHO checklist not being performed. So continuing for the results, it was found that, like we mentioned, 60% took full responsibility. And it's important to validate the patient's emotions. So about 70%, 67 to 70% had validated the patient's concerns and emotions when they expressed responsibility for the errors. A good number of the resident physicians were interested in the future preventing such surgical errors, so about 71%. However, only half of those knew of a formal system within their institution to prevent and address surgical errors in the future. So what were the reasons for non-disclosure? I'm sure we've all had an experience or two, and what we found across the board was fear. Fear was the #1 reason for non-disclosure. There was fear of litigation, about 33%, and then fear of other things, fear of loss of colleagues' respect, fear of loss of licensure, fear of physical or verbal altercations with the patient or their family, etc. The respondents also gave some insight into their past experience with consequences to either non-disclosure or disclosure. For disclosure, there were actually incidences of physical assault from the family or next of kin, verbal altercations, as well as mistrust moving forward from the patients. Some were ostracized by their colleagues. On the side of the non-disclosure, it was mostly psychological impact, what would almost be described as PTSD. Many physicians noted that they had difficulty sleeping, they had loss of confidence, they felt guilt, self-condemnation, etc. However, there are also patient complications due to non-disclosure. 2 minutes. Thank you. So moving to the discussion, what was highlighted from the respondents, they wanted us to look into prevention. Is there a way we can look into education, continuing professional development to help them deal with surgical errors and their prevention? Can we communicate better with our colleagues, with our peers, with the multidisciplinary team? What about with our patients and their next of kin? Is there a way we can put systems and checkpoints in place to reduce surgical errors? Is there amnesty for those who have these incidences? And what about patient advocacy? Can we vouch for our patients, etc.? So this brings me to the end of our presentation. Thank you for your time, and thank you for listening.
Thank you, Dr. Alice, for that wonderful presentation and keeping time. I don't like to commit any error by dissecting your presentation. However, we have seen that this is a potential area which usually attracts medical legal issues in the practice of medicine. We have all encountered errors in surgery. Some of them can be systemic, random errors, limiting errors, or gross errors. But I think, as the saying goes, to err is human. There are some errors which will always come in our practice, But as the saying goes, forewarned, forearmed. I've come to the end of the presentations, but before I proceed, I know most presidents all over the world have jurisdiction over one country. But in the House here, we have a president of 14 member countries. That is none other than Dr. Jane Fualal. You're welcome, Madam President. While you're aware, all has been well, and as the president-elect of the Association of Urologists of Uganda, I wish to bring you warm greetings. Now, we have the three presenters in the room. Kindly step forward for a few questions from the audience. And Dr. Lekuya and Dr. John Baptist, kindly keep online for any questions from the audience. And I think in the interest of time, we shall have, this is my suggestion, maybe 5 or 6 questions. Thank you.
Thank you, presenters. Thank you, Dr. Olivia, and I didn't catch your name, Dr. from Guru. A small scenario. We once consented a patient at the Heart Institute, and everything went well. She was ready for surgery with the kid, and in the morning, when she was being wheeled to theater with her child, she asked, "Where are the whites?" I don't see the whites, because her mentality was that the beginning of the program, we used to have collaborators, and then she was seeing no white person. So implying that the consent was not properly done. And frankly speaking, I think the area you are pursuing is wonderful, because I've noticed, and frankly speaking, our consent document is poor. We have got to admit that, because we consent for the surgery which is going to be done, but there are aspects we don't consent. In other medical environments, you consent even for blood transfusions. There is a complete separate document where a patient actually agrees. Jehovah's Witness, you can consent. You say, we are going to do this surgery, but you don't mention. And then when you reach the part where you are going to transfuse the patient, and the patient tells you, no, I don't take blood, and the patient is already on your table. That consent was not properly done. Then the other thing are medical devices. In our area, we do valve replacements, the other term for cardiac surgery. Replace a valve, a mechanical valve, in a young female reproductive age. She has got to be on anticoagulation therapy the rest of her life. You have interrupted her other wishes of where she could have been a mother. If you don't cover that in your consent and you have a document for it that I'm putting a mechanical valve in you and you have to be on anticoagulation therapy for the rest of your life, she can actually come back and say, I didn't know this part of where you are going to make me fail to be a mother. So I think that the area which you are pursuing is wonderful, and it actually highlights the patient in Guru, tells you that, no, I want to first speak with my parents, however much I'm 45. So I think there is a new document which should be pursued, and this is where us as surgeons can champion this and guide properly. The current document that goes around in private hospitals and in public hospitals, it seems to be insufficient. There are costs like, I see you where you want to do the surgery, I want to recover, but there are other hidden costs where my ICU admission at Nakasero at Kampa Hospital might end up being like for 20 days, but I wanted to be operated. The other part of the costs were not mentioned. Thank you very much.
Thank you very much. This is quite an interesting topic. I wanted to also seek clarification or guidance from from us. I recently had a patient who was a 60-something-year-old, an RVD patient, and he came with a gangrenous leg. I think it was up to the level of the knee and needed a below knee amputation. He was blind and he couldn't see what was going on. So convincing him that you need a below knee amputation was hard. The family that was taking care of him declined. And we were left in that dilemma of trying to explain what was going on and the need he had for the below knee that he had declined. And the family consented, but the patient actually declined the surgery. And we knew he was worsening and getting worse. We got the psychotherapist, but they couldn't break through to him. And the guidance was just let him go home. And we all knew what was going to happen. So what, I think I would give this to Dr. Olivia. What would be, how would you deal with such a situation? Thank you. Because I was now the senior on the team, and my residents were looking up to me to provide a solution. Yeah, we spent about a week actually dealing with this. So, yes, thank you.
Thank you so much, and I would like to thank all the presenters. My question or discussion would be for the aspiring professor of Gulu. Thank you so much for that very important presentation you gave us. I also remember in the history of your patient, you said that the patient was in a shock. And we know that patients who are shocked are mentally unstable. First of all, I wanted to know whether that patient had an attendant, maybe who could be consulted, or given the status that this patient was mentally, I would say, a challenge, because when you are in shock, you don't think rightfully. In our practice, maybe someone also will help you out. Is it allowed that maybe not the surgeon, maybe the colleague can make a consent for this patient, whom I assume that was mentally challenged? Thank you.
Thank you all, the presenters. I think it has been a wonderful session, and whoever chose the topics, I think, did a very good job. I need all the copies of the papers, including yours, Dr. Alice. You were speaking very fast. I couldn't make the notes, but I think it was a very good presentation. Now, my comment, I have many. Olivia, I think you're going to have to do I don't know how many PhDs you're going to do on this topic, because there's so much need. Like in casualty, you showed those those pictures of what is in casualty. At any one time in casualty, we have like 4 or 5 unidentified patients. How do we get that consent? Many of them need to go for procedures. I understand we should even be getting consent for, is it CT scans or something like that? Do we or we don't? How do we get the consent? When we get the imaging and the neurosurgeons now have to operate, who gives that consent? And another thing which I want to know is how often do we get the consent? Because I think you have alluded to it, that we should be getting consent practically every time the patient is going to the theater or for any procedure. So how often? And I think since you're in Mulago, or maybe you could help the ministry all over, I think we have to look at the consent forms. There's a lot lacking. There's really a lot lacking. So I think we need to redesign so that it's not just at the back of that face sheet or that whatever it is, but then we have room for everything. Because I think now it's only consent for admission, consent for operation once, and then also where they sign discharge against medical advice. So I think we need to look at that page. Then Dr. Eric, your case is not unique. We have so many cases in casualty and adults who are not even in shock. And then another time, another case is maybe you and Olive can give a guidance on patients who come in, they have severe head injury, they're unconscious, they've been worked up, they're supposed to go to theater or for surgery, and then the relatives or the attendants start saying, no, we are waiting for our mother who is somewhere far before they can actually wheel the patient to theater. But everything is set. Why? So what do we do there ethically? Thank you.
Yeah. Good afternoon. I'm glad to be here. I don't think there are very many people who know that I'm a surgeon, but I am. Now, I think the case from Guru takes the award. This patient presents a great ethical dilemma. The patient is free to grant and withdraw the consent. But the patient should not have given the consent in the first place because he was in septic shock. And therefore, as the sister said, could not be blamed for his decisions. He is not accountable for his decisions. And I think for the entire consent process, we may need to graduate to a situation where we have a judge on duty, as in other countries, whom we can call to consent for these people, because I think this person was not served as he needed to be. I have had a similar situation. Fortunately for me, the patient was not in shock. He had a wound that wouldn't heal without skin graft. And I explained all I could, and he said, his senga, he was an adult, but his senga had refused. Why? Because it had never been done in their clan, that you repair a wound with a tissue from elsewhere. I stayed the course. Fortunately, it wasn't an emergency. I explained and explained, and we did the skin graft, and in less than a week, he was cured, and he's now an advocate for what we do. I remember somebody talking to me about which surgeons will be sued. This is towards medical errors. Who will be sued? The Ainoito surgeon will certainly be sued. The surgeon who takes time to explain and also approaches the situation with a healthy level of doubt, because he's not the creator, will also not be sued. But people who said, no, you don't need to ask the questions, leave it to me, I know what I'm doing, that surgeon will be sued. Now, medical errors, I think we should borrow a page from the airline industry. In the airline industry, they disclose everything, good and bad. And they have been able to reduce accidents to a minimum. And airline travel is, despite the devastation of an accident, is among the safest we can have. It is actually safer than crossing a road at Wandegea. So what we should aim to do is to provide adequate information. You cannot present too much information. You must present adequate information. And also consent every step. And the form we are showed is definitely inadequate. It is actually kwekwasai. It is not a consent form. I was tickled by the dissection, the need to dissect if you are going to be a surgeon. And I remember saying to myself, well, surgery is not a virtual reality. It is actually an actual reality. So I would rather that my surgeon actually did practice on something that wouldn't die before practicing on me. Thank you.
Thank you very much. We apologize for the people who had their phalanges in the air, but they were not allowed to ask questions. At this juncture, we have questions from the panelists which have been interesting. And when you notice that these questions are through decades of experience and being on the ground, panelists, it's your time to start. I think we shall start with the people on the who are actually seen. Then we shall go to the virtual presenters, the two. Anybody who is ready can start. Thank you.
Thank you all for the questions and the comments. Definitely, first of all, in response to the comment Dr. Mhozi, I think, made, it is true that we do have to consent a lot more than what we're actually consenting. Evidently, our consent forms are very inadequate. But also, when I interviewed, among the people I interviewed during my study, they did acknowledge those issues about consenting for devices, you're using implants and all sorts of things. And that was also brought up, which was interesting, that we are aware of it. We know what challenges come about, but we go ahead and use what we have. We don't think of trying to change that and making it appropriate for our patients. Then the issue that Dr. Christine talked about, the ethical dilemma, which is coming out in some of the other questions, about the challenge between the patient's autonomy and their right, and then what you think is good for them, and then their relatives. And usually that is such a tug of war in the ethical world. Who is the utmost? Who trumps everything? And usually it is taken as the patient's autonomy, as long as the patient has the capacity. So if the patient is incapacitated, then that becomes a bit different. And now the issue is determining which patient is actually, sometimes the incapacitated patient is very obvious, they're unconscious. Then you have the patient he talked about, who is not mentally challenged. Is actually, if you assessed him, he's probably alert and normal and has full awareness of his faculties. So he's made a decision knowingly. But you might find in such a situation, you may feel that it's more convenient to call him incapacitated, that he wasn't really in the capacity. So that becomes a challenge. And one of the things that he mentioned and is coming out is the issue of having an institutional ethical committee. These are people who will be able to look at those cases and be able to make an unbiased and guide on the ethical aspects of this. Because at that time, it's sometimes very difficult to balance all that at the same time. For you, you're looking at life. The patient is looking at many other things. He's an adult, but he's looking at his relatives. And that was also highlighted by the people I interviewed, where many of the patients were fully able to consent, but they always asked somebody else. They always wanted somebody else around. And maybe for that patient, maybe it's something that we have to consider, which is a bit different from, I'll call it the Western side. We have such a familial community decision-making process. So you'll find that even if a person is capable of deciding for themselves, they tend to they even want a clan leader. I've had there were people who were asking for clan leaders to help them make a decision. they're asking. But then when you add in things like finances, then it even becomes more complicated. It depends on who is going to pay the bill. So they'll talk to their employer, they'll first call this. So those complexities and intricacies are coming in. And then the issue of our consent form is definitely wanting. And we do appreciate that not only is it not capturing what we are going to do, it doesn't even capture what the patient is actually consenting for. And you find that in some cases, for example, we have the multiply injured patients. So they consent to neurosurgery. And then the next team comes in and says, oh, they need also this. What was happening? There was no consent for that. It was just going on. They were riding on the consent. They were riding. Our forms have some blanket consent for medical treatment. Very vague. So it's kind of, so we tend to ride onto that, saying that, okay, if they're going to put a cannula, if they're going to give me blood, I've consented to everything, which is not right. And then, as far as the procedure is concerned, it will consent probably to one procedure and will not tell you about risks, benefits, and any of those things. So it is very wanting, and this study actually brought that out. And so many other studies have been done. And I think it's long overdue to have that consent form redone. And that brings me to the issue of guidelines about consent. Someone was asking about what helps people make the consent forms. We have national guidelines on what a consent form should have and that is standard. We don't. We have something from the Medical Council that tells you that that patients have to consent to research. It's just a statement, but you don't have a policy that helps to guide on what should appear in every consent form. So maybe that's something that we need to bring to the council and other bodies that are involved in policy making. Then the other issue of what we do for incapacitated or unknowns, we did ask, I didn't present that information, but we did ask, what do people do? What do the emergency staff do in such cases? And it is really, there's no written law, there's no guiding rule that what happens for these patients, but what is done is they'll look for the most senior person on duty who then comes and makes that decision for those patients, and then that is what is done. But the point was, there is no clear guideline on that. And that is a challenge. And when it comes to litigation, then we get into a lot of pitfalls after that. So all these are gaps that we actually identified and need to be addressed, especially in the emergency setting.
Thank you very much for that eloquent answer. Before the next panelist continues, Dr. Ms. Olivia, since you're in the middle, you become the principal focus of most questions. There was an issue Professor Bogard brought about having a clinical judge. I would imagine this clinical judge would be able to let alone the senior person in the place. We are now taking it to another level, where the Ministry of Justice and Constitutional Affairs will have an attachment in every casualty. So that is able to give a ruling that proceed. Then the other issue I'm seeing, if we make many consents, this is just my personal view, about other smaller things below the bigger thing. Like now as a urologist, if you are going to do a nephrectomy, should you consent for opening the abdomen, consent for getting the renal vessels, consent for putting a drain, etc.? Thank you.
First of all, the question of the big judge, it is not really fair to have the decision being made by one person. It is prone to a lot of challenges, it's prone to biases and many factors. And that, instead of that judge should actually be an institutional ethical committee on which you can have different people, including people from the legal fraternity, who are part of that committee and able to handle those ethical dilemmas, because they are usually complex and you might not be able to pick different aspects as an individual. But if you're a team that is well-versed with all these ethical issues, then it is better. Then about many consents, a lot of times what is the challenge is, what are you going to ask consent for? What is the actual, what are you disclosing? What is the patient consenting for? And the first thing is, when you talk about the procedure, you say nephrectomy, for example. I'm using your example. You have consent to nephrectomy, and the assumption is that you have told the patient what nephrectomy involves, and it involves all those things. So you take it as one thing. But what is also coming out is that on that form, ideally, when you talk about the risks and the benefits, because usually that's where the challenge is, there are certain risks that you should communicate to the patient. And it should be known that you actually communicated those risks. But our forms don't have that information. And our emergency staff do notice that at times they get into a situation where the patient gets a problem, and then afterwards they say, I wasn't told that this was going to happen. And yet the doctor communicated that. So the aspect of what the doctor communicates is being considered as one of the things that should appear in the consent form. For example, with nephrectomy, I have said the risk of bleeding, clot, venous thrombosis, anything, or whatever you've actually said that is key is actually documented that you said it, and the patient signs against it. That is one of the things that came out from the interviews of the emergency staff and what sometimes happens in the emergency settings.
Thank you very much. Next panelist.
Okay, thank you so much. Benefits of sitting near Prof. Most of the questions have been tackled. So, yeah, my work, of course, has been simplified. I'll pick it from there by telling us that informed consent is an ongoing process. It's not just a signed paper. That's why we had to have a second thought of the patient of whether the surgery could actually be conducted. So it's not just that you sign and leave it at that point. We acknowledge the challenges that this patient was actually in shock, but like I made mention, the patient was fully optimized for the procedure. The shock was reversed, the patient was stabilized. But this gives us an understanding of how patients will always present at emergency or during emergency situations. They are anxious. They are dying. They will tell you, doctor, at all, I'm dying. And I mean, that's how they feel. They feel like whatever you're doing might not actually help. And now it's upon you to assess and see, like Prof said, if you think this is a patient who is unfit to consent for themselves, then a surrogate decision maker can come in. But importantly, we need to highlight the importance of ethical committees. I think in this case, this played a very big role. We invited our members of the ethical committee, the senior consultant surgeon, had to intervene and then gave the final ruling of how the case should be handled. And it was none other than taking the patient to HDU to continue resuscitation as we wait for possible arrival of his parents. There's paramount need for innovation in informed consent process. I invite the team from biomedical engineering. I think this is another area we can venture in. There is a lot to do with audiovisual assistance. I know it can help when we think about documentation. I don't know, is describing all the steps on a single paper we are going to print, and we shall use all the cartons of the printers.
in the hospital just for informed consent. So I think if we can venture into innovation like use of audiovisual assistance, it would be a good innovation to boost the process of informed consent. Thank you.
Yeah, thank you very much for that insight. What we are learning today is the patients with special needs need a lot of innovation. And I think that's an area we need to delve into. Dr. Alice, you're on.
Thank you. I hope you can hear me. Thank you for the feedback and the comments. I noticed I got the least number of questions. I just want to reiterate that this study that we did was amongst the earlier years of the graduate students, so first and second year when they're still in basic sciences or coming out of basic sciences. So it reflects their experience prior to their current clinical experience. Why am I saying this? It takes vulnerability to talk about surgical errors and your experience with surgical errors. There's a lot at stake. And if you throw in the wrench of being in training, there's a lot more at stake to lose. That being said, Ms. Malvijano, sorry about being too fast. I'll try to slow down for future presentations. But thank you for the feedback. And then moving on to what Professor Luboga had highlighted. It's true the airline industry has had systems in place that they've developed over time from their prior experiences. They have a lot of checklists and a lot of procedures or protocols where it's not only one person going through a checklist, but it's 2 or 3. So it will be the pilot, co-pilot, or the pilot, co-pilot, and the control tower. And that has reflected on their improved safety over the years. How we can segue this into surgical practice is not something that we can handle in the scope of this discussion now, but we can throw light on that moving forward. Thank you once again.
Thank you, Dr. Alice. We now have Dr. John Baptist. Are you still on?
Yes, I can hear you. I'm on.
You had concerns from especially Professor Luboga. Could you go ahead?
Yes, thank you so much. I've enjoyed the discussion, especially with the consent issue. I have my experiences, but going straight to the point of discussion, yes, Professor Luboga raised a very concern, saying that he would rather have his students have the dissections rather than simulations. And I think I agree with him. The topic wasn't comparing dissections to simulations, but rather the different approaches and if these dissections are still relevant. Because if we have students learning neurosurgery per se, do they have to dissect the pelvis? If we have students doing ENT, do they have to dissect the lesser sac? So that's one of the perspectives we're looking at this from. And also the level of dissection and the level of cadavers that the students are exposed to. If you are training the meticulous dissection that a surgeon needs to dissect around maybe an aneurysm, are they going to get it from a formalin cadaver that's been there for a year versus if it's a fresh cadaver that's maybe in the morgue? So these are the different angles of discussion, because one of the goals that we aim to teach students from these dissections is not only do they master the anatomy, but also the art of approaching certain spaces and the angles of dissection and how meticulous you have to be at this dissection. So those are the nitty-gritties that the dissections of cadavers may not give a trainee, besides the landmark knowledge of where the certain structure passes. So it is something that we still need to talk about and ponder about and see another approach. So yeah, that's my response to that question. It's still work that has to be in progress. Thank you.
Thank you very much, Dr. John Baptist. Dr. Lekuya, are you still online?
Yeah. Thank you. I think much has been said already.
Thank you very much.
I can just make a comment on maybe on surgical dissection. I think it's still relevant, and I think, let me say again, it may be mandatory for some specialties, some surgical specialties like neurosurgery, to go through not only dissection, but a routine dissection, like a continuous dissection, because we keep on learning stuff and we keep on learning new technique. Giving my experience, like I spent like close to three months, twice, like 6 months in one of the highest, biggest center in the US, New York. So we've been given task to do approaches in scalp base, and initially I thought it was like something simple, but I came to them to the table. I see very senior professors that they come and do practice something. I want to do this because I have a patient to do tomorrow, and I have to do this approach again. Try to see the angle, try to see. So I would be ticked to see, like, it's not like you learn anatomy for once and then you stop. And myself, the assignment was like they give you one and a single organ. The funny thing was they give me in a orbit, just the orbit to dissect. The instructor say you have 1 week for the orbit. I say 1 week, I will do it in maybe 3 days. And then I realized I did it faster. Then he said, no, you did the wrong thing. And then he showed me all the mistakes that made. And then it was simple. Then I went to the next. Then I start discovering things that are never actually bad. Like you think you make an incision, you go through, and there is like the ear is very complex. The things that you think is not relevant, but people who do dissection, they can tell, they can prevent some injuries and so on. So this just board is saying it's not about learning anatomy for passing the courses and so on, but you have to keep on practicing. Whatever time is going to take you, go back to the cadaver. The question is the quality of the cadaver that you are working on. I think that matters more than having it dry, which doesn't look like. You need to have a cadaver which is close to a fresh dead person, and then it may make sense. Yeah, that's my comment. Thank you.
Thank you very much, Dr. Lekuya, for that insight. As a urologist, up country where there's no neurosurgeon, I sometimes find myself straying away from the prostate, the urethra, up to the brain. And I've discovered that the blood supply of the scalp is actually a necessary evil in surgical site infections. I don't need any comment on that. As I conclude, thank you for being a wonderful panelist, a wonderful audience, for giving us this time. Thank you very much. Have a nice morning.
Thank you, Dr. Epodo. That was quite a difficult topic to moderate, because even now I can sense drums of which just want to start beating to discuss this particular topic. A photo for the panelists. So the next agenda on the program is that we are going to go and have break tea. It should be ready in the exhibition tent, and we should be back in the next 20 minutes. Thank you. And probably before we go, allow me to recognize a few people who have joined us. Mr. President of the Association of Surgeons of Uganda, you are welcome. We have also received Dr. Runumi Francis, who is a former commissioner in the Ministry of Health. Mr. Rumuni, you are most welcome. Let's go for the breakfast. Our time is running. Those ones who are going down, please, let's run down for the breakfast.
Today is a good day for the Association of Surgeons of Uganda. It's a good day for the Ministry of Health, and it's a good day for our country. But the whole idea is for us to showcase what we do in our theaters, what we do in our hospitals, in our intensive care units in Uganda, and we put it to the public so they can see for themselves. Uganda can now proudly boast of performing transplant surgery, separation of conjoined twins, complex open heart procedures, laparoscopic abdominal surgeries.
I would really want to juxtapose this same tent, the way it is, to the grounds of Parliament sometime this year or next financial year, so that our fellow colleagues are able to walk through and see what Ugandan doctors are able to do and what they are doing currently.
The small beginnings that we are seeing, the advancements that have started, the opportunities that have opened will continue to grow. We shall nurture those beginnings with you. Government must find money to train specialists if we want to see these services being performed.
We had our surgeons populate the peripheral hospitals, especially the senior ones. That would be more cost effective than having 90% of them in Mulago.
We must have good teachers, dedicated, and mentors. As the seniors go away and we see our exit door, we become mentors and supervisors to the young ones.
We need to go beyond the perspective of only focusing on clinical care and open up to other components. It will enable, reorient the surgeons in terms of the way they see things, the way they look at health in a more broader perspective.
Let the people know what you are doing. Let's make documentaries.
When will those people in Kisenyi know that you can do those surgeries? Even amongst ourselves here in the various hospitals, people don't know what you do. Because most of the specialties are concentrated in Kampala. The regions don't know. I know it is expensive, but we are here to support you, to spread the good news.
This landscape exhibition is one of the ways of raising public awareness about the availability of surgical services in the country. It will help to reduce forex loss of dollars to other countries. Government will continue to provide a conducive environment for training and retaining specialists.
Together with the scientific committee, we are pleased to present this year's conference theme, Advancing Access to Safe, Affordable and Timely Surgical Care. This theme underscores our commitment to promoting global surgery in Uganda and fostering collaborations with all international surgical initiatives.
Now, if we limit ourselves to repeating what's been handed down to us, no matter how meticulously we do it, no matter how many patients we treat with these established methods, we do ourselves and our patients a disservice. So let's not settle for the technician role, grand as it might be. Let us also become the teacher, the educator, the innovator, the scientist, the researcher, the patient advocate. All these are our roles as surgeons.
The practice should change, but most important also the policies. Does our curriculum in surgery actually ask the resident to understand statistics? We might still be researching on things that are for the 20th century.
But one other thing that stands out very, very clearly why we have a gap in advocacy is we don't put price tags to our things. Now, the people who sit in those boardrooms and make decisions, there's something they look at before they make a decision. The same thing you do when you go to a shop and you look at a nice shirt or a nice top and you want to buy it. What do you do last before you make a decision? Price tag. So we make these arguments, but we're not putting price tag. The guy in the boardroom is going to ask, how much does it cost to have an anesthesiologist? And if no one can answer that, that might.
All the children who are under maybe 15 years constitute more than 50% of the population. And we can't claim that all these children could come to Mulago for treatment. So we realize that unless we spread out to all regional referral hospitals, probably that's when we can try to address some of these conditions.
I don't think we have a surgical problem. We have a leadership problem. So we need to think about the stories and how we tell the stories to our society.
We need trauma surgeons. Please do some training in trauma. Trauma is taking its toll on Ugandans.
Get a lot of advice from a lot of different people, a lot of different mentors. Oftentimes you will have a mentor for your clinical work, sometimes for research.
going to dedicate money to do those things, you need the support of everyone so that we see the necessity and put resources where it matters. We are trying to raise awareness in the public. We are trying to raise awareness in the policymakers. We are trying to raise awareness to the people who appropriate money to see that actually there is a cost benefit by investing in certain things, because then we'll stop going abroad in some of these procedures, yet can be done here. And all we need is just some of the simple equipment. All we need is appropriately fund and smart funding to put that money where it can give us more dividends. If we are going to dedicate money to do those things, you need the support of everyone so that we see the necessity and put resources where it matters. We are trying to raise awareness in the public. We are trying to
Ladies and gentlemen, welcome back to the room. Kindly take your seats. Our next session, we are going to be talking about so that we start with this session. Thank you.
Welcome back from the break. So we are doing our 11th session. And I have the pleasure of inviting Professor Bellman to give us a talk on quality improvement in the preoperative environment and combat casualty care. Thank you for coming all the way from Minnesota. How many hours are those? 24 hours, all the way from Minnesota. We really can't take that for granted. And we appreciate the relationship we've developed over the years. Not just the Department of Surgery, but the Uganda. And the amazing work that you guys have done with I think that's a story for another day. Those lymph nodes and what's happening to them. It's the old science of lymph nodes and immunology. Very exciting stuff. Maybe we should invite you again next time when you talk about that. So thank you again. And Minnesota and Bellman and his group were very generous to have our residents go to Minnesota, 3 of them. And they spent there a whole 6 weeks, and they're very excited about that exposure. And we shall get many more to come. So please come and discuss with us this topic.
Thank you very much. Dr. Galukande, thank you for that generous introduction, and it was our pleasure to have your residents with us, and as you have said, we are hopeful of many more in the future. I'm very proud of the work that Dr. Galukande and I have done to build that relationship back and forth between Minnesota and our friends in Uganda. Today I'll be talking to you about combat casualty care with a segue at the end into quality improvement, with the goal to talk about what we did in our hospital very briefly to set up the speakers who will follow me in this session. I want to highlight the fact that Dr. Duruk, Dr. Guma, Dr. Ibingira Treasure, Dr. Namaguga Martha both did a wonderful job of setting me up for this talk today in talking about your work in trauma in Uganda. And so I look forward to speaking a little bit about some of the lessons that we've learned from fighting 20 years of war in the Middle East with the United States. So what I'd like to cover briefly is a brief history of combat casualty care from my perspective, talk about the last war that we've just finished and what we are thinking about in the next war, talk about the global burden of trauma, how it applies both in the United States and in Uganda, and then, as I mentioned, a segue into hospital quality improvement. As a former colonel in the Army, I need to say that nothing that I say today should be misconstrued as official policy of the Department of Defense, the Department of the Army, or any other official organization. Hippocrates said 2,000 plus years ago, he who wishes to be a surgeon should go to war. Somebody from the state of Minnesota, William Mayo, who was a brigadier general in World War I, said medicine is the only victor in war. As somebody who was rounding in the ICU, looked up on the TV screen and watched a plane fly into the World Trade Center, and then knew my life had changed, and somebody who served in my country's military for 20 years, taking care of injuries from that conflict, I strongly agree with what William Mayo said. We spent nearly $8 trillion on wars in 20 years in the United States. And I think the only thing we've learned from it is a lot of things related to how to better care for trauma patients. Ambroise Paré, as was mentioned yesterday, a French barber surgeon who lived from about 1510 to 1590, was a pioneer of battlefield medicine. You already heard the story of how he learned to use suture ligation instead of hot irons and boiling oil to obtain hemostasis. His famous quote is, "I bandaged him and God healed him." I continue to be amazed at the work we do as surgeons. All we do is set up the body to heal. The body does all the work. God does all the work. And it's a privilege to be able to continue to do that kind of thing with my patients. The U.S. Civil War was the bloodiest war in our history in the United States, with nearly 1 million deaths, most of these injuries from musketry. There were major advances made in the system of care, including the U.S. Sanitary Commission, which only came into effect in the last year of the war, and a 3-tiered evacuation system that we continue to use to this day, and most military trauma systems continue to use to this day. There was no understanding of germ theory, no understanding of how to really prevent infection. The most common operation at the time was amputation. Blood transfusion was a huge advance in World War II and the Korean War. This is a quote from Lieutenant General Leonard Heaton, who is the Army Surgeon General. If any single medical program can be credited with the savings of countless lives in World War II and Korean War, it was a prompt and aggressive and liberal use of whole blood. Very interesting, we in the United States moved away from whole blood for nearly 50 years. One of the things we figured out in the last conflict was that whole blood, especially used in a fresh setting, has significant benefits to patients. And so, especially for severe trauma, especially when we can get it, we're using a lot more whole blood. Somebody that's not talked about very much is this guy, Basil Pruitt. Basil run the U.S. Army Institute of Surgical Research, which was my last posting as an Army reservist for nearly 20 years. This institute was established in 1947 to help the U.S. Army figure out how to deal with casualties due to nuclear thermal injuries. Basil drove major advances in burn and combat casualty care over his 20 years as commander of the ISR. And then it's now tradition is understanding how to drive improvements in combat casualty care through focused research. And you can see there a list of some of the things that came out of the ISR that you and I use every day as we care for our patients. As I mentioned, war is expensive. CENTCOM spent $2.3 trillion over the 20 years of this conflict. The U.S. spent $8 trillion, a number that I can't even get around in my head. You think about, I have the privilege of coming to Uganda, working in a small hospital, serving 60 patients over a couple of week period, fixing hernias, and I can buy $1,000 worth of medical supplies in the United States that takes care of those 60 patients. $8 trillion? Really? Isn't that amazing, folks? We lost 7,000 U.S. service members killed. I must say that's an amazing number because of how low it is. More people die in Texas of road accidents every year than died in the 20 years of this conflict. But nearly 1 million people died in this conflict if you count everybody who is involved in this war. What did we learn? The major thing in my mind is rapid hemorrhage control, which included tourniquets, how to train people to take care of trauma injuries, damage control, resuscitation with appropriate resuscitation, pharmacologic adjuncts, the tools for caring for these patients, training of people, not just surgeons, but the medics in the field, the nurses in the field, the transport people, and so on. And then importantly, the systems of care to support the care of these patients who are the most severely injured patients I've cared for in a 35-year history, over 3 continents, in the back of helicopters, in the back of aircraft, and so on. And this led to this concept of one hospital in 3 continents where patients were receiving the care they needed at the time they needed it, but were not receiving unnecessary care when they didn't need that unnecessary care. Early on in my military career, I made the mistake multiple times of trying to do too much for patients in the field. That patient paid the price for my mistake when they developed wound infections or their vascular repair clotted off, or they had other complications that could have been prevented by me doing something that was temporizing in the field, getting them back to the right setting further back. And so we learned to do what they needed to keep them alive day 1. We did what they needed to be evacuated from the theater day 3 or 4. They got what they needed at launch stool at day 5 or 6, and then got their rehab care and definitive care back in the United States day 7, day 8, and so on. And it was, by the end of 20 years, it was, in my mind, the only thing we were doing well as a military was taking care of our combat casualties. And please don't quote me to Uncle Sam for saying that. The next war is a little frightening to be thinking about. This is likely for the United States to be a near-peer conflict where we won't have air superiority, where we will be literally dispersed across large areas of the globe in that conflict. My hope is that me and my colleagues who are maybe as gray-haired as me will not have to live through that conflict. That doesn't mean we shouldn't be thinking about it. And what are the implications for combat casualty care in that conflict? It may take us much more than that golden hour to get patients back to a definitive care. You will have not Dr. Beelman taking care of you in the field, but you'll have some young man or woman who has 12 weeks of on-the-job training who is trying to stop the blood loss and trying to stabilize these patients. And then these patients will receive prolonged casualty care in the field, including interventions to stabilize shock, give them pain control, provide airway management, and then do standard nursing care. These issues suggest significant challenges as we think about how to do this moving forward, but also have implications for us both in Minnesota and I think for you in Uganda. In Minnesota, I live in a state where the Twin Cities, an area of 3 million people, live in about 100 square kilometers. But you go outside of the Twin Cities and you can be 800 kilometers from definitive medical care. And many of our injuries take place in these rural settings. In Minnesota, if you are injured in a rural setting, 72% of those injuries have death at the scene compared to only 41% in an urban environment. And delay in care matters. This is one bit of information from one of our rural level 1 trauma centers where when they looked at about 400 femur fracture patients Increased time to fracture fixation was associated with increased length of stay, higher complication rate, and decreased discharge of this patients to home. And this is important for you in Uganda as well. I've seen these statistics quoted in the last day or so, so I won't cover this. I want to point out that Dr. Galakande is the senior author on this paper in the middle, where over 10% of the population in Uganda suffers from a significant unmet surgical need. The major issues for your patients and some of my patients include access first and then safety and quality. And what I keep telling my quality people is you have to be able to get to the doctor to be able to measure safety and quality, to be able to work on safety and quality. And so it's that access to care that's critically important for our trauma patients and other trauma patients. So I won't walk through the conclusion slide. Again, I'm happy to share these slides with you. Nothing's hidden here. And I want to move to quality and safety. And what I want to talk through very briefly is our quality and safety journey from the University of Minnesota Hospital. I am incredibly proud of being a Golden Gopher. That's our mascot at the University of Minnesota. I moved there from Kansas 35 years ago. I've spent my entire career as an academic surgeon at the University of Minnesota. But when I was asked to lead our organization, the hospital, we sucked. Okay, we were bad. When you looked at our quality numbers, we were number 11 for the Twin Cities rankings by U.S. News and World Report in 2019 when I was asked to step into this role. Number 11 in the state, number 8 for the metro. I was appalled by these numbers. And as soon as you start talking about quality, you know what surgeons do? You know what doctors do? They say, well, my patients are different from everybody else, and you're not really measuring my patients. That's bullshit. Excuse my French, please. That's bullshit, okay? Because everybody's playing by the same rules. Everybody's being judged the same way. We went into this saying we want to be a top 10 academic medical center, and what we told our doctors, our nurses, our leaders, our administrators is quality and safety for our patients has to be the first priority, because where are you going to take your spouse? Where are you going to take your kid? And by darned, it better be the University of Minnesota if you're in the Twin Cities. And the worst thing was my former chairman, when he had his appendicitis, went to our competition in town. He did not trust us enough to come to the University of Minnesota to get his appendix taken out. What does that tell you? So we spent 3 years talking to people about how important quality and safety were for our hospital, how this has to be the first thing out of your mouth. It's not rankings by grants. It's not a great paper. It's faculty development, but it's faculty development to help them understand that when you walk in the door, you are taking care of patients. And for quality and safety, we developed clear lines of accountability and responsibility. This is where we were in 2019 when I took over. They have 4-star rankings, U.S. News and World Report, and Vizient. We were 2 stars out of 4 stars. There were 8 hospitals in the Twin Cities that were better than us. Okay, we were the biggest hospital, the number 1 academic hospital in the cities, but that's where we ranked. And this is where we ranked nationwide. You can see us in the bottom quarter of all hospitals in the nation. So I went to the boards, the boardrooms for our practice plan, the boardrooms for the hospital, the academic boards, and what I said over and over for about a year was, we suck. We are bad. We are performing poorly. Is this where you would take your parents? Is this where you would take your son? We have to focus on doing this well. And what you really need if you're going to do this is a physician and nurse and administrator champion to help lead that process. And so we developed a standard structure for doing this. And I love this cartoon. Who wants change? Everybody raises their hand, but who wants to change? Nobody wants to change, right? But we spent a year or so talking to our people about that need for change. For our department chairs, I said there's 3 missions of academic medicine. We are frequently judged on academic success, that's grants and papers. There are huge pressures of budget to produce the number of cases in our hands, RVUs, and so on. And the values of the department chair are reflected by what the faculty in that department do. But I said, if you want to be a great department of surgery or anesthesia or urology, you're going to be a great department because you take great care of patients in your department. That great care will drive great papers, will drive grants based on the production of patients that you take care of. And so you've got to know that quality and safety for your patients comes first. And so we had a data-driven quality organization. We met with every department chair every quarter. I pulled up all their data. I said, you guys suck, okay? I own it, but so do you. And we worked on their data. We worked on transparent reporting structures, and we really worked to drive quality across our organization. And this from a year ago shows that we dropped our mortality, which is one reflection of quality. And in this graph, mortality is measured by an observed to expected ratio, or an O to E ratio. And you can see when we started this journey, and it doesn't go back far enough, in 2019, our O to E ratio was 1.6, meaning that our patients had 60% higher risk of dying with a similar situation as any other patient measured across all of these academic medical centers. And every quarter we reported this data to our department chairs. Every quarter we reported this to our clinical leaders, our nurse managers, and so on. And everybody focused on driving system mortality, observed to expected ratio down. And you can see there in 2022, second quarter, we were down at 0.6, meaning our patients had a 40% better chance of surviving than people across the country who had similar types of patients in similar types of hospitals. We're now in the top 10 in the country in terms of quality and safety, and I'm proud to have been a small part of helping drive that change. So in conclusion, Dr. Galakande and others, thank you for the opportunity to come and speak to you folks yesterday and today. I've been coming to Uganda for 20 years. I have been proud to be a part-time Ugandan here and look forward to our ongoing relationships. Thank you.
Thank you very much. That is priceless information share. And it's really challenging. It's really challenging. You're not allowed to ask questions. So I also won't ask questions. I read a book by Atul Gawande, I'm sure many of you have. And somewhere it talks about counting. I'll paraphrase, if you don't count, you're doomed. And the data, the information I shared here, quality improvement, how can you improve if you're not counting? You have to count. I think in all fairness, we do some counting, but then we hide what we count. Professor Shamanya talked about, was it fair, findable, accessible, interoperable, and reusable? I think we need to count. We need to count. I think even in our personal lives, you need to count. If you count, you discover how much money you spend on newspapers, and then you decide whether you need to spend that or not. I think that's one of the big messages I take from this. If we are to go anywhere, we need to count. Thank you very much again. So you're in trouble. When you do such a good job, we'll keep inviting you. Our next speaker is Barbara Nabaiga. Is that correct? Barbara Nabaiga from, this should be from Lubaga Hospital. And the talk is about optimizing operation room safety. So our sub-theme is multidisciplinary pre-operative care. Barbara, you're welcome. You have 10 minutes. Please go ahead.
Thank you, Doctor. Good afternoon, everyone. I'm Nalong Barbara Nabaiga, nurse in charge transplant theatre, Lubaga Hospital, presenting to you a paper that is looking at optimizing operating room safety and efficiency through tracking a customized dashboard. This is our experience as transplant theatre. As I begin, I would like to start with a quote from one of the famous management author, Peter Drucker, who said that you cannot improve what you do not measure. And I greatly agree with him. So a lot of investment has been put globally to improve safe access to surgical care. In spite of all this, there is still unmet need to improve this access. And over 5 billion people have lacked access to this care. And this has been many factors that have contributed to this. For example, low quality assurance systems, ineffective utilization of operating rooms, and also poor monitoring of safety and efficiency matrices. So in 2008, the World Health Organization introduced what we call a surgical safety checklist. Its implementation has shown improvement, and we realize that it has been a challenge in low and middle income country for its implementation. Among other factors that have limited its compliance is poor quality assurance systems. And our hypothesis as transplant theatre is measurement and monitoring of safety and efficiency matrices can improve operating room safety and efficiency. So, in September 2003 and February 2024, all cases operated in transplant theatre, their data was retrospectively retrieved and analyzed, and a customized dashboard was developed to monitor safety and efficiency matrices. Quarterly audits and performance review meetings were performed, and there is our dashboard with 10 matrices. With 10 matrices looking at the safety and efficiency, and we were measuring 2 quarters because our existence has been short from September 2023. We were looking at the first quarter and the second quarter as it has the 10 matrices where the surgical safety checklist referred to the surgical safety checklist compliance, referred to the number of cases done, and a surgical safety checklist was administered. Then surgical safety completeness, this is cases administer the checklist and its parameters have been completed. Mortality referred to all deaths that occurred operatively. Near misses referred to the cases done with significant adverse events operatively or during recovery. Caseload, operating room caseload referred to the monthly average percentage of cases compared to the target, which is 80 in our case. Operating room utilization refer to the percentage, sorry, the other one refer to the number, and this one refer to the percentage of cases done in comparison to its our target. Case booking rates refer to the percentage of cases done in the theater and booked according to the standards. And in our case, all bookings before 4 p.m., which are elective, excluding the emergencies. Then same-day cancellation referred to the percentage of cases cancelled or postponed on the day of surgery. And transfer time referred to the time from calling the ward to bring the case, to bring the patient into the theater, to the time when the patient is brought into the theater, and this is measured in minutes. So we realized that there was some great improvement when it came to checklist compliance, which improved from 57.8 to 80.6%. And checklist completeness also improved from 24.1 to 63.4%. Then operating room utilization rate also improved from 43.2% to 46.2%. Caseload booking rate also improved from 61.1 to 85.7%. Same-day cancellation rate dropped from 6.56 to 4. And according to our target, anything below 5 is good work. We realized that according to our standard, the transfer time, patient's transfer time, our target is anything below 30 minutes, but we realized that it increased from 40.5 to 43.5. And this has been as a result of teams from different units that prepare patients, appreciating the pre-operative preparations done thoroughly. But we are looking forward to seeing that we go into the target, which is 30 minutes. In conclusion, consistent monitoring of safety and efficiency matrices contribute to improvement in operating room safety and efficiency. And these findings agree with the global perspective. We also conclude that a customized dashboard is a helpful tool for use when it comes to quality assurance. And also, improving operating room efficiency leads to growth in operating room utilization. And growth in operating room utilization improves safety, improves access to safe surgery. Our recommendations, we conclude that consistent measuring and monitoring of safety and efficiency matrices contribute to improvement to operating room safety and efficiency. And our findings guide us that we recommend using applying a robust quality assurance systems in operating room. We also recommend continuous use of surgical safety checklist as a rule, not an exception. And we also recommend that operating rooms would use customized dashboards to monitor their safety and efficiency matrices. And also periodic review meetings and audits should be adopted to evaluate. Thank you so much for listening to me, and I also thank my team for having helped in producing this data. Thank you very much.
Thank you very much, Barbara. I know surgeons are some of the most patient people, so that's not true. So anything that can improve on your time utilization, I'm sure you'll be happy with it. Let's move on to the next speaker. Is Miss Diana here? I know Mgisha. Please come. Diana is a BSN nursing from Aga Khan University, and she's done perioperative nursing for laparoscopy. And I understand you're currently also doing your MSc in nursing in midwifery. Please, you're welcome, and give us your talk on teamwork in operating rooms, the power of communication, and collaboration with the WHO checklist.
Thank you very much, Professor Galkande, for the humble introduction. And I'm privileged to be here among the mighty surgeons, and to recognize that, yes, you recognize the power of teamwork with other professionals like nurses like us and maybe anesthesia team. So I'll be talking about teamwork in the operating room, the power of communication, and collaboration with WHO checklist. Thank you, Sister Barbara, for your presentation, because this is to add on what you were talking about. So what is this WHO checklist that she has been talking about? First of all, the operating room is a pressure cooker of an environment. Those who have been in, you can agree with me. And we need a well-functioning surgical team it is the key to successful outcome, and at the heart of that successful outcome lies two critical things, and that is communication and collaboration. And why is this checklist important? It's because significantly it reduces surgical complications and improves patient safety. And I think the reason why we go in those theaters, we need safety for our patients. That is very key. So this is the summary of our checklist. Because of the few minutes I'm given, I would like to go through the past scenarios. When I was in South Korea, I happened to train with people from Muhimbili Hospital, and there is a prominent surgical error that happened where one of the patients that was meant for, I think, leg operation ended up with brain surgery. And what was the compensation? Because when I got to know them and I knew the scenario, I asked them, what happened to this patient thereafter? They told me that to compensate this patient, he was actually put on their payroll to date. That patient is being paid. He comes in, he reads newspapers, and gets away and gets his salary. I don't think that we need to do that. Yes, I was interested in following that case. That's why I had to ask those surgeons and nurses from Muhimbili Hospital to know what happened after. So if we use the checklist, it means that we won't go through the same. And there are many unreported errors, actually. I have observed most of the times there are many errors, like one of the doctor was discussing, which are not reported, and they are happening. This study was carried out by Carillo in 2012, and it was found out that my hospital, Mulago, the compliance rate was at 10%, which was quite not nice, and we need to improve. So after I've just came back from South Korea, and when I entered their OR rooms, one thing caught my attention. I found when they are doing the checklist so well. I was observing for 6 months. Then after that, I requested that I can do a study, a survey between their hospital and my hospital, and we do comparisons. Because of the short time, I will present a few of the outcomes of the checklist. Because when I asked them if they have heard of the checklist, surprisingly, both hospitals, in fact, I was doing it among the 20 people, that is 10 nurses, 5 surgeons, and 5 anesthesia team from the both hospitals. So total number was 40. So everyone at Wonju Severance Hospital in South Korea agreed that they know this checklist, and also at Mulago National Referral Hospital. Then when we went to how often do we use this checklist, you realize that 80% of people from Wonju are using the checklist. Where are we? They are using the checklist always. For us, we are at 35%. Those who say that yes, always. Most also at 30%. For them, they don't have never. Rarely, they don't have. For us, people are saying rarely, we don't use it. So that is it. And then I went on to ask, do we get training or reminders about using this checklist? And as you could see, the Mulago team said that yes, regularly, but that was at around 15%. But the Wonju team in South Korea, they are saying that at 80%, yes, they have these trainings, which we don't have. What did the staff talk about the compliance rate? They said for us at Mulago, we are at 10 to 20%. And like for Rubaga, which has moved ahead of us at 80%, for us, we are there, but we hope to get better as days come by. And then Wonju, the compliance rate was found at 80%. And this is my roadmap. If I want to be at Wonju Severance Christian Hospital, because we know, yes, they are first world countries, but what can be done? What do we need to do to improve this checklist at my hospital? I thought about a pilot study whereby 30 theater assistants are supposed to be hired. First of all, why is the checklist not being done at Mulago Hospital? We have an issue of human resource. Human resource is a problem that even when surgeons come in, you find one nurse is working in 2 rooms. How are they going to carry out this checklist? How are they going to count your goals when one nurse is running 2 rooms? So I thought government is saying that we don't have money to recruit nurses, but me, I'm thinking otherwise, because we have people who train for 2 years, and these are theater assistants, and they are, by the way, very well trained, because me, I have worked with them. Sometimes they come to volunteer, but they are well trained, because for them, they do it for 2 years straight for OR rooms. But for us, we do it maybe 3 years, but you are doing pediatric, you're doing emergency, you are in everywhere. But these people, practically 2 years, they are studying about theater and all its relations. So I'm thinking, what if the government thinks of, we hire like 30 theater assistants in my hospital, and then we cover the gap of HR, so that each room could actually have at least 2 nurses. So that, because the goals is not going to be counted by 1 nurse, by the way. When you go to surgical counting, the goals is done by 2 nurses, and they count around to confirm that, yes, they were 30 goals, or the instruments. So if it is only 1 nurse in OR, then you're not doing the surgical count at all. And surgical count is part of this checklist. We need modification. That checklist needs to be modified to suit the local environment. Because I found at Wonju Hospital, they are modifying it for the 3rd time. For us, we have never modified even once. So we need to modify it to suit our environment. We need training, because one of the requests from Mulago Hospital, people are saying that we need to train, the proper training. When I asked them a question on sign in, time out, and sign out, some of the answers that were being given to me, which I have not shared, were alarming. That would show you that clearly somebody does not understand what this checklist is about, and to some surgeons, to nurses, and also to anesthesia team. So we need proper training.
1 minute.
We need to change our attitude.
1 minute.
When we come on board and we say, let's do this, let's train in this, let's change our attitude in those rooms. And then we need to avail it, availability. Once we do that, then we shall reach there. What is my conclusion? Let the WHO checklist be more than just a tick box. It's not a matter of coming in OR room and then you tick. No, it's practical. Embrace it. It's an opportunity to cultivate culture of safety in our OR. By prioritizing clear communication throughout the surgical process, you create an environment where everyone feels empowered to speak up, ultimately leading to the best possible care for your patient. So, doctor who spoke about surgical errors, this is the medicine for the surgical error. If we do this, then we would not have any surgical error in our operation room. I also want to appreciate the team, the above team, that have helped some of us to be what we are today. Thank you.
Thank you very much, Diana, for sharing that. We need everything we can get to be safe, patient safety, but also doctor safety. I'll be a bit vulnerable here. About 20 years ago or so, I was asked to see a patient who was quite ill. He was about 65, he had intestinal obstruction. Long story short, it was a colorectal tumor. I think it must have been on the left side. Got into the operating room. It was an emergency. I had one nurse. She was a new one. There was a bit of a trouble with the light. Long story short, the patient is on the ward, not recovering very well, but discharged anyway. Fast forward, a lawyer issuing a demand for 500 million. And I interacted with the patient who came in at that moment and presented pictures of a gauze that had stayed in the abdomen. 20 years, I think it's 20 years later now, I see the gentleman jog near my neighborhood. I negotiated down the 500 million and paid 75 for the gentleman to get off my back. But when we checked the file, the account was done and signed. But in the circumstances, one nurse assisting, one nurse running around to do other things. So maybe when they did the count, they didn't actually complete it like it should. Since then, I've opened up like about 5 abdomens with mops in there from other people. So it happens, and I think we need to learn a lot from the aviation industry and other industries that do, where the head of the team briefs before the work begins, and then also debrief after the work is done. But I think surgeons, we are so impatient, or so busy that we just want to start. And when we are done, we want to run away. I see Diana is agreeing. So we don't want to stop and brief, and we don't want to debrief. We want, so this conversation should carry on for us to practice safely, both for our sake, but most importantly for the sake of the patient and the reputation of the discipline. Our next speaker is Laila Naluyima. Naluyima, you're welcome. Assistant Nursing Officer at the Uganda Cancer Institute Operating Theatre. And I understand you pioneered the theatre in the operating rooms in UCI. You're welcome.
Good afternoon, everyone. Thank you very much for this wonderful opportunity. I'm glad to be in the room of surgeons. I'm not discussing a paper, but I'm here to advocate for nurses. That will be my content. Let us focus on the Donabenian framework. It gives an insight in our healthcare system, the Uganda's healthcare system. Today, let us not look at the patient. Let us look at the service provider, in this case, the nurse. What are the needs, the nursing needs for safe surgery? In the process, how do the nurses do what they are supposed to do? And how often do we do harm? And we do it so many times. In Uganda, it is on record whenever there is a surgical site infection, the first culprit is a nurse. So understanding what we do, our roles range from individualized care plans to administration. We advocate for patients, we act when there is an emergency, and we must ensure operating room safety. But getting all the work done in Uganda, you have to improvise and you have to be creative. So we have a lot of inefficiencies in the nursing department, that one you know, and the effect is the unintended. Most of the adverse events in surgery, like the wrong site infection, the surgical site infection, the wrong sites are all, these are something that are avoidable, but they occur. And you will know our staffing levels and the rostering practices. Rostering practices means you have the right group of people with the right skill and they're in the right place. In Uganda, it is normal for an enrolled nurse to be in the recovery room, which is not the case world over. So that is why we need to transform perioperative nursing if we want better surgical outcomes, and this is the direction we are going to take. We envision surgical excellence where collaboration meets evidence for patient-centered care. And it is high time we embrace education to transform perioperative nursing. Myself, I just walked out to the Solid Tumor Center in Cancer Institute and walked to the operating room. What do you expect from me? Even the checklist, I don't know about it. We are not taught the objectives of safe surgery during the nursing school. So that is why we need to scale up the access to safe surgery through empowered professionals. Let's start with the service providers first before we go to the patients. So the key strategy is, number one, training and education. We need to change the practice in Uganda that you just wake up from a pediatric ward, the next day you're in the operating room. They are talking about surgical counts, you even don't know the order of surgical counts. They are talking about checklists, you even don't know the checklist, even the parts of the checklist. And to make matters worse in public service, today you're in the operating room, you have picked up, the following day you're transferred to OPD. That practice should stop. If you want things to be done the right way, the perfect surgical counts, the perfect surgical checklist, not just a tick box like Diana said, let us ensure that people learn right. It all starts from training and education. If you learn from the wrong person, you're going to do things the wrong way. So this is about sectoral collaboration. You see that I talked about COSEXA because President COSEXA, after your surgeons graduating, the following day they are working with Leila who has never received any training. So what do you expect from them? It will be who is going to set up those trolleys for them. So while every surgeon these days is comfortable when the anesthesia provider is an anesthesiologist, how come that you're not comfortable working with someone you're not sure of their qualifications? Let us change the attitude. Let us empower the nurses. There we shall have things done in the right way by the right team, and we shall have better surgical outcomes. Thank you very much.
My only comment is, wow. They are so executive, Mr. President. I think we need to be making declarations from these meetings and then taking them to the powers that be. Thank you very much, not only for that eloquent, highly relevant talk, but also time. Our next speaker is Dr. Andrew Marvin Kanyike. Kanyike, you're welcome. Kanyike had presented earlier as well. So Kanyike is going to tell us about trends of transfusion, transmission infections among blood donors at a tertiary hospital blood bank in Uganda over 6 years. You're welcome.
Thank you so much, Professor Gaukande. It's an honor to be back here. Good afternoon to you all. Once again, I'm Dr. Andrew Marvin Kanyike. I'm a medical officer and research associate at Mengo Hospital. And we are going to sway a little bit away from the operating room to a multidisciplinary section of the blood transfusion. We all know as surgeons, blood is very important as we go in the operating room, but we need to know how safe is the blood being collected that we use in the theater. So this is a 6-year retrospective study from Mengo Hospital Blood Bank, second largest blood bank in the country. And the results are majorly meant to tell us how well is the screening done and the blood that is being used for the patients. As we all know that blood transfusion really saves millions of lives around the world, but it also carries a risk of transfusion-transmitted infections. And there are quite a number of diseases that can be transmitted through blood, but at least the World Health Organization mandates that those 4, HIV, hepatitis B virus, hepatitis C, and syphilis, should be screened for each and every blood that is collected for purposes of transfusion. And we see that this risk is really high in our countries. First, where we have very high demand of blood because of the kind of conditions that we have, but also have a very high incidences of these diseases within the general population. Remember, these are people who come to donate this blood when they think that they are safe. I don't have HIV, I don't have hepatitis B, but in the end you actually find out that probably they do have. Sorry? So, like I said, TTR is not only expose risk to the patient, but they are also very important for the success of our surgical interventions. And trying to establish these prevalences of TTIs is very important. Not only for the public health aspects of knowing how well the population is doing as far as these diseases are concerned and the government programs, but also for our safety of the operation in the operation room. However, data on this is really very limited. There are a few studies that have been done in Uganda in the past, and for this purpose, we wanted to try and train these infections for the past 6 years that the blood bank has existed at Mengo Hospital. So this was a cross-sectional study at Mengo Hospital, and we included all those blood donor records extracted from the Uganda Blood Transfusion Services electronic medical records that meets that criteria for blood transfusion in Uganda. And that's just give you a hint of what takes place, how this blood is routinely screened using those machines, the Architect I-200 system, that's in the lab. But we collected this data with the help of the blood bank clerk who extracted the information into an Excel sheet, extracting those demographics and the test results for both of those 4 infections. And we studied the outcomes, looking at prevalences of each, but also the trends and factors associated with them. We analyzed the data using Stata, and this research was approved by the Mengo Research Ethics Committee and will be published We analyzed records of 21,012 participants that donated blood with an average of 28 years. Most of these blood donors are actually students, if you may know. And majority of them are always male, 76.3 with blood group O, and they are usually new donors. Usually the females have a lot of caveats. They are not supposed to be pregnant. You must not have been menstruating in the last month and all that. And that partly contributes to why you see that there are more males actually donating blood. Overall, in these 6 years, we see a prevalence of about 9.1% of these infections. And there has been a great significant decrease in the prevalence from 9.6% that we saw in 2017 to about 7.9 in 22, which should be good news for us. These are demographic distributions for those particular demographics and diseases that showed significant association. As you can see, there is a great correlation between syphilis and age, and we see that there is a lot of syphilis among people that are more than 40 years of age. Yes, and HIV, like the national statistics are, it is a lot between people who are 25 to 40 years. People who are within teenage reproductive age really have a lot of HIV. Even those that come when they are thinking that actually I'm safe, because they do screening actually before you're accepted to donate this blood. When you see at hepatitis B and hepatitis C, it still had significant associations with gender, and we can see that still in that's orange. In orange, the males have higher risks of having hepatitis B and hepatitis C as well compared to the females, but which could also be partly because they were the most. And all these infections, you can see that they are really very high in new donors. Now, in the blood bank, we have what we call new, repeat, and regular donors. New donors are those that are giving blood for their first time. Repeat donors are those that are giving for multiple times, but we have what we call regular donors that give blood every other 3 months. So that means in a year they donate like around 4 times, and there are people who are committed to that. But people who are giving blood mostly for their first time, they have most of these infections, meaning that people who know that they regularly donate blood try to keep safe practices and be conscious. This is just a table of the trends, and hepatitis C is highlighted because it's the one that had a significant trend with a decrease, if you can look at this graphical presentation. But as you can see, syphilis in that yellow graph, it has fluctuations, but you can see that it has a general increasing trend. We have had a lot of focus on HIV. We have had a lot of focus on hepatitis B, which takes us back to advocacy that we were talking about earlier. For those diseases whose trumpet is being blown, you will always see the change. But where there is no advocacy, still you will see that there are gaps. So I think we have neglected things like syphilis. People have a lot of determines when they test HIV negative, they go live. And they forget that there are a lot of other diseases that could be transmitted. When you looked at the logistic regression, we saw that males were twice more likely to have hepatitis B and hepatitis C compared to the female counterparts, and people with blood group O had lower chances of having hepatitis C infection. I think this is of very much relevance to people who are hematologists. In this house, you may want to find out why. And as already explained, the new donors always have higher chances of having these diseases. But where I want us to put focus is these individuals that are between 25 and 40 with a very high risk of HIV and syphilis. And I think this is really still a concern for us and the programs. And the high syphilis rates in the people that are above 40 years of age. These are just the regression table to give us a feel of what that was. So in conclusion, we see that we have a lot of male donors, which is also seen in other studies. But you could say that this could be attributed to the fact that I've already talked about, but also the risk behaviors of males. And we have also observed a decreasing trend in these transfusion-transmitted infections, which is good. And these prevalence, changes in the prevalences, in the demographic distribution could be explained by a lot of things. But all in all, we have to look at this significantly high HIV prevalence among people who are relatively young in their age. That is it, and I would like to acknowledge the team at Mengo Hospital and the head of the blood bank unit, Dr. Kakuba, who is behind there. Thank you so much.
Thank you very much. Doing research is about finding out the truth. So we are truth seekers. And then we use that truth to make the changes that we need to make. Thank you very much for that. Some new information for me. I didn't know syphilis was rare, and it said again. So we need to do something about that. Our last presenter for this session is Dr. Flavus Egby. It should be online. Flavus, can you hear me? Dr. Flavus is a newly qualified.
Yes, Professor, I can hear you. I'm adjusting some few things, and I should hear you in a very short while.
Could we up the volume for Dr. Flavus?
Yes, let me do that.
Super. Dr. Flavus is a newly qualified surgeon from Makere, and is going to present to us the effect of perioperative blood transfusion on complications following emergency non-trauma laparotomy at Mulago Hospital. Dr. Flavus, you're welcome. Please carry on with your presentation. You have 10 minutes.
Yeah, thank you, Professor. 1 minute. I'm trying to connect here with my...
Recording in progress.
Okay. I hope I'm being heard here. Thank you very much. I am Flavius Egbe, a surgical resident at Makere University. Oops.
Have we lost him? Flowers, please go ahead. You may share your screen if... IT, we are good? No, we are not good.
Recording
Okay, Flavus, could you please switch off one gadget? and stay with one, we have echo. I hope you can hear me. And when it's done, we'll ask the panelists to come over and we'll take a few questions and then we'll conclude the session. Okay, we still have an issue with Flavas. Okay, let me ask the panelists to come over, the ones that I presented earlier. And then, Flavas, if you can hear me, we'll get you on a little later when the IT issues are sorted. Okay, could we have the mic move around? I'll allow 6 questions or comments. And whoever speaks is allowed only 1 question or comment. Okay, whoever is moving the mic around. Professor Bellman, you want to do the first one? Could you have the mic this way? Chigonya, right here in the front.
I'll use my loud voice. How's that?
Your military voice.
Mugisha, wonderful talk about timeout. Thank you for that. The question that we always struggle with is, let's say you want to change a surgeon's behavior. How do you change a surgeon's behavior? We had a terrible time when we did this in our operating rooms and told the surgeons that they were now going to have to start a timeout and then a discussion after the operation. I'd be interested in your thoughts on that. And Dr. Kanyike, just one brief question. Why do you think the incidence of HIV and syphilis increase with age? Thank you, sir.
Thank you. Thank you for the presentation. Mine is just perhaps an information. I know COSEXA was mentioned there. With the advocacy, COSEXA managed to advocate for the College of Nurses and Midwives, EXA College of Nurses and Midwives, to start a module on theater nurses. And it is only CANEXA, not CANEXA, but EXACON, EXA College of Nurses and Midwives, that is delaying that training. So you as nurses should push for that training to start. And even before I left the main theater and the theater committee in Mulago, I was trying to push the administration to let the nurses go on that module of training. It is by the Irish Aid under the EXA College of Nurses and Midwives. So get in touch with your college in Arusha and have that training started. Thank you.
Thank you. My question or concern is to Dr. Kanyike. The CDC reported an 80%, my question is to Dr. Kanyike. The CDC reported an 80% increase in syphilis numbers in the US between 2018 to 2020, and it looks like it's being mirrored here. The concern is, are we reporting to the concerned bodies, the Ministry of Health, WHO, etc.? Thank you.
Thank you. My question is to Leila. I know that the Uganda Cancer Institute is currently involved in developing an oncology nursing curriculum, and I think it would be a very good avenue to actually slot in the oncology nursing surgical issues. So I don't know if that is being captured, and if it's not being captured, is there still time for you to slot this in? Thank you.
Can I have two more?
Yes, my question is to Leila. I was interested in the discussion. You really pointed out a good need. But I'm interested in knowing what is currently being done to address this issue. Do we have some training that is being done? And it might be not done here in Uganda, but also outside. I would want to know that.
Please go ahead.
I'm so glad that we have nursing here, because a lot of times our problems as surgeons are partly, we blame the nurses unfairly in their absence. I'm glad that you're here, but we can air some of these issues. And my concern is about the issue of, you touched upon it. You have nurses who are trained, or who get trained on the job, and then they keep being shifted out of the theater to another place. Maybe this is an avenue for you to advocate that you get specialist nurses as opposed to the nurses being shifted all the time, because we've had challenges with that. I would like to hear your comment about that.
Okay, thank you very much. We'll close the questions at this moment and let our panelists respond from, I think, my end. Moving up to Kanyike. Please respond if you have a response. And in the meantime, please take note. We need some feedback. That would be nice.
Okay. Thank you very much, Professor, for the question. Surgeon's behavior. I'm glad that at least Mulago Hospital comprises of a bigger percentage here in this room. So our behavior is going to change from today. Yes, we have a big number in the house, and then we need to change our attitude when these things come on board. So let's change our attitude from today, because the professor already knows that our behaviors are not very easy to change. But today I am advocating that we need to change our behaviors, that when new things come on board, like you would see me running around those 16 theaters and trying to guide each team. Don't say that this is a nurse, she can't guide me. Yes, I can guide you because I'm trained to do so. So if I come and I'm like, this is ENT team, how best can we do this? Kindly and humbly, let's be positive towards this, because I talked about the attitude. Let's change our attitude, because this is teamwork. You don't work in an island alone. We work as a team. I was happy when I was in South Korea and the nurses were telling me that before sign out, this anesthesia team will never touch your patient if the whole team is not in the room to do a sign-in. They won't touch your patient. So if a nurse is not in the room, they won't touch your patient. And they are saying that it's anesthesia team which is actually leading this WHO checklist. So allow me stop here, but I think our behavior is going to start changing from today, now and onwards. Thank you.
Thank you very much for all your comments and concerns and the questions. Number one, about the training offered by ECOSAN. I have done this training. It is online. But even in this room, we are in Kampala. next to the airport, but still, internet is on and off. So how about our nurses in Nebi? It is a very good course, a modular course. I have done it. It is so good. But let us go back to the basics, the foundation. Just like you, the doctors, graduate from medical school with your basic surgery, then someone chooses to specialize. I think it is high time. That is why if we could project my slides, I had so many stakeholders, including the nurses, the National Council for Higher Education. These things need to be taught at that tender age when someone still has the passion for the course. You know, old habits die hard. So getting this person at this tender age, they have just joined nursing, and you're taking them through the surgical counts. Theater is not as easy as a word. Mastering those sets that this is how I pass on this artery. You don't just wake up from the ward and go. So it needs a well-blended course, the online and the practical part of it. I have benefited from international collaborations like the Korea Foundation for International Health. I have done the observership. I have done the hands-on. This is what I'm advocating for my fellow nurses. Not everyone can go to the labor ward and deliver those mothers. Why is it that everyone can work in the operating room and we are comfortable? Let's change the story. On Cancer Institute, I'm lucky to be part of the curriculum development team. It is captured. The surgical oncology nursing is captured. We just have to see where it has reached, but everyone will be taught. But I'm still advocating for the basic during the nurses training, the first, whether it is on enrolled level. Everyone in this room, I said, let me echo it. Every surgeon is comfortable having an anesthesiologist, giving them anesthesia. Anesthesiologist is at master's level, is a consultant. All the surgeons here are aspiring to be consultants, and most of them are consultants. Then you're not fair to us, the trolley setters. We are managing the equipment, but everyone is comfortable with us having our certificates, our diplomas, no specialized training. I'm advocating for a specialty in perioperative nursing. That is why I had public service as my stakeholder. Let people train, have a wage, and they should be incorporated in structure. Everything is possible in Uganda. Please, let's advocate for the right nurses in the operating room.
Thank you. Kanyike?
Thank you so much for these questions. Indeed, everything is possible in Uganda, in all aspects. I would begin my submission with the fact that I think authorities and the WHO will have to shift some of the diseases into neglected tropical diseases, besides the known parasitic diseases we know. Because besides the ATM diseases we all know, which are very, being blown out so much, most of these other diseases are becoming neglected, and they are still cropping up within the population. When you look at why HIV and syphilis increase with age and this demographical distribution, I would want to take this back to the health belief model, the perceived risk. You know, when they talk about a lot of HIV, everybody knows how HIV is spread, everybody knows how to prevent HIV and all that. People get that perceived risk of, I think this disease is dangerous. And if it's not done for all these other diseases, like, for example, the syphilis, we are seeing people are going to become complacent about it. But also, you can see that the fact that we are not seeing a lot of advanced HIV disease where, people were really very debilitated and all that, people have also become complacent about HIV. They no longer mind so much about it, and I think within this teenage and young adult population, this is very high, and it hypothetically could be one of the leading cause of increased incidences and new cases within this age group. There's a lot of complacency, there's a lot of information out there about contraception and all that, so people know how to prevent pregnancy, so the rest of the things, they can sort it. People no longer see very badly of HIV patients, so they actually have lost that perceived risk of HIV being dangerous. And away from my question, just permit me to have just a submission about how to change the surgeon's behavior. I am a student of implementation science. I'm a research fellow at Washington University, and I think, like you said, you cannot change what you don't know. I'm an advocate of shifting towards doing what we call implementation science, translating evidence into practice. We know that the surgical checklist works, but we know that the surgeons are not doing it. So we have that no-do gap. How do we bridge it? This is where we are shifting from research of p-values, confidence intervals, to translation research, looking at how do we create intervention and implementation strategies to change the practice to what we want to know. And there are a lot of information about this growing field. There are a lot of models and frameworks like the Combi model, which suggests that a person's behavior is influenced by their capability, the opportunity, but also the motivation they have around them to change their behavior. So we can employ such models, we can employ such frameworks to do formative researches, and then follow them up with developing implementation strategy interventions, and eventually we can have results. So this is a growing field. It's a very interesting field that you would want to look at if you want to change such things. Thank you so much.
A big hand clap to our panelists. And as they stand up for a photo, there's someone special here who was born like today. Can we sing for them happy birthday? IT? IT? Our president, Koseksa. I have a spy network, so I get to know the things. And the chief spy is Professor Chijambo. A photo of our panelists, and then we Secretary General, you want to make the lunch announcement?
Hello, ladies and gentlemen, thank you so much. I hate to interrupt the cephalic phase that Professor triggered. But I want to ask you to bear with us. We have one more session, and then we can go for lunch. The restaurants have been informed our lunch will be there when we do so. Dr. Nasser, you are most welcome. Thank you.
Good afternoon, ladies and gentlemen. I'm Nasser Kakembo. I'm the session chair for this session, which is number 12, Harmonizing Multidisciplinary Teamwork in Surgical Care. I have a list of 6 presenters, and our first presenter is Dr. Fiona Kavagenyi, talking about collaborative care, transforming pediatric aerodigestive management through multidisciplinary teams, insights from 4 cases. Dr. Fiona Kavagenyi is a pediatric ENT surgeon, currently lecturing in the Department of ENT of Makerere University. She's also the Secretary of Otolaryngology Society of Uganda and a CHESA Fellow. Her passion is in taking care of children with complex aerodigestive conditions. Dr. Fiona, you're very welcome.
Thank you, Dr. Kakembo. And I'd like to recognize the pediatric surgeons for helping me navigate this. Sorry if I'm panting. I came quickly so that I don't, by the time I reach, I'm better. But it might take a while. Okay. The presentation? Perfect. So I will not go into that, but that's what I'm going to present about. As a background, we have so many children that come with complex aerodigestive head and neck issues, and they present with respiratory problems and gastrointestinal challenges. And these children tend to see so many specialists like pediatric surgery, pulmonologists, pediatric ENT in this case, and so many others, to mention a few. And generally over the world, not over so many of that, but the developed world, there's been a shift to structured pediatric aerodigestive centers. And if you look at that map, ranging from the dark colors to gray, which shows no data, US has more than 30 of these centers, and Africa here only has 1 in South Africa, and there is none for us here. But it has been shown that collaborative care for these children actually helps to improve diagnostic accuracy. It also reduces delays in cares, it minimizes anesthetic exposures, and reduces the financial burden of these patients. So we decided to, in Uganda, at Mulago National Referral, which is the teaching hospital for Makerere University, to carry out a chart review of the patients that have had at least more than 2 specialists take care of the children, but have complex aerodigestive lesions. So we'll talk about the 4 cases. The first case is an 11-month-old who came to us with 5-month history of gradual swelling of the mandible and the maxilla, had inadequate feeding, but had no stridor. Our problem list was that there was anticipated difficulty to intubate this child, and between OMF, ENT, anesthesia, and the intensivists, we decided that we would try awake flexible intubation without putting a tracheostomy. For a pediatric ENT, I hate tracheostomies, so I absolutely put one when I need it, but not if I don't. So we discussed this over WhatsApp, we did physical, we talked to the ICU that would take the patient to ICU so that we just wait for the child's airway to come down after the surgery. And the beauty was that we actually avoided a tracheostomy. We did this with the flexible. The child spent far less time than they would have if they had a tracheostomy. The second case was a 21-day-old female who failed to feed since birth. Radiologically, they had a tracheoesophageal fistula, and we needed to rule out other airway issues. We needed to locate the lesion. So between pediatric surgeons and pediatric ENT and the anesthesia, we decided that we wanted to do a direct look, so direct laryngoscopy, tracheoscopy, bronchoscopy, mostly called a DLTB, to locate the size and the size of the fistula. And what we found was that this child, this is the look, had a fistula that was just 1 centimeter from the carina horizontally on the left. And because of that, it was easy for the pediatric surgeons to just put the child in left lateral, go straight to the point, count from the carina 1 centimeter, and that was it. It reduced their surgical time immensely, other than just going in and look. So it was actually better for them. The third case, The third case was a child who's 23 years old, came in with washing machine breathing since birth, had cyanotic spells, poor weight gain, frequent lower respiratory tract infections. And I hope I can do the video. They talked about this when they were telling us, but I don't know how to make the video work. Good. So this is what a larynx looks like, and the tracheal rings are supposed to be C-shaped, but as you go all the way down, it's supposed to be a beautiful wide space. But you can actually recognize a narrowing right there, and that was the problem. So when we actually looked radiologically, the child had a long segment tracheostenosis. This can be congenital, and so this was the problem of their washing machine breathing. When we consulted after finding this out between cardiothoracics and ENT cardiology to make sure they don't have any further cardiac issues, we realized that we would need cardiopulmonary bypass, elongated pediatric ICU stay. We'd have to open the chest. These things are not available in Mulago National Referral Hospital. So we decided that since this child would benefit from a slight tracheoplasty that we can't do currently, it would be safer to refer. So this is for the safety of the patient. So we decided to refer this patient. And lastly, the 2nd-month-old female had a large thoracocervical lesion. They had an impending airway obstruction and severe thrombocytopenia, like 10. They had already started bleeding spontaneously. They had difficulty in feeding. And so we talked about it with ped oncology, ped anesthesia. We couldn't intubate, we couldn't trach. There is nothing that you can see to put your tracheostomy at all. And this was a patient that needed palliative care because we realized we weren't going to do anything for the child. So we kept talking about what we could do. We did cross consultations with mentors across the field in different places. We decided to do a trial of propranolol because it was a hemangioma. Initially, there was some improvement, but it came back. And then we tried to do the vincristine. But because there's a variation of some of these lesions that have what we call Kesselbach-Merritt syndrome, 40% die. We decided to engage the palliative care team, talked about the outcome with the patient, decided hands-off as surgeons, medical treatment as far as we can, and cancel the patient. So in summary, all our 4 cases were actually under 2 years of age. We had both medical and surgical specialists involved in their care, and the conclusion of these 4 cases is that multidisciplinary teams are actually advantageous to both patients and specialists. To the patients, it just reduces operation time, avoids potentially morbid procedures, and enhances the family and patient quality of life because you tailor their evaluation and treatment. To the specialist, who doesn't want to be the one who decided singly? The pressure is off, but we also have enhanced working relations. We have shared decision-making, and we come and present at the Asou meeting because we feel invited to be in this table. So MDTs are holistic. They should be integrated. They should be structured. And it's something that we should embrace going forward. Thank you very much.
Thank you, Dr. Fiona. I've just picked one lesson from your presentation to observe the ABCD of life, which actually stands for always be collecting data about your business. Our next presenter is Dr. Rachel Angom. She'll be talking about clinical outcomes of children with cancer who have survived and had surgical intervention before presentation to Uganda Cancer Institute. Dr. Rachel Angom is a pediatrician and a pediatric oncologist. She did her MB-CHB training from Makerere University and Master of Pediatrics from Makerere as well. She also earned a fellowship in oncology from the East African Center of Excellence for Oncology, based at Uganda Cancer Institute. She's currently an oncologist at UCI, and her passion is in dancing and cooking. Dr. Rachel, you are very welcome.
Thank you very much. Thank you. My name is Rachel Angom Ariaka, and I am presenting on behalf of the Pediatric Oncology Multidisciplinary Team at the Uganda Cancer Institute, and the pediatric surgeons that sit on the MDT. Some of them are here. And that's the presentation outline. So multidisciplinary teams in pediatric oncology consist of specialists that are making decisions about a common patient, the child with cancer. 2/3 of childhood cancer will at one point require some sort of surgery. And multidisciplinary teams have been found to improve care coordination as well as patient survival. At the UCI, we have an MDT that meets 3 times a week, on Tuesdays, on Thursdays, as well as on Fridays. And this has not only been used for patient care, but increasingly for research and training as well. Importantly, surgery has really improved survival for a multitude of childhood cancer cases. And it's an integral part of the treatment pathway for childhood cancer, as you can see from biopsy, venous access, surgical resection, as well as reconstruction and palliation. And strict adherence to pediatric surgical principles will lead to better local control as well as better survival for children with cancer. On the contrary, non-adherence will lead to tumor seeding and spread, mutilation, morbidity, as well as mortality. So we did a retrospective review of 13 cases of children less than 18 years who presented to us having had a surgical intervention from their referral center. All these patients were discussed at the MDT, and we report whether the surgical interventions were appropriate in type and in timing, whether we also report the time from pre-referral surgery to arrival at UCI, the quality of diagnostic tissue submitted, the effect of pre-referral surgery on definitive management, as well as the patient outcomes. So these are the 13 cases, but I would like to draw our attention to the first 4 cases. The first 3 are children who ended up having Wilms tumor. The first case had radical nephrectomy. However, when this child came, we had no comment on what the stage was. Was the tumor in the capsule or not? We had no comment on the ureters, but this child ended up having Wilms tumor with no anaplasia, which is a very curable tumor. We had another child who also ended up having Wilms tumor, but they had had exploratory laparotomy with debulking surgery of a kidney tumor. So it chopped a little bit and left part of it, and then this child presented up with wound sepsis, as well as a burst abdomen. We had another child who had radical nephrectomy, however, was not referred for adjuvant care. So at the time of presentation, about 6 months later, they came with recurrence at presentation. The fourth child was an 11-year-old female who presented with abdominal distension and had exploratory laparotomy with a left oophorectomy, was not referred for adjuvant chemotherapy, and had recurrence at presentation, and this patient ended up having a dysgerminoma. So the average time from pre-referral surgery to arrival at UCI was 9 months. The shortest was 7 days, the longest was 2 years. Was the type of surgery appropriate for the tumor? In 2 cases, yes. In 11 cases, no. Was the timing of surgery appropriate? In 13 cases, no. In all of them, the timing was not appropriate. Was the tissue submitted sufficient for diagnosis? In 6 cases, yes. So the effect of pre-referral surgery on treatment and outcomes, we noted that all 13 children had increased morbidity. They presented with severe malnutrition, they had burst abdomens, they had wound sepsis. We surmised that in all cases, the tumor was possibly upstaged. These children needed more intense chemotherapy and radiotherapy, and they had significant delay in receiving appropriate care. So I want to shine a little spotlight on this case. We received this 8-year-old girl who had a 3 months history of abdominal distension. And at the time, a right ovarian mass was discovered on ultrasound scan. She right away had a right salpingo oophorectomy. And at that time, there was no histology done. So she was sent back home. A year later, she had a recurrence of the abdominal distension. The ultrasound scan showed a left ovarian mass. At that time, she had a TAH with left salpingo oophorectomy. As a pediatrician, I understand that at this point, she has no ovaries and no uterus. I hope I'm right. And at this point in time, they give us histopathology, and it's high-grade non-Hodgkin's lymphoma. Nobody takes out ovaries and a uterus from an 8-year-old who has non-Hodgkin's lymphoma. It's highly curable with chemotherapy. So this child arrived at UCI over 1 year later, since the first symptoms. The tissue block that we received was actually insufficient for us to make a conclusive diagnosis. So now we have an 8-year-old girl who has no ovaries, has no uterus, but we also do not have tissue to make a diagnosis. So the challenge here, as I've listed, we have no tissue, we have no conclusive diagnosis, but now we have a child who has significant morbidity down the road. So we discussed her in the MDT, and of course the recommended pathway for children with suspected cancer is really history, physical exam, do a bit of investigations. For an 8-year-old who has an ovarian mass, a germ cell tumor is a plausible differential. MDT discussion on the best mode of tissue harvest would have done well for this girl. A diagnosis, discussing all the way to surveillance would have saved this girl from the morbidity which now she faces. So the findings suggest that surgical intervention for children with suspected cancer in the absence of consultation with a pediatric oncology multidisciplinary team has the potential to cause 1, referral delay, increased morbidity, upstaging of the tumor, and therefore children requiring more toxic treatments and hence severe side effects. So the recommendations from the team is really development and or adaptations of collaborations between pediatric oncology practitioners and the surgery community to develop an urgent consultation and referral pathway for children and adolescents with suspected malignant tumors to develop and or adapt and disseminate pediatric oncology surgical guidelines for surgeons as well as trainees, and also to design and package training modules for medical students, interns, and surgeons on the pediatric oncology surgery principles as well as practices. Thank you very much.
Thank you, Dr. Angom. For sure, multidisciplinary practice is the way to go, especially in cancer care, as long as we stick to the 3 pillars of multidisciplinary team approach to things. That is communication, collaborations, and appreciating the roles assigned. Our next presenter is Mr. Yakobo Nsubuga. He will talk about clinical outcomes of patients hospitalized with femoral fractures at Guru Regional Referral Hospital, a retrospective cohort study. Yakobo Nsubuga is a 5th-year medical student from Guru University. He holds a diploma in orthopedic medicine from Lago Paramedical Schools, and he has published very many papers and as first author. His dream is to become the best surgeon. Thank you.
Thank you so much. Good afternoon to you all. First and foremost, I'm thankful to Asou for this great opportunity, especially the scientific committee, in allowing me present this paper to you. I'm really humbled. One of our papers that we have carried out in our stay in Guru region, it's about clinical outcomes and associated factors. Okay, clinical outcomes and associated factors among patients hospitalized with femoral fractures at Guru Regional Referral Hospital. It was a retrospective cohort study. Julius, Edward, Kenneth, and Jerome are fellow colleagues. Dr. Maurice Ojala is a serving orthopedic surgeon in Guru Regional Referral Hospital, and Dr. Felix Bongmin is a lecturer in Guru University. Our operation definitions are treatment success, which was defined as the proportion of registered patients who were cured plus the proportion that completed treatment to all registered cases. Then treatment failure, it was the proportion of registered patients who were not cured regardless of proper treatment protocols being followed. Then the fracture pattern, it's the structural appearance in which a fractured bone appears as diagonized on the X-ray radiograph. So the background of our study, fractures of femur are among the leading cause of lower limb discrepancies and disabilities in developing countries, according to Samieto. According to Koval, the femur bone can fracture at the proximal, mid-shaft, or distal end. And according to Dr. Sakamate, he says different patterns of femoral fractures predict different clinical outcomes. So data on femoral fracture patterns and their association with clinical outcomes in northern Uganda remains unclear. This is something we shall discuss about a bit later. We aim to determine the femoral fracture patterns, complications, mortality, and predictors basing at Guru Regional Referral Hospital. In our methods, it was a retrospective cohort study where we retrieved archived clinical notes of patients diagnosed with femoral fractures from January 2021 to December 2022. The study setting, we used the orthopedic unit and the surgical ward, the orthopedic unit which is incorporated into the surgical ward of Guru Regional Referral Hospital, found in Guru City in the north of this country, Uganda. Our eligibility criteria, our inclusive criteria, we considered radiologically confirmed diagnosis of femoral fractures and excluded all those archived files of those patients who had femoral fractures, but having missing 75% of the predefined data on the abstraction tool that we are using. Another criteria, we also excluded all those that had been clinically diagnosed with the femoral fracture. Data collection, in our abstraction tool that we used, it had variables that were structured in demographics, X-ray patterns, complications, and also indicating in-hospital outcomes. Data analysis was done based on those objectives. Objective 1, proportions were considered with corresponding 95% confidence interval. At a stage of multivariable analysis as well was done. Part of the work was multivariably analyzed. We had some parts of also regressed by poison. And then later on, some of these patients, since they stay on ward for some time, we had to use a Kepler-Meyer estimator to estimate their length of stay in the hospital. Ethical considerations, we received permission from Guru University Research Ethics Committee, and at the same time, we received a waiver of consent to receive anonymized data. Our key findings from that data are as below. We managed to get 248 files of patients who had been admitted and had been diagnosed with femoral fractures. Their median age was of 33 years. And in the clinical findings, we found out that 90.7% of them had a closed fracture, 27% had complications, yet 76.6% of them had a fracture shaft, femur. And we also found out that 84.4% among all the causes that attributed to attainance of that fracture pattern or any, attainance of a fracture of specifically the femur bone, the greatest cause was road traffic accident. In hospital mortality, it was at 8.5%. Out of those files, we found out that 21 of those participants had died. We also found out that low level of education could independently predict mortality. So we found out that at least the primary education, it had a p-value which was of 0.009, which was a key finding to us. Important to note, I discussed this. These are just general portions of the femur bone, but we found out the greatest part that was affected, it was the shaft part of the bone, which scored 76.6% among others. Furthermore, we found out, using Kepler-Meyer survival analysis, we found out that the overall mortality was 8.5%, I discussed it earlier, and the median time to death was 19 days. This overall survival analysis we used from the date when the person was diagnosed, of course clinically with the X-ray, up to the time the person either died from any cause or comorbidity or up to the end of the information that was available by then in the records. The complications are important to note here is that if you look at all these p-values, they were greater than 0.05. So they had no statistical significance, so we didn't look at them so much. But important to note are these complications that are in this graph here below, where bleeding took the highest percentage, 34.9%. Just to make a recap, the complications we are looking at in these patients are the in-hospital complications. When a patient is admitted, up to the time the patient is discharged off, or up to the time the patient has died. So we are considering those complications that could occur in these patients. So that graph there shows us that bleeding took the highest percentage, whereas misalignment, possibly post-surgical intervention, maybe misalignment of the implants, it took 7.6% compared to others. In our conclusions, we found out that road traffic accident, the TV is off. Let me use the other side. We found out that road traffic accident is the main cause of femoral fractures. And then we also found out that the complications are common, like 1 in 4 of them, and we found out a high mortality in 1 in 10. My last slide, this is acknowledgement. I must echo it again. I'm really so humbled, so thankful to Asou, especially the scientific committee, for accepting this study to be presented to you. I'm happy for my mother university, where I belong to, from the Chori land over there, specifically the Guru University Research Ethics Committee that gave us the permission to present to you, to be capable of working out this data. Important to note on Guru University, also appreciate part of my lecturers who are as well in this room. For example, Professor Chitara David seated behind there, Dr. Kid Ronald around. I've seen Dr. Nyeka around. Thank you so much for the motivation. I'm as well thankful to Guru Regional Referral Hospital and St. Mary's Hospital, Asou, for the great opportunity they have given us to act as, to get our research very well from those two sites. Important to note, my supervisors on this paper, specifically Dr. Felix Bongomin, with over 286 papers produced, who has motivated me into this from my second year as an undergrad, together with Dr. Ojara Morris. Thanks a lot. May God bless you, and my co-investigators.
Thank you, Mr. Yakobo, for sharing your experience from Gulu. Our next presenter is Dr. Chintuluwaga, talking about clinical pathological patterns and management of thyroid cancer in Mulago Hospital, a 10-year retrospective review at a major tertiary center in Uganda. Dr. Chintuluwaga is a fellow of the breast and endocrine surgery, which he attained from Sanjay Gandhi Postgraduate Institute of Medical Sciences, India. Chintuluwaga is also a consultant on the breast and endocrine unit in Mulago and is the head of that unit. Mr. Chintu, you are welcome. Give your talk.
Thank you so much for inviting me to make this presentation. All protocol observed. I wish at this juncture also to thank the organizers for giving me this opportunity to share with you some aspects on thyroid cancer. Indeed, like the sub-theme says, management of thyroid cancer is also requires a multidisciplinary team, and as you can see, this entire team has been involved both in the clinical care of our patients and also in making this presentation. So in the background, the World Health Organization has actually acknowledged that all cancers are on the increase, including thyroid cancer. And talking about thyroid cancer in particular, the global incidence is on the rise across almost all geographical regions, including sub-Saharan Africa and Uganda in particular. And numbers aside, the profile of this disease is also changing rapidly. For example, as we speak, papillary thyroid cancer has been reprofiled into low risk and high risk. And of course, the management strategies are also changing accordingly. For instance, you'll find that in cases of papillary thyroid cancer of low risk, management is no longer as aggressive as it used to be. Unfortunately, in our regions, thyroid cancer remains understudied. And this is why we have a lot of work to do to find out more about this condition. In this particular study, we sought to describe the clinical and pathological characteristics of thyroid cancer in our setting, and also to look at the various management options available on the endocrine surgery unit, in particular at Mulago Hospital, and we did this over a period of 10 years, as indicated. Mulago Hospital also serves as a teaching hospital for Makerere University, as you may all know. This was a cross-sectional study performed in the period indicated and on our endocrine surgery unit. It was carried out in the middle of 2019 using a team of trained research assistants. We worked out the proportions and frequencies among the various variables that we saw, and we presented our data largely as percentages. In our results, we accessed about 568 case files, and 87% of these were thyroid cancer, confirmed thyroid cancer cases, histologically confirmed, and this was 15.3%. Looking at some of the social demographic characteristics, our mean age was 46 or 47 years, which is in the lower segment of the middle age. And as we shall see how this compares to other territories. The majority of our patients were female, about 70%. And regarding the location, most of our patients were from the central and western region, probably because of proximity to the institution. Unfortunately, about 50% of our patients had no formal education at all, and this tells a lot about this condition and its predilection regarding the socio-economic status. Major presentations were neck swelling, pressure symptoms, including difficulty in breathing, and pain or tenderness on examination. We tried to tease out some known risk factors, but as you will discover, most of them actually were low. History of smoking, about 6%, exposure to radiation, about 5%, positive family history, 3%, and exposure to known foodborne goitrogens was only 3%. And all patients reported to be consuming iodized salt regularly. So we begin to raise questions about iodine deficiency. This is an atypical presentation of papillary thyroid cancer with direct skin invasion, something we are seeing more and more these days, probably telling another story about the changing profile of the disease. Looking at the subtypes, based on histopathology, papillary thyroid cancer was found to be dominating at 70%, followed by follicular thyroid cancer, Hutto cell and poorly differentiated cancers, and the other types as indicated. In the management, we found out that about 14% of our patients had been exposed to other unconventional, or you call them traditional treatments out there before seeking conventional treatment in the established medical centers. And for those who received, about 70%, we offered surgery as the main intervention, and this was in the form of total or near total thyroidectomy. And about 50% of those we saw had a significant lymph node involvement, and we had to do either selective lymph node dissection or central compartment lymph node dissection. We also had a significant number of about 30% who could not benefit from surgery because of advanced disease, and these were forwarded for non-operative interventions, including chemotherapy. We also had a small portion of patients who declined surgery for various reasons. Radioactive iodine is one of the major adjuvant therapies we offer to those with differentiated thyroid cancers, and as you've seen, 90% of our patients actually had differentiated thyroid cancers. But unfortunately, as you may see, only about 2.3% could access or afford radioactive iodine. And this is a major gap in completing treatment of our patients. We used the telephonic follow-up to establish the number of patients who were still alive in this period of time. And we found out that about 70% of those who were reachable were still alive, and about 55.5% had no health problems. With this data, we calculated an absolute 5-year survival rate of about 65.2%. We noticed that prevalence of thyroid cancer in this study is slightly higher than what has been recorded in our setting, as indicated. This is also slightly higher than what has been seen in other regions, like East and West Africa, in Ethiopia and Ghana respectively. As indicated, most of our patients presented with late disease, and this is why most of them could not benefit from surgical correction. Our mean age of 46 is actually slightly lower than what we see in the Western world, where they have peaks in the 5th and 6th decade. Also important to note is that the non-risk factors, as I indicated earlier, were very low. And this raises questions about the need to research more and discover what else could be contributing to this condition. And the histopathological pattern, our pattern of papillary thyroid cancer leading the pack is not very different from what has been seen in other territories of the world. We also noticed that our survival rate is slightly better than what has been documented earlier at 12.5% by Wabinga and others around 2005. So in conclusion, we notice a slight increase in the prevalence of thyroid cancer in our region. It's also commonly affecting the lower segment of the middle age group. We are intrigued about the low prevalence of the known risk factors, and this leaves a lot of work for us. We are also concerned about the low utilization of radioactive iodine in adjuvant treatment, as well as the other targeted therapies. And this leaves our management of these patients incomplete. One of our major limitations was incomplete records, which comes up in our recommendations, where we need to do prospective studies to overcome this limitation. We also need more studies to understand the risk factors better in our setting, and we need to lobby to improve access and affordability of radioactive iodine to complete therapy of thyroid cancer. We also want to adopt screening measures so that we can catch this disease early. These are some of our references. I thank you all for listening, and I acknowledge the other members of the team. Thank you.
Thank you, Dr. Chintu. We thank you because our cellular phone coverage in this country is very low, but you went ahead and did a telephonic follow-up for your patients. Thank you. Our next presenter is Dr. Mbaga Chigongo. He's going to talk about the increasing early detection of prostate cancer through screening. Dr. Chigongo Mbaga is a urologist at Eurocare Hospital. He holds a Master's of Surgery from Makerere University and is a fellowship in urology from COSEXA. He's also the Assistant Program Director for Urology Training at Eurocare Hospital. His passion is in surgical training and research. You are welcome, Dr. Chigongo.
Thank you so much, the chairperson, for the kind introduction. Greetings, dear all, our distinguished guests. Yeah, my name, Mbaga Chigongo, like mentioned. Allow me to talk to you about prostate cancer. Early detection of prostate cancer using a screening program at a tertiary hospital in Uganda. Sorry. Okay. Sorry about that. So, prostate cancer, like all other cancers globally, is increasing. This chart will summarize the burden. The blue bars indicating the incidence of prostate cancer in different regions. The top two are Northern Europe and Western Europe, having about 80 and 70 cases per 100,000. You find Eastern Africa somewhere in the middle. On the lower end, East Africa, about 27 per 100,000. The red bars represent mortality. What stands out is that the mortality rate of the top two regions in Northern Europe and Western Europe are less, they have less mortality compared to East Africa and many other parts of Southern Africa. So how can they have such high numbers of prostate cancer, but still they maintain lower mortality rate? For us, you can see that mortality is closely following the incidence, and the answer is in the health system challenges, which cause late presentation. As you know, our patients present with advanced disease, and as a result, they usually succumb shortly after. There's no primary prevention of prostate cancer. We can't prevent it from starting, so we need to boost screening. So that's why I'm interested in increasing early detection through screening. Our study objective was, one is to describe the characteristics of patients who underwent prostate cancer screening and biopsy at Eurocare Hospital. Two is to determine the factors associated with the cancer diagnosis. The third and most important is to determine the proportion of patients diagnosed with localized cancer. When you do screening, the goal should be to identify the early cancer, not just to catch any cancer, but to have a lot of them with the localized cancer. Localize the patients. Those whose screening outcome is suspicious for cancer, we recommend a prostate biopsy, and we are routinely doing ultrasound-guided transrectal biopsy. On the other side, those whose screening is normal, we do a health education and refer them to routine care. There are always those in the middle who are indeterminate. There we use MRI of the prostate. We see how the prostate lesions look like on MRI. They are described and attached a score called a PIRAD score, scored 1 to 5. And lesions which look like PIRADs 1 and 2 are determined to have low risk of cancer, so we consider them normal. And the lesions 3 to 5 are considered a high risk for cancer, so we consider them as suspicious finding. So eventually we biopsy all those. We collected data. The men included men who are 40 years and above. Over a 6-year period, Eurocare has been around for 6 years. We extracted the variables, anonymized the data, and used Data 14 for analysis. And this study was a sub-analysis of a bigger study which was cleared by IRB of Makerere University. These are the results. For screening over the 6 years, 6,500 men attended the screening program, PSA-based screening. As we follow that to dichotomize them, those who have suspicious lesions and those who are normal, eventually we end up here at 370 were having suspicious findings. Therefore, we recommended the prostate biopsy. And this 370 is the main denominator for the study because we went further. For those who had cancer, we went further and did a stage to determine their stage. So like we said, 6,500 men screened. We ended up having 370 having suspicious screening findings who were biopsied. So a biopsy rate becomes about 5%. The median age was 69 and the median PSA was 22. Among those we did a biopsy, the cancer detection rate is 58.8%, totaling to 218 patients. And when we do staging, we find that 35% of them had localized disease. Remember, this means stage 1 or stage 2 prostate cancer, and this lends itself well to curative treatment. The commonest treatment we offered for localized disease was open radical prostatectomy in 17% of the patients, which is 39. Some other patients had other radical treatment like radical radiotherapy. Others preferred to be referred to India for robotic prostatectomy. Some other men were not fit for surgery. Although they have localized disease, maybe they are not fit for surgery, so you opt for other treatment options. The factors associated with prostate cancer, we identified the age. If you are older than 70, the odds ratio was 4. PSA, as PSA increases, the risk of cancer comes out in agreement with many other studies, and suspicious finding on digital rectal exam. On rectal exam, we look for suspicious nodules and other factors, the mucosa, the bleeding, and the things we look for in a rectal exam. So our old rectal exam is still very important. A sensitivity of 41%, but a very high specificity of 94%. This means that on rectal exam, if a doctor found that you have a suspicious findings on digital rectal exam, there is a high likelihood that biopsy is going to confirm cancer. In the discussion, I choose these three that a study done in the USA 2 years ago found that when they diagnose prostate cancer, about 90% of them have localized disease. 10% have advanced disease. In Uganda, at the Uganda Cancer Institute, Dr. Kuku and the team documented that we get the exact reverse, where the 90% come with advanced disease. As a result, more than half die in the first year, from diagnosis to death 1 year. Yet, typically, prostate cancer runs a long course, and if diagnosed early, most patients can live for 10 years and above.
2 minutes.
So our study at Eurocare finds that our screening program was able to identify localized prostate cancer in 35% of the patients, which is a slight improvement, a significant improvement from the 10% which was reported in another study in Uganda, but we are yet to reach the high 90s or 80% diagnosis of localized cancer. Advanced cancer was confirmed in 18%, so there is still a gap of 47% who had no stage. They were never staged. Most likely these ones on clinical features, they had features of advanced disease, so the benefit of staging investigations which are costly was determined not so good. So with some of them we didn't stage, and they ended up receiving treatment as advanced disease. So the ones we are sure of localized disease is the 35%. Staging investigations, we routinely do a chest X-ray, MRI, selected cases do a bone scan and a PET scan. Yes. So in conclusion, our screening program registered a significant detection of localized prostate cancer, which offered us an opportunity to do radical treatment with the intent of curing some of them. Recommendation 1 is we need to scale up screening, prostate cancer screening, using the PSA, using rectal exam, and confirming with the ultrasound-guided prostate biopsy. In this country, we still do a lot of finger-guided biopsy, but ultrasound-guided biopsy has shown higher accuracy. That's why it's the one we are doing routinely, and this skill can be transferred to urologists. Our center, the urologists do it. We no longer need to call a radiologist to do ultrasound-guided prostate biopsy. Second recommendation is now we need a follow-up study to document effectiveness of the radical treatment, because are we curing actually these patients who get radical treatment, and what is their quality of life? Yes. Thank you very much for your time. Some of my references.
Okay, thank you, Dr. Mbaga. And our last presenter is Dr. Kakuba Frank, is to talk about surgical pathology discrepancies. Dr. Kakuba Frank is a pathologist at Mengo Hospital and Platinum Hospital. He's the head of the Rotary Blood Bank at Mengo Hospital and is currently a PhD student in cancer of the esophagus at Makerere University.
Okay. Good afternoon, ladies and gentlemen. I want to thank so much my brother here for the kind introduction. I also forgot to tell you that out of all that, I support Liverpool Football Club. Yes, my name is Frank Kakuba. I'm a pathologist. Also to mention, to note in my presentation, when I talk about pathologists, I'm going to be meaning a histopathologist or a cytopathologist. Of course, keeping in mind about other types of pathologies. But because we are talking about surgical pathology, those are the two I mean. So, colleagues, I represent your close partners, the pathologists who work behind the curtains. I must tell you, I must admit to our shortcomings as pathologists that quite often we don't show up, we don't tell you what we do, and that's why many times you think we don't have pathologists in the country, and to my surprise, many of you still refer histologies, biopsy for primary histopathological diagnosis abroad. I think that is our mistake. We haven't told you what we are and what we can do. So what makes a good histopathologist? This is not a definition of any of the medical or academic board. This is a thought of me, the old man. So you have a right to critique me on that, but later. So a good histopathologist to me equals to a good surgeon, a good quality processes, and then individual pathologist capabilities. So to make a good histopathology, to get a good report, you, the surgeon, must also be good. If you are the surgeon whose histopathology results always differ from your expectations, also check your skills of collecting the samples. I put individual pathology capabilities in italics because it contributes less to making a quality report. The eye, if your eye can see, quite often you will see the tumor, but something went wrong in preparing the slide. So the capability of a pathologist to see a tumor is it contributes minimally to the quality of the report. Oh, what happened? It's moving faster than... Oh, I'm supposed to see here, sorry. So what are the objectives of my presentation? It is intended to highlight the common causes of histopathology, diagnostic discrepancies. I also hope it will encourage surgeons to develop trust in their pathologists. It, again, to encourage teamwork or continuous discussion between surgeons and pathologists. I don't know how many of you have telephone contacts of your pathologists, or when you receive a report, you complain alone, and what you can do is to sack the pathologist. Then also to emphasize your role in making a good pathology report. What are the common causes of diagnostic discrepancies? We are talking about a same tissue or same patient. We have got a tumor sent to two different pathologists and we have different results. What are the common causes? Poor sampling by the surgeons. I put it number one, I'm sorry to say. You may give me an inadequate tissue, necrotic material, or missed target sampling. Inadequate tissue, you may enter the abdomen, find a huge tumor, and out of fear, you don't want to tamper with it, you come out with a capsule, and you send me the capsule. Or you go see a tumor, it looks bad, bloody, red, darkish, and because of your thinking that cancer is where it looks bad, you pick from the dark red area. You send to me that, actually you have given me necrotic material. Or you want to pick from the prostate and all you get is rectal mucosa and fibrous tissue. No gland is picked. So what happens when you receive the report of inadequate sample? I must tell you, colleagues, no pathologist fancies sending out a report which says inadequate tissue. It is a burden to all of us. We imagine what you have gone through to get it. No one wants it. But by the time we say that, we have really done our best. Then, poor tissue handling, no fixative. Up to now, I still receive samples in normal saline. Insufficient fixative. You have a bottle this size, you want to put the whole breast. Then formalin is 1/4, the bigger part is above formalin. That is not going to be fixed, it is going to rot before I get it. Or you squeeze it in a small bottle, it has folds. Where folds are, formalin is not reaching. That area is not going to be fixed. You must note, friends, a tissue must be well immersed in formalin and it must move around. When you move it, must move around, all its edges must get in contact with formalin. Some of you still use 40% formalin as if you are embedding bodies. It is 10%. Then, another cause is inadequate clinical information. Friends, I know of some of you who think we shall not bias the pathologist. When you disclose all I think, you are biased him and he will give you a biased report. That is a wrong thought. You must bias me to think about your fear, because there are thousands of possible diagnoses. So once you bias me about your clinical diagnosis, I am not going to settle till I deal with your fear. Poor tissue processing, that is our mistake in the laboratory. Poor grossing by the pathologist. You give me the whole breast, then I just cut a cassette, 3 things out of that whole breast, and I leave the whole mass behind. That's my mistake. Missed target microtome sectioning. We have a microtome that I'm going to show you. We have a tissue block, all the tissue is embedded in there. Then when you are sectioning with a microtome, you take a thin ribbon on top. It is likely that you may miss the cancer in the ribbons under. That is now the importance of good, adequate clinical information. If you biased me, if you showed me your suspicion that you are thinking this is cancer, I am going to section it deeper till I finish the block. If you don't bias me, I will ask myself, what makes me section all this? After all, it takes so many days. Poor pathologist microscopic interpretation, that contributes very little. All pathologists I know can see cancer. These are some case reports. Friends, I want to tell you what happened. See, a missed target sampling from a surgeon. This surgeon gave me very good information. He said it was a 45-year-old mama with a breast mass. He sampled it and sent to me the first sample. When you check, this is an H&E, that is a clear diagnosis of a benign mass. The mass is fibrous tissue and fat. I called it fibrolipoma. But the doctor had told me there is even associated lymphadenopathy. In me, I had suspicion of cancer, but that's all I could do. That's all I could see. I told him, doctor, all I can see is a fibrolipoma. He was good enough, and he did a rebiopsy and sent me the second biopsy. Many of you will not do that. What do? You sack the pathologist. You sack the pathologist, then the second sample does not go back to that primary pathologist, it goes to another one. So the rebiopsy, when he sent it back to me, it was obvious cancer. Do you need to be a pathologist to see that cancer, friends? You don't need to be a pathologist to see that there is cancer there. So it was simple as that. So it is important, friends, it is important to trust your pathologist, ask them to review. Look at the second case report. It is when you can pick a necrotic material. Unfortunately, this is eosinophilic, means orangish. So the image to the right is totally necrotic material. You could go to the tumor, and when you see that bad red thing, you pick it and send to me. In this case, when I saw it was totally necrotic material, I re-examined many times. All I was seeing was necrotic material. He got angry and sent a biopsy to my colleague. When he sent a rebiopsy to my colleague saw this tumor. Now this is a clear tumor. The one on my side is a clear tumor. And he sent it back to me and said, Kakuba, how could you miss this?
2 minutes.
And I said, actually what happened is, they didn't give me that. They gave me the bad thing. They gave you the good thing. This is the importance of a good clinical information. This urologist was very good. He said a 75-year-old with long-standing urinary symptoms has marked weight loss, severe backache, PSA of 100, and bilateral lymphadenopathy. At that point, I'm thinking about cancer. If I don't see cancer in my slides, I must check out what the hell has happened. See, behold, after all that, I see a benign tumor. Benign, this is BP, this is benign glands, benign fibrous tissue. At that point, because clinically I had a suspicion of cancer, I was not going to have the guts to tell my surgeon that I have not seen cancer. I examined my own self. What did I do? See, that is the tissue block. That tissue block has tissue embedded. That's a paraffin block. That superficial ribbon I had taken was the one which showed me benign tumor. What I had to do was to go back and section all these, even without his guidance. I sectioned all of them, and I found there, the monster, clear, poorly differentiated adenocarcinoma, in the very last bottom ribbon. If I had not suspected cancer in his clinical information, I was not going to bother cut all this. After all, what is it I'm looking for that no one has warned me about? And what was going to happen if we got angry? Look, friends, if we got angry and withdrew the block from me and said, bring the block, I want to send to another pathologist. Another pathologist would have got chance to section it deeper of my sections, and he would have found the cancer. And he's called a good pathologist, I'm called a bad one. Now, this one, I hope it is the last. This, the tumor you see there, it is a cancer-forming gland, and the surgeon sent to my colleague and called it hepatic mass. That was the only clinical information. Clinical information was hepatic mass, full stop. My colleague saw that, and he called it a poorly differentiated hepatocellular carcinoma looking like intestinal mucosa, because after all, it is possible poorly differentiated cancer can look like anything. When he got the report back, the surgeon had his fears of metastatic cancer. He had information he hadn't told him. Then he called me and he said, Wama kakuba. Wama is the word we use when we are angry with the first discussant. He said, Wama kakuba, review for me the block of a patient who primarily had a colorectal mass, now has multiple masses in the liver, and the primary pathologist has called it hepatocellular carcinoma. That's what he told me. And when I reviewed it, I already had the answers. That is a tumor looking like intestinal mucosa, and I rightly called it metastatic adenocarcinoma. So I was the good pathologist because I had the information. The very last, friends, I'm sorry, I want to talk about a lymph node. If you have a lymph node, many times you have lymph nodes and you tell us lymphadenopathy, generalized lymphadenopathy, and you stop there. There are thousands of diagnoses, and actually you are testing the pathologist to tell you what it is. Now, if you don't put suspicion of cancer in my head, I am never going to see a tumor like that one. That one, unfortunately, is an obvious Hodgkin's lymphoma. But for us to diagnose Hodgkin's lymphoma, we need to see the atypical Hodgkin cells, the Reed-Steinberger cells. Getting a Reed-Steinberger cell is equivalent to catching a grasshopper in a grass field. It takes the whole day. What will make me sit on a slide looking for a Reed-Steinberger cell for the whole day if you didn't corrupt or if you didn't influence my thinking of cancer? I thank you very much, and sorry for taking your time.
Thank you, Dr. Frank Kakuba, for that interesting presentation. Friends, we have come to the end of our session. I request for a few of your minutes so that we go into the discussion. May I request my panelists to come to the front and we have a brief discussion. not enough. Can we have the first question or comment?
Thank you so much for the presentations. My comment or my inquiry goes to Dr. Rachel. Thank you so much for that presentation. In fact, looking at your title, one would think it's positive, but from the presentation, it turned out to have been a negative experience. So my inquiry is, were those patients formally referred? And if so, was feedback given to the referring clinician? Or if they were not formally referred, was feedback given to the units that conducted the surgeries? And also, since the MDT discussions are planned, were the concerned units or clinicians given the opportunity to participate in these discussions? Then to Dr. Chigongo, just an inquiry at the age for screening the prostatic cancer. Did you have a reference age? Thank you.
Thank you very much. My name is Dr. Peter Mbide. I'm a surgical oncologist. My question goes to Dr. Kakuba. Thank you very much. It is in this kind of interaction that we get feedback from the pathologist. Thank you very much. And please, at any time, please give us that information so that we improve what we give you so that we get better results. However, I wanted just to put it out to you, to request you that nowadays, please give us a bit more, because we understand that it costs more to give us a more detailed report. If you don't give a very good report, a very detailed report, many times it will impact the kind of treatment. I'm talking especially for cancer. If the report is not very detailed, in this particular instance, I'm giving an example of, let's say, a colorectal specimen. If you don't give me all the details that I need, then I will choose a pathologist who will give me all the details that I need. So I think that's something which we need. We understand it is expensive, but you need to give us as much as possible to be able, because it impacts this patient. And the decision where I choose to send the pathologist, where I choose to send the specimen to which pathologist, is the pathologist who gives me much more, because much more will affect this patient. Thank you.
Let's try to keep the questions a bit short. This session is between us and our lunch.
I want to ask one follow-up question to Dr. Kakumba. The challenge we have with the pathologists, we give them nice resected samples, big, but the report on the lymph node yield is always a challenge. So that is a challenge we have with the local pathologists. Please, we can't give you a nice, big resected specimen with all the mesentery, especially for GI. And you don't comment even on one lymph node. That's unacceptable. Thank you.
Thank you very much. I wish you had time to ask everyone their question, but let me go to pathology, since it was also the last one. Actually, maybe I'll just do two. pathology, we've proposed before that maybe we modify the request form and modify it to kind of a menu so that the individual asking ticks exactly what they want. I want margins. I want lymph node count. I want this immunostain as well. So that helps both of us. So that the person requesting knows that I requested for all this. The pathologist knows this is what they requested. So that they also indicate the price tag for that is 2 million. So that everyone knows what is going on. To Fiona, it's Fiona, yeah? Yes, to Fiona, thank you for that presentation. I think the challenge, I'm in Arua, and a patient comes, and it appears like it's urgent, and maybe the patients can't afford to come to Kampala, and maybe I'm limited in my understanding of it. What do you suggest we overcome those barriers of needing to consult other people despite all the limitations?
Let's have 2 more questions and have the panelists respond.
Thank you so much. My question is going to Dr. Chigongo. As a man who is going to become 40 years at some point, I'm really concerned about the prevalence of prostate CA. But my question is, in your recruitment of these participants, were they 40-year-old men who had any lower urinary tract symptoms? Like, did you recruit any 40-year-old men who would come? And if so, how easy or difficult was it to convince them to do a digital rectal exam and those transurethral scans? Thank you.
Good afternoon, everyone. This is for the pathologist. I attended one of the conferences in South Korea, and one of the pathologists noted that if you don't use the right needle for the breast biopsies, chances are high you're going to get the wrong results. Here we are in Uganda with a lot of improvisation. Where are we and our results? Secondly, the surgeons are patient enough to stand for all those hours during the surgery. But when it comes to filling out that form, oh my God, they leave out the date, the age, the sex, even those obvious things. I really don't know.
Thank you very much. My question goes to Dr. Mbaga. Thank you for salvaging urology. I was beginning to feel lonely. The role of MRI, I am happy the way you presented it. I would like you to speak a little bit more because in some practice it seems to have become routine. Suspicious node, then MRI, then biopsy. How much value does it add if you already are suspicious? PSA is already elevated, there are nodules that you have already felt on the prostate. Do we really need to do the MRI vis-a-vis the cost and the benefit of the MRI? Thank you.
Okay, can we have the panelists respond, starting from my immediate left with Dr. Fiona, and then.
Thank you, Prof. Galkande, for the question. And I'll answer about the communication challenges. We have been trying to use what we have commonest to us. We've been using the WhatsApp. We just request that when we are taking pictures, for example, we talk to the patients before. So for example, an ENT in Arua or the neonatologist in Mbale will want to send me a patient, and we will ask about the patient or a picture, but she has to first ask the patient to be okay with it, and then we have the cross discussions on the phone or WhatsApp. WhatsApp has been the commonest method, but also to make things a little bit more, instead of just sending to me, we have slowly structured it such that it is a team. Because sometimes, and soon I may go away, there should be someone who has already been knowing and following up with the way we are asking the questions, what we are looking out for before you send the patient. In some instances, I only operate on Mondays, and we need to have the team ready by then. So having a patient coming in from Mbale and spending all the time when they can do certain investigations in Mbale, come when they are ready for the slot and just work them up for that, the WhatsApp actually helps quite a lot. So we use that because it's what is locally available, but because it doesn't have proper patient confidentiality, we still get the hit or ask the person who's referring to please do the due diligence, ask the patient if they can share the information outward. So what happens is that when they reach, we have a team that knows, my residents will know to look out for this patient, so the whole bit of not knowing where to go is reduced. So it has been mostly WhatsApp or phone calls, and then spreading it out to the team so that even the team that is working under me will then know that these are the questions that we keep asking, much as it may be super specialized. So that's how we're trying to use what we have to deal with the communication issue. Thank you.
I think most questions are for Dr. Kakuba. We know it.
Hello? Yeah. Okay, my two brothers backside both mentioned about oncopathology. One talked about not reporting about margins, another one talked about not reporting about lymph node status. Colleagues, I must tell you, as surgeons, also we expect you to nurture pathologists. The growth of pathologists, you also have a role, because oncopathology actually in our community, in our country, is a skill acquired during practice. It is not a course offered at the university. What a pathologist is trained to know is, I mean, if a pathologist can see that this is cancer, it is very easy to tell how far it has gone, but probably they lack that knowledge that they are supposed to go that far. So what you need to do as a surgeon, call back this pathologist and say, please, now that you have seen the cancer, tell me how deep it has gone. If you do it once or twice, the third time he will do it himself. If you keep referring to one person who was taught by an older surgeon, once that person leaves the ground, you will have no one to report about that. So please help pathologists to grow. Then my brother professor here, what he said, I think is what we should be doing. Maybe for the sake of removing any doubt, you surgeons can indicate in detail what you need. My sister there talked about the type of needle. I think that is out of my scope. That is to you, the surgeons. I can tell you what you give me is what I read. Thank you.
Thank you for the question. Doc, you asked whether the patients were formally referred. Yes, the majority of them were formally referred. Was feedback given to the centers that referred them? In about 5 cases, we were able to give feedback and to ask for more information regarding these patients. In some cases, the surgeons had moved on. Some of them had come back for MMed. For the majority of referral notes actually had no telephone number that you could reach out to. So the other thing is where concerned clinicians given an opportunity to participate in this discussion. Dr. Kakembo has been a long-standing member of our pediatric oncology MDT, as well as Dr. Sekabira, and this question has, this issue has been a long-standing issue of giving feedback to the people who refer to us, the patients. And this presentation was actually born out of the MDT, that perhaps we need a bigger forum to speak with the surgeons. And because of this particular issue, we now have multiple MDTs. For instance, we have a separate neuro-oncology MDT, where now we sit with the neurosurgeons who refer to us the patients with brain tumors. And initially, we would have children with a posterior fossa tumor that was removed 1 year ago. Patient went into the community and never returned, and now is coming with a recurrence. But now we have an opportunity to actually have pre-surgery discussions with them so that we can have a discussion along the way. So I think that's a work in progress. Same with the bone tumors. For the longest time, we had situations where a child comes, the leg is chopped off, you really don't know what it is. the orthopedic surgeon gave you nothing, and now the child has no leg and you have no tissue. But we no longer see those anymore. So I think the feedback loop is slowly working, and we are slowly working on it. And yeah, hopefully we can have less of those cases in the future. Thank you.
Yes, Dr. Chigongo.
Thank you. Thank you very much for the questions. I have 3 questions. Reverend Sister, you asked the cutoff age for screening. We use the age 40 and above to screen men for prostate cancer. I know guidelines, some say 45, others 50, but in high-risk populations, we do 40, we start at 40. And all the men here are high risk because we are Africans. There's a genetic risk. Africans, we get more aggressive disease. We die more, and our incident rates increases faster. So the whole of Urological Association of Uganda, what we are teaching, 40 years and above, all men once a year screen for prostate cancer. Second question, someone asked, how do you convince men without symptoms to go through screening? Actually, we don't convince them, they come by themselves. Awareness is improving. A man walks in and says, I heard about the prostate on the media. I've come for a check. I don't have any symptoms. These are the ones we want. These are the ones we are advocating for, and they are the ones you're likely to get localized disease, the asymptomatic type. Please remember, once prostate brings symptoms, if prostate cancer brings any symptom, it is advanced, most likely. If it gives you back pain, it's advanced. If it gives you hematuria, it's advanced. So you want to catch cancer in asymptomatic men. They actually just walk in. The last question, my teacher, Professor Frank, about MRI. Yes, screening and diagnosis for prostate cancer is very expensive. MRI costs $800,000. Prostate biopsy, if it is ultrasound guided, $1 million. So you're telling a patient to spend 1.8 to see if they have cancer. So most cannot afford. So for some selected patients, we cut it out. But it has 3 roles. The first role of doing MRI of the prostate before biopsy is to eliminate unnecessary biopsies. Generally, PSA level between 0 and 4 is generally considered normal, while a PSA of 10 and above, we consider that the risk of cancer is significant. So those ones, you may recommend prostate biopsy straight ahead, but there's a gray area between 4 to 10. The risk of cancer is small, 20 to 30%. So those are the ones we recommend MRI. If it comes out with a low score, someone avoids a biopsy. If it gives us a high score, then we do the biopsy. For those with a PSA of 10 and above, we can go straight to a biopsy, but we are also routinely doing MRI before biopsy. The reason is radiologists are saying after we do a biopsy, they find it difficult to read the MRI. The biopsy track through the rectum and prostate, they cause inflammation. So they look like cancer has spread from prostate to capsule to rectum. So if you do a biopsy and then you need an MRI after, it's recommended you wait 6 weeks. Inflammation goes down, then you order an MRI. So our Ugandan anxious patient you've told them you have cancer, but let's wait 6 weeks to do an MRI. So to cut out that, those who can afford, we tell them you need both MRI and biopsy, but it's recommended we start with MRI so we save time.
Thank you.
But those with a PSA above 50, we don't do MRI. Thank you.
Let's have one very last comment from Professor Chamanywa, and then we go for lunch.
Yes, thank you very much, moderator. And I thought this was a very relevant session to relate to my talk earlier yesterday. We talked about big data. We talked about the value of data. I think what we need to do is to standardize. So for the biopsies, for the prostate, etc., we need checklists so that when this data is entered into a database, it has a pattern. Whether you do it or not might not be the issue, but at least let us know what is expected. That way, when we start developing management algorithms and so on, we'll have a meaningful database. But if one surgeon ticks number of lymph nodes and another doesn't, then another ticks a width of tumor-free margins and another doesn't, that will cause us very confusing and useless data down the road. And so when we start integrating artificial intelligence, robotics, and so on, the machine learning will take long because the data set is all over the place. So I think it's important for us to standardize. So as professional associations, please benchmark, do the systematic reviews, and come up with the checklists. What should a pathologist report on in a biopsy coming from the GIT? It should be standard. Whether your unit is able to do it or not, that should be another discussion. You could say unable to assess. Yes, but at least you have captured that as a need. I thank you.
Okay, let's give a big hand clap to our presenters. This was a very good session. And thank you, the audience, for your indulgence. It was very lively. Let's remember that in cancer care, tissue is the issue. Thank you very much.
We will have a photo with the panel and a photo with all the delegates, and then we'll go down for lunch. Let's have all the delegates one more time on the stage, and then we will go down for lunch. Please, kindly, everyone come onto the stage. We take a group photo, and then we go down for lunch. Let's do it fast. Our lunch is getting cold. We might actually miss it. All the delegates, those ones outside, kindly come in, and we take a photo with you. Everyone, please. Let's come back to the stage. Let's do it faster. Faster, faster. Everyone. Everyone back there, kindly come to the stage and we do this and go. Everyone behind, please come. Please, please. Please get a coupon at the exit as you're going down for lunch. Get a coupon so that you can be served. Let's be back here by... be back at 4. Let's go down for lunch. Should be back at 4. Please, let's go down for lunch, unless you're fasting. Let's slope down for lunch.
Muslims who are fasting, please come and register.
the external iliac artery, external iliac vein, the rectal wall, the bladder neck, the bladder neck reconstruction, mini version of the mucosa, Masseca retract, vessel retraction. Yes. Now. Very clear actually. Hey, you push the catheter, come down this side, push the catheter. That's the urethral stem. The stitch is already put in place. Yes, that. Make it clear.
If we are going to dedicate money to do those things, you need the support of everyone so that we see the necessity and put resources where it matters. We are trying to raise awareness in the public. We are trying to raise awareness in the policymakers. We are trying to raise awareness to the people who appropriate money to see that actually there is a cost benefit by investing in certain things, because then we'll stop going abroad in some of these procedures, yet can be done here. And all we need is just some of the simple equipment. All we need is appropriately fund and smart funding to put that money where it can give us more dividends. If we are going to dedicate money to do those things, you need the support of everyone so that we see the necessity and put resources where it matters. We are trying to raise awareness in the public. We are trying to raise awareness in the policymakers. We are trying to raise awareness to the people who appropriate money to see that actually there is a cost benefit by investing in certain things, because then we'll stop going abroad in some of these procedures, yet can be done here. And all we need is just some of the simple equipment. All we need is appropriately fund and smart funding to put that money where it can give us more dividends. If we are going to dedicate money to do those things, you need the support of everyone so that we see the necessity and put resources where it matters. We are trying to raise awareness in the public. We are trying to raise awareness in the policymakers. We are trying to raise awareness to the people who appropriate money to see that actually there is a cost benefit by investing in certain things, because then we'll stop going abroad in some of these procedures, yet can be done here. And all we need is just some of the simple equipment. All we need is appropriately fund and smart funding to put that money where it can give us more dividends. If we are going to dedicate money to do those things, you need the support of everyone so that we see the necessity and put resources where it matters. We are trying to raise awareness in the public. We are trying to raise awareness in the policymakers. We are trying to raise awareness to the people who appropriate money to see that actually there is a cost benefit by investing in certain things, because then we'll stop going abroad in some of these procedures, yet can be done here. And all we need is just some of the simple equipment. All we need is appropriately fund and smart funding to put that money where it can give us more dividends. If we are going to dedicate money to do those things, you need the support of everyone so that we see the necessity and put resources where it matters. We are trying to raise awareness in the public. We are trying to raise awareness in the policymakers. We are trying to raise awareness to the people who appropriate money to see that actually there is a cost benefit by investing in certain things, because then we'll stop going abroad in some of these procedures, yet can be done here. And all we need is just some of the simple equipment. All we need is appropriately fund and smart funding to put that money where it can give us more dividends. If we are going to dedicate money to do those things, you need the support of everyone so that we see the necessity and put resources where it matters. We are trying to raise awareness in the public. We are trying to raise awareness in the policymakers. We are trying to raise awareness to the people who appropriate money to see that actually there is a cost benefit by investing in certain things, because then we'll stop going abroad in some of these procedures, yet can be done here. And all we need is just some of the simple equipment. All we need is appropriately fund and smart funding to put that money where it can give us more dividends. If we are going to dedicate money to do those things, you need the support of everyone so that we see the necessity and put resources where it matters. We are trying to raise awareness in the public. We are trying to raise awareness in the policymakers. We are trying to raise awareness to the people who appropriate money to see that actually there is a cost benefit by investing in certain things, because then we'll stop going abroad in some of these procedures, yet can be done here. And all we need is just some of the simple equipment. All we need is appropriately fund and smart funding to put that money where it can give us more dividends. If we are going to dedicate money to do those things, you need the support of everyone so that we see the necessity and put resources where it matters. We are trying to raise awareness in the public. We are trying to raise awareness in the policymakers. We are trying to raise awareness to the people who appropriate money to see that actually there is a cost benefit by investing in certain things, because then we'll stop going abroad in some of these procedures, yet can be done here. And all we need is just some of the simple equipment. All we need is appropriately fund and smart funding to put that money where it can give us more dividends. If we are going to dedicate money to do those things, you need the support of everyone so that we see the necessity and put resources where it matters. We are trying to raise awareness in the public. We are trying to raise awareness in the policymakers. We are trying to raise awareness to the people who appropriate money to see that actually there is a cost benefit by investing in certain things, because then we'll stop going abroad in some of these procedures, yet can be done here. And all we need is just some of the simple equipment. All we need is appropriately fund and smart funding to put that money where it can give us more dividends. If we are going to dedicate money to do those things, you need the support of everyone so that we see the necessity and put resources where it matters. We are trying to raise awareness in the public.
Today is a good day for the Association of Surgeons of Uganda. It's a good day for the Ministry of Health, and it's a good day for our country. But the whole idea is for us to showcase what we do in our theaters, what we do in our hospitals, in our intensive care units in Uganda, and we put it to the public so they can see for themselves. Uganda can now proudly boast of performing transplant surgery, separation of conjoined twins, complex open heart procedures, laparoscopic abdominal surgeries.
I would really want to juxtapose this same tent, the way it is, to the grounds of Parliament sometime this year or next financial year, so that our fellow colleagues are able to walk through and see what Ugandan doctors are able to do and what they are doing currently.
The small beginnings that we are seeing, the advancements that have started, the opportunities that have opened will continue to grow. We shall nurture those beginnings with you. Government must find money to train specialists if we want to see these services being performed.
We had our surgeons populate the peripheral hospitals, especially the senior ones. That would be more cost effective than having 90% of them in Mulago.
We must have good teachers, dedicated, and mentors. As the seniors go away and we see our exit door, we become mentors and supervisors to the young ones.
We need to go beyond the perspective of only focusing on clinical care and open up to other components. It will enable, reorient the surgeons in terms of the way they see things, the way they look at health in a more broader perspective.
Let the people know what you are doing. Let's make documentaries. When will those people in Kisenyi know that you can do those surgeries? Even amongst ourselves here in the various hospitals, people don't know what you do. Because most of the specialties are concentrated in Kampala. The regions don't know. I know it is expensive, but we are here to support you, to spread the good news.
This landscape exhibition is one of the ways of raising public awareness about the availability of surgical services in the country. It will help to reduce forex loss of dollars to other countries. Government will continue to provide a conducive environment for training and retaining specialists.
Imagine needing to give birth with no way to get to a hospital. Imagine needing surgery and having to wait 20 years. Imagine having no one to turn to when you need help the most. Then imagine you meet Bulamu Healthcare. Since 2016, Bulamu Healthcare and our partner health facilities have provided life-changing care in Uganda. This includes performing more than 10,000 surgeries at no cost to the patients. The value these procedures bring to each patient's life is priceless. But Bulamu Healthcare is able to perform them for about $200 per patient by working with local health leaders and teams. Bulamu Healthcare is also leading the fight against infant mortality, the #1 cause of death in Uganda. Every year, Bulamu Healthcare helps thousands of mothers safely deliver their babies. Bulamu Healthcare also provides Helping Babies Breathe training to more than 70 maternity facilities that deliver more than 50,000 newborns per year. This training reduces newborn mortality by 47%. Currently, Bulamu Healthcare partners with more than 350 health facilities to serve more than 4 million patient visits per year. And while our impact has been significant, with your help, we can do more, and we need to do more. Help a baby take her first breaths. End the wait for a surgery patient in need. Bulamu means life. Become a lifeline. Donate or partner with us to continue the life-saving work of Bulamu.
Since 2016, Bulamu Healthcare has worked with Uganda's local and national governments to make quality healthcare available to patients throughout the country by organizing teams of licensed Ugandan doctors, surgeons, nurses, and midwives. Together, we have done more than we ever expected to achieve. 325,000 plus Ugandan patients treated all time, including 10,000 plus surgery patients. Thanks to Bulamu and our partners, all of these patients were treated free of charge. In 2018, leaders at the Ministry of Health of Uganda shared key challenges of the health system with Bulamu's team. This set Bulamu on a mission of developing health systems that can improve patient care through Ministry of Health facilities and the existing doctors, nurses, and midwives.
Ndo wange nga amaze okufa yaleka akasajja kano nga kato. Mama wako n'agenda nako nga tumaze okumuziika. naye nagendanga ne ŋŋendayo. Buli lwaki olunaku olumu ŋŋenda okugendayo ng'omwana yafuna akananka wano eno ng'ensolosozi gwe yalumye. Mukyala wange oyo yaŋŋamba nti omwana alina akananka wano.
Greetings, ladies and gentlemen. My name is Dr. Frank Asimwe. I'm a consultant urologist and transplant surgeon here in the Mulago National Referral Hospital. In urology, we've moved many steps to advanced surgery in Uganda. Right now, we are able to do prostatectomy using TURP. Very few of our prostates are done open. Most of them are done endoscopically. We're able to do urethroplasties, DVIUs. We're able to do stone surgery for stones which are in the ureters, in the kidneys, PCNL, URSL, cystolithopaxy. All that is done without making big cuts. We are able to do pediatric surgery, all the abnormalities, hypospadias repairs, undescended testis. We are able to do transplant. That's the most recent thing we have been able to add to the menu of what we are offering. We are starting small, but we are going to grow in this in terms of the numbers and complexities. We've already done one, so we don't need to have our patients travel abroad. We are doing in the areas of uro-oncology. We have been able to do partial nephrectomies, retroperitoneal lymph node dissections, inguinal and pelvic lymph node dissections laparoscopically. We have been able to do this partly because we have invested in training. Many of the urologists have traveled and had specialized training. Some trainings have been done here in the country. We are part of the College of Surgeons of East and Central Africa. In the last 12 years, we've managed to train over 10 urologists in basic urological skills, and some have traveled abroad to add on advanced skills. So both in terms of numbers and in terms of complexities of cases, we have been able to increase our profile in urology here in Mulago. And also in the rest of the city and in the rest of the country. As I speak now, we've got urologists in Gulu, we've got urologists in Soroti, we've got urologists in Mbarara, in Mubende, we've got urologists, of course, here in Kampala, in various hospitals. And our aim is to train urologists so that every city has got a urologist. In Jinja, we must have a urologist. In Mbale, I think we have got one. In Arua, we must have one. In Fort Portal, all major cities in the country need to have a urologist. That's our plan for the next 5-10 years. I want to thank you.
My name is Dr. Kabweru Wilberforce. I'm a senior consultant surgeon, and I am the head of thoracic and vesicular division of surgery. And this unit actually deals with the surgery of the lung and the foregut and the chest, and also the blood vessels in Mulago National Referral Hospital. We see patients actually who are either adult and children, and they have either injuries to the chest. Those are the commonest. And one of the biggest burdens we have, chest trauma. And usually it may be blunt or penetrating. And among the blunt, we have patients who come with falls, either being involved in accidents, and they have injuries to the ribs, rib fractures, and any collections in the pleural spaces, and sometimes even the lungs themselves have been contused or injured. So depending on the gravity and the extent, we manage those patients. Also, we have penetrating chest injuries, whereby we have gunshot wounds to the chest or sharps that have impeded into the chest or following either fights, arrows and other things. So depending on the extent of the injury, in most cases we admit those ones and we actually drain out any pool collections that may be blood, air, or other fluids within that. Once in a while, we need to open up the chest to actually handle some of those complications. Also, sometimes we get patients who have other general thoracic conditions like anterior chest wall swelling sore masses, and we do anterior chest wall resections, whereby we resect out that mass on the chest and we do reconstruct. We put back the chest using different materials, and actually we are able to do that in this country. And then also we manage patients who have either cancer of the lungs or cancer of the foregut or esophagus. And that's one of our biggest now clients with the cancer of the esophagus. And depending at what stage those patients come in, if they come early, which is rare for stage 1, at stage 2, if they come early, we tend to do esophagectomies. That's when we cut off some part with the esophagus, or some part of the esophagus with the tumor, and then we join the esophagus with the stomach. So we do it in 2 phases or 3 phases. We open up the abdomen, we mobilize the esophagus, and then also tubularize the stomach, and then also open up the chest wall so that we can cut out that mass, and then we connect the stomach to the esophagus. But sometimes if it's high up also, we do a 3 incision and we go through the neck. So esophagectomy is one of the commonest surgeries we do in Mulago. Almost every Friday we do one because these are long surgeries. And also we do other surgeries on the lung. Now, depending on how injured the lung is or what congenital things that children are born with or adults acquire as they grow, sometimes also we do a number of lung reduction surgeries. What do I mean? We know that the right lung has 3 lobes. There's an upper, middle, and lower lobe. The left has 2. So sometimes if any of those has an infection, or it has been injured terribly, or if the entire lung is no longer functional, we may remove 1 lobe, what we call lobectomy, or we may remove 2 lobes, or if the entire lung on the right is injured, we do what we call pneumonectomy. We also admit patients who have achalasia. That's when we have narrowing of the gullet down there when it is moving towards the stomach. So if you can no longer swallow, we go inside there and then open up so that the patient is able to swallow, and then things go into the stomach. So there's a number of things that we do, and the Ugandans should be aware that actually we do those things in the country.
I'm Dr. Orotho Nobat, the clinical head, Department of Surgical Services in Mulago Hospital. By training, I'm a consultant orthopedic surgeon. I trained orthopedic surgery, and I was given the mandate to head the unit, the Department of Surgery, and supervise the services in all the surgical units within the Department of Surgery. The Department of Surgery is one of the clinical departments in Mulago National Referral Hospital, which offers mainly surgical services to patients in the hospital. We have 2 main areas of operation in Lower Mulago, or the New Mulago as it is known, and Upper Mulago, or Old Mulago as it is known. Of course, our main vision is really to be a center of excellence in offering surgical services in Uganda and Africa at large. We are also a center of training, a training for all the specialties in the surgical disciplines, and also as a training center for Makerere Medical School and a number of other training institutions around Kampala. We also conduct operational research in many areas concerning surgery, and we are called upon by government for the ministry for technical advice. We offer that advice to the Ministry of Health. The surgical department is broad. We have 18 clinical units or operational units, and these include the accident and emergency, commonly known as the casualty unit. This is where all the emergency admissions or patients are received following accidents, acute illnesses, and it is a screening area where patients are, and a holding area where patients are kept for 24 hours, offered emergency treatment, screening done, then after that they're directed to the various areas of specialty. We also supervise the intensive care unit. Intensive care unit is where the critically ill patients are kept and managed. And the patients there are not only surgical, they're also medical. And the ICU of Mulago acts as the main referral ICU for hospitals around Kampala. Many hospitals refer their patients here. Other clinical units include neurosurgery unit. Neurosurgery is where patients with ailments or conditions concerning the brain and the nervous system, that's the spinal cord and the nerves, are treated. And they perform a number of surgeries that involves the brain and the spinal cord. These are high-tech surgeries, and also they train a number of doctors and personnel to handle neurosurgical conditions. We also have the ENT, that's ear, nose, and throat surgery, where patients with conditions affecting the ear, the nose, and the throat, and the neck are managed. And this also ranges, and this includes both children and adults. And they do a number of highly specialized treatment in those areas of the neck and the ear and the nose. We have ophthalmology. Ophthalmology is the eye care, where patients with the conditions affecting the eye are handled. Again, here, a number of highly specialized treatment and surgeries are performed, where they restore people's vision, people who have lost eyesight, so who have conditions affecting the eyes. And then we have the surgeries of the intestines. It is divided into two, that is the upper intestinal system and the lower, known as the hepatobiliary unit, and then they say the colorectal. Colorectal is the lower one, which involves the large intestines and the rectum and the anal areas. Then you have the upper intestines, which starts from the stomach to the small intestines, the liver, the pancreas. And here again, they perform a number of highly specialized surgeries. And with modern technology, this includes the minimally invasive surgeries or laparoscopic surgeries or endoscopic surgeries, which are performed on a daily basis by the surgeons in this unit. We have urology. Urology is a unit that deals with handles patients with conditions that affect the urinary system, that is the bladder and the kidneys. Again, here they restore the urinary system of a number of patients who have conditions that are affecting the urination system. And they also perform a number of highly specialized surgeries. We have cardiothoracic surgery, cardiothoracic and vascular surgery. These are basically, they handle patients with conditions that affects the vascular system of the chest, the lungs, and the chest. That may include the esophagus or the gullet. We have the lungs, the heart, and the big vessels. Here again, they do a lot of repairs, especially patients who come with the injuries, cancers, and so on affecting these areas of the body. And then we have the oromaxillofacial or an dental unit. These ones mainly handles conditions that affects the jaw and the teeth of the human body. It's a very busy unit. As you know, many patients have a lot of dental issues and also do a number of surgeries to restore the dentition and the face, basically work around the face of the patients. We have plastic and reconstructive surgery. Plastics and reconstructive surgeries basically restore the shape of the human body and any condition that affects the skin or the shape of the body. They basically refashion the human body. And this includes restoring maybe the breast, body parts which are lost and repaired, and so on. We have the orthopedics. Orthopedics is a very big unit. Orthopedics basically deals with conditions affecting the bones and the muscular system. Here, it is again divided into very many subunits, which is the spine surgical unit, general orthopedics, the trauma unit, joint and joint replacement unit, where they do replacement of worn-out joints, and they do a number of surgeries to restore people's joints, repair conditions of the spine, and also fix the bones of patients that are involved in accidents and the other conditions that affect the bone. There are also a number of cancers that affect the bones, so they do treatment in that area as well. We have the pediatric surgical unit. Pediatric surgical unit basically offers the surgical services to children and newborns. A number of babies are born with abnormalities. Some may have what they call conjoined twins, where twins are joined together. They have organs which are malfunctioning. So their duty is to try to restore these abnormalities that are in inborn babies. Babies are born in these conditions, separation of twins. Some have imperforate anus where they cannot pass stool, therefore they restore that pathway. And so on. There are so many, and as babies are born in that condition. Another area of orthopedics which I forgot is a clubfoot clinic, where babies born with deformed legs are managed, and those deformities are corrected. It's a very active and popular unit. That's why these days you see so many babies, very few babies have abnormalities or deformities of the leg. We have a surgical outpatient unit, which basically manages all these patients on daycare. Patients are seen daily in the clinics. This surgical unit runs every day for all the various specialties. And they also do what we call daycare surgeries. Patients who come with conditions which needs immediate surgeries, they rest for a few minutes or hours, then they go home. So that unit operates on a daily basis. We also have the breast and endocrine surgical unit. This unit basically handles conditions affecting the breast and the endocrine system. Patients who have maybe breast cancers, thyroid cancers are basically handled in this unit. They perform a number of surgeries to restore or to remove this abnormal growth in those areas. The department also supervises rehabilitation care in the hospital. That includes physiotherapy. So offer a number of physiotherapy services. Physiotherapy and occupational therapy. Occupational therapy is where patients who have had ailments or diseases and has affected their abilities to work or do their duties. So this unit trains such patients on alternative methods of work and therefore survival. We also have the speech therapy. Speech therapy is where people who have lost maybe their voices, and therefore they're taught how to speak again or how to find a way of communicating. All in all, there are 18 units within the Department of Surgery that offer surgical services within the hospital. Of course, these units do not work alone. We have worked with other areas, other directors to fulfill the goal of treating patients. This includes areas of diagnosis, where we do x-rays, laboratories, pathology, postmortem. So we work together with those units because patients may have both surgical and medical conditions. A newly established unit within the Director of the Department of Surgery is the organ transplant unit. As you're all aware, Mulago pioneered the kidney transplant surgery in Uganda. So, and that's a very active unit within the department that works in ensuring that organ transplant started and will be maintained and continued. Of course, we started with the kidney transplant. We hope to progress to other organs to be transplanted, like the liver, bone marrow, and so on. So those are the various units that are really in the Department of Surgery, and they offer a number of surgical services within the hospital.
My name is Dr. Muhumuza Michael Edgar, a senior consultant neurosurgeon, heading the Department of Neurosurgery, Mulago Hospital Complex. Neurosurgery basically handles the brain and spinal cord problems. What we mainly have here are, one, head trauma, especially from accidents, the borders being number one culprit. Two, what we call congenital anomalies. These are babies who are born when they are not fully developed. They have defects. Three, infection in the brain and spinal cord. Then we do have the brain and spine tumors. We handle about 5 to 10 operations for head injury patients per day. This is a lot. This is too much. And this has not enabled us to handle the other areas, cases of the other areas I just talked about, especially the brain tumors. Most of these accidents that come in are borders. And I would like to take this opportunity to talk about helmets. Helmets have been found to be very, very protective for head injury, the extent of the head injuries. So it is strongly, strongly advised that if you know that you have to use a motorbike very often, at least invest in a helmet. The border riders, please let them have helmets. This is going to go a long way in helping us reduce on the head injury cases. With all these head injury patients we operate, we are unable to handle the tumors. For instance, as I speak, we have tumors booked as early as 2001, 2022. Of course, you can't leave a patient dying with a head injury, brain moving out, and you're operating somebody walking. These are the challenges we are having. So please, 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 let's use helmets. And the worst and very painful lately is the kids who are being hit by boarders as they move to school early mornings. The boarders, please, let's be disciplined. Thank you.
I'm Sebuya Martin, working at Uganda Cancer Institute. I'm a radiation therapy technologist responsible for delivering radiation to the cancer patients. I'm using this is a linear accelerator. It's a true beam. It is one of the best on the market. It is able to treat all cancers. We have different techniques, from the simplest, which is a 2D, 3D. Then we are also able to do advanced techniques like the IMRT, VMAT, stereotactic, radiosurgery, everything. So this machine is able to treat, and it is also able to take images so that we are sure of where we are treating as we planned this patient. It can do an X-ray, like an X-ray. It can do a CT. So all those images are used so that we align the patient exactly as we planned this patient.
My name is Michael Okecho. I'm a senior consultant pediatric cardiac surgeon and head of the pediatric cardiac surgery program at Uganda Heart Institute.
I'm Dr. Mohoze Wakaliebe. I'm a consultant pediatric cardiac surgeon at the Uganda Heart Institute.
I'm Mura Pascaline, perfusionist, working at Uganda Heart Institute, Mulago Hospital.
We have an 8-month-old baby girl who has a condition commonly called a hole in the heart, a ventricular septal defect, which is a communication between the two big chambers of the heart, an unnatural communication that shouldn't have been there. So today we are going to take this child to the operating room, and the task at hand is to ensure that that hole is closed. This baby, because of this large hole, has been in heart failure. And the baby weighs only 4.5 kilos at the age of 8 months. By 8 months, he should be weighing about 9 kilos or more. This surgery is done by opening the sternum, and the sternum is the breastbone in English, and it is done with the help of the heart-lung machine.
Here is a heart-lung machine. A heart-lung machine is a blood pump, but it provides other functions like suction. Now, during open heart surgery, the surgeon needs a heart which is asystole. He needs a heart which is not beating. He needs an empty heart. And this heart should not even receive blood. So it is the heart-lung machine that takes over the functions of the heart and lungs during the time when the surgeon is repairing intracardiac defect. So here blood is drained from the patient into our system, whereby it is filtered, it is pumped and oxygenated back to the patient. We also provide myocardial protection by arresting the heart, keeping it cold during the time when the surgeon is repairing the intracardiac defect. And when the surgeon has finished with the repair, the patient is rewarmed, the heart starts beating, and cardiopulmonary bypass is terminated.
So because of this, we have many people in the operating room, different specialties, from the surgeons who do the actual surgery, the anesthesiologist who handles the aspects of anesthesia, that is putting the patient to sleep, monitoring the patient, keeping them sedated and so on, and administering drugs. The perfusionist who operates the heart-lung machine, operating room nurses, biomedical engineers. We are able to do open heart surgeries for about 85% of the conditions that children with heart problems present with.
Where our patients, once they have been operated, when they leave theatre, the operations, you find that will depend on which type of operation we have done or what was the condition of the patient. So these patients will be admitted under critical care services in the cardiac intensive care unit. Now, these patients will recover differently depending on the number of factors. Among them is the type of defects which have been corrected, which have been operated, and the other comorbidities, or let's say the other associated diseases that these patients have been presenting. In our environment here, most of our patients with heart defects are operated late compared to developed countries where resources are immense and available to do all surgeries, and you have various centers. So here you find that we have one single center, the Uganda Heart Institute, which is capable of doing these surgeries for a population of Uganda of 45 million population. So it will be difficult that all these patients coming out of the 45 million operated on time. To give you an idea of the statistics, you'll find that in a country, each year we have about 1.6 million children who are born, and with this, let's say 1% of them present one congenital heart defect, which might need surgery or any intervention or management. So the patients are many, which means that one single center cannot manage them as how they present. So some of these patients are operated late, which means that their cardiac function or heart function, together with their cardiorespiratory, the lungs function, will have deteriorated. And once they are worked on, some will stay in ICU requiring life support or mechanical ventilation longer than habitually what would be necessary.
Having said so, we are not able to offer this service to everybody who comes because of limitations. Which limitations are mainly to do with funding of the surgeries. They tend to be quite costly, availability of materials, different supplies, lack of adequate numbers of healthcare professionals, and inadequacy of the facility in terms of the operating space and ICU and so on. So we hope that in the future, we're able to offer this service to many more patients than we have been doing up to this stage.
today is a good day for the Association of Surgeons of Uganda. It's a good day for the Ministry of Health, and it's a good day for our country. But the whole idea is for us to showcase what we do in our theaters, what we do in our hospitals, in our intensive care units in Uganda, and we put it to the public so they can see for themselves. Uganda can now proudly boast of performing transplant surgery, separation of conjoined twins, complex open heart procedures, laparoscopic abdominal surgeries.
I would really want to juxtapose this same tent, the way it is, to the grounds of Parliament sometime this year or next financial year, so that our fellow colleagues are able to walk through and see what Ugandan doctors are able to do and what they are doing currently.
The small beginnings that we are seeing, the advancements that have started, the opportunities that have opened will continue to grow. We shall nurture those beginnings with you. Government must find money to train specialists if we want to see these services being performed.
We had our surgeons populate the peripheral hospitals, especially the senior ones.
Attention, please. I just want to take this opportunity to welcome you back for this last session, and I'll be giving just 1 minute for us to wind up with whatever we're doing, and then we'll start the session. In the meantime, I want to encourage us all to scan that QR code that you see displayed on the screen, and then you give feedback. I think it's important for the next conferences, subsequent conferences, that we get feedback. So I just want to encourage us to take this minute to scan that. Yes? I had a similar problem this morning, but eventually it submitted. I think it could be a network issue. Alternatively, you can use the link if you can't scan the QR code. All right, I think in the interest of time, we'll move on. Once again, I welcome you to this session on wellness and welfare among the surgeons or among the healthcare workers. My name is Emmanuel Bua, and I will be chairing this session. So without wasting time, I just want to call upon the first speaker, who will be Dr. Jennifer Rickard. Jennifer is an acute care surgeon at the University of Minnesota with a clinical focus on trauma, surgical critical care, and emergency surgery. She's had over 80 research publications, and her research interest is in global health and surgical infections Her global health work focuses on health system strengthening, surgical capacity development, and she has been working in Rwanda with the Rwandan Human Resources for Health program since 2012. We are so much honored to have you, Jennifer. You're welcome.
Thank you so much. It's both an honor and a privilege. Can we work on the slides? All right. Before I get started, I do want to thank everybody. I've been very, not just honored and blessed to be here, but I've been so impressed with the presentations that I've seen and the work that is going on here in Rwanda, or in Uganda. It's very inspiring. Obviously, I spend too much time in Rwanda. And today, I want to talk about making that leap from going from being a trainee to being faculty. And to do this, I want to give a little bit of perspective of where I've come from. As we've talked about, I've been with the Rwanda Human Resources for Health program from its beginning in 2012. I lived and worked in Rwanda for 2.5 to 3 years straight. After that, I did a critical care fellowship and then came on to faculty at University of Minnesota, where I spent 6 months in Rwanda and 6 months in Minnesota. I did that for several years before now doing a little bit more time in Minnesota, a little less time in Rwanda. But through that journey, I've really questioned what it means to succeed as a faculty. And some of that is, let's talk about what it means to be a trainee versus what it's like to be a faculty. When you're a trainee, postgraduate, resident, there's some pretty preset expectations. You're going to show up and you're going to do pretty much whatever they tell you. There is a defined curriculum, whether you're aware of it or not. There's regular assessments. You should be getting feedback, and I appreciate that this is done maybe not consistently everywhere, but that's at least the general expectation. And you're really accountable to the program director, and even though there's a lot of other people who are more senior to you, there is kind of a role and expectation with that. And your ultimate goal with your training is to graduate. Now, hopefully through that process, you've actually learned how to do surgery and a few other skills, but that's the ultimate end point of being a trainee. Being a faculty is actually very much different. Even though you've learned all of these skills in residency, and you have a general idea of what it means to be a surgeon, there's not actually clearly defined expectations. Nobody's kind of checking in with you and necessarily telling you whether you're doing a good job or not. Oftentimes, many of us feel like, well, if nobody told me I'm doing it wrong, I must be doing okay. As an academic surgeon, you're particularly challenged because you've got multiple bosses, meaning you're responsible to the hospital that you work in, and that here would probably mean everybody within the Ministry of Health domain. But if you're an academic surgeon, you're also responsible to your university, and whether that falls under the Ministry of Education. So you've got a lot of different bosses, and you kind of have to make everybody happy, and it's not always clear who takes priority. You have some responsibility, or a lot of responsibility, and maybe some power, depending on what position you're in. But overall, what tells you that you are a good surgeon? What makes you a great surgeon? And as I thought about this more and more, it's not very clear. I can say I know people who are great surgeons, but what does that mean? Does that mean you do a certain number of cases and that's what makes you great? Is it that you have a low complication rate? Is it that you publish a lot of papers? What of these things really matters? Because I want to focus my efforts and work smarter, not harder. And so I think Prof. Galakande referenced this book earlier, talking about Atul Gawande, and he talks about being better and all the things that we do in medicine, striving to be good at what we're doing. One of the chapters specifically talks about being good as a surgeon, and he talks about how a lot of us think that being a good surgeon is like being the graph on the top, where everybody is over there on the good side, and most of us are great, and that there's just a few outliers who are not so great. But truth is, the spectrum of surgical care or medical care in general is probably more like a bell curve, and hopefully I'm at least in the middle. I'd like to imagine I'm somewhere on the far side there as one of the exceptional surgeons, but at this point I'd be happy to be middle of the road. I just hope that I'm not over here on the lower side of the bell curve. But again, I think there's a big problem in transparency that I don't actually know how I'm doing. Nobody necessarily gives me feedback, and there's no published metrics to have an idea. When somebody noted that I have 80 publications, I feel like that's a good number, but I'm not really sure what does everybody else have, and is quantity the right number to look at, or are we looking at quality, and how do you measure these things to know how you're doing? So, segueing into, this is in my free time that we all have so much of. I actually have taken on quite a bit of sport. I don't know if anybody's familiar with Ironman, but this is a triathlon. So swim, bike, and run, and it's an endurance event. So you swim, bike, and run, and you do all three of these events in one day. I don't know if you guys are English system or metric system, but to put it in perspective, if you are an elite professional athlete, you will do all these in the time period of 8 to 10 hours, depending on the course. If you are the average person who does a triathlon, you have up to 17 hours to complete this event. And what I found is that I didn't know much about triathlon when I got started, but there's all these books that tell me how to be a good runner. I can look up and know what the average time for a marathon is, both for an elite person as well as for an average person. There's all these books, and the ones on the left are all about running, but there's triathlon ones as well that tell me not only how to do the race, how to train for it, how to track my progress, how to vary how much time I spend on swimming, biking, running, all this guidance on how to do something like triathlon. But I couldn't find anything about that even remotely about surgery or medicine. In fact, Gawande's book is probably the closest one that even talks about it. The only books that you find in medicine really talk about this is the pathophysiology of disease, which doesn't tell me how to be better. I keep reading the textbooks, but you've got to take the next step further. So I'm obviously somebody who likes to read quite a bit, so in addition to the running books, I've discovered that there are some publications and books from the business world, and they talk about how businesses can be better. And so this book in particular, Good to Great, was really a comparison, like a case control study essentially of businesses that had performed better than the average and did it over a sustained period of time. And then they compared it to similar businesses that didn't have that same growth, didn't have that sustained presence. And so I think between the athletic training books as well as the business books, this gave me some perspective on at least what I should be doing and trying to apply that to how to be a better surgeon. All right, so first things first, I think you have to start and think about what type of surgeon do you want to become? And I don't mean, do you want to be a trauma surgeon versus an endocrine surgeon? I mean, are you interested in being a great clinician? Are you interested in being a great researcher? Is your passion really for education? Do you aspire to move up the ranks in academia? Meaning, do you want to be head of department, dean, minister of health, kind of stepwise up the ladder? Or are you just kind of happy going and doing your job? And not only do you need to think about what it is that you want, I think you need to know and understand what your institution wants, all right? And this means all of your institutions, all of the key players. What's important to them? Because somebody is measuring them and somebody is measuring their success. So my department head is measuring me, but my department head actually has somebody measuring him, all right? And so I need to know how he's being measured, because if my wishes are in conflict with that, we're not going to do my wishes. So if my wishes are in alignment with my head of department, my dean, kind of the overall mission of the institution, I have a much better chance of achieving those goals and dreams. All right? And again, in academia, you need to think about both the clinical side of things as well as the university academic side of things. And this can get complex and you're going to have to pick and choose, but you need to at least understand the layout of it. We also, as much as I like to just think about me getting money, I need to understand that it runs as a business. And so my institution needs to at least break even, if not make money. Because if they don't make money, they can't pay me. So some common themes that emerged going through all of this is it's pretty clear that you have to have passion. You have to have passion to do great things. So are you passionate about what you do in the operating room, or are you passionate about teaching? There's no right or wrong answer. It's whatever you're passionate about. And oftentimes I'll find that your passion really plays to your strengths. And in terms of endurance events, I will tell you, you're not going to get through surgery residency and you're not going to get through an endurance event if you're not interested in doing it. That's really what sustains you through the long haul. The other thing is having a vision. And I want to thank Dr. Bielman for giving his presentation on chronic pancreatitis yesterday, because I thought that this actually fits in very well with this. So one of the business models talks about the hedgehog and the fox. And what this is comes down to a Greek parable where they talk about how a fox has so many tricks in his bag, but a hedgehog really has one. He knows how to do one thing, and he does one thing really well. And what they found with the really great businesses, the great businesses really followed a hedgehog model. They weren't doing a lot of different things. They were doing one thing really, really well. And this is the cornerstone of what they said for the hedgehog model is, what are you passionate about? What can you be the best at in the world? And what drives your economic engine? And if you think about what Dr. Bielman talked about yesterday, I think that fits in quite well with the hedgehog model and shows why he's been so successful with that. He's obviously passionate about taking care of people with chronic pancreatitis. He is the best at it in the world, or certainly a top in the world. And there's an economic model behind it to sustain it. And again, these things are looking at long-term outlook. Right? You also need to know what your values and priorities are. And I think this really comes in helpful when you are facing difficult decisions, because if you have a good idea of what's really important to you, it helps you make those hard choices. And I like to think of this as you need to know why. Why? What's important to you? Leadership, it goes without saying that this is an important component of what we do. And again, when they looked at the best businesses out there, the leaders all almost universally practice what's called benevolent leadership. And what this means is these leaders are not crawling their way to the top, knocking everybody down on their way up. What they're doing is on their way up, they're promoting others around with them. They're finding the great people and bringing them up. And so instead of pushing themselves up, they're carried along by the people that they bring along with them. Okay? And it's just an important leadership style to understand. So try to practice benevolent leadership. That's what's going to get you to the top. I also think that it's important to get experience. And this is a challenge that we have called the permission paradox. The idea that I can't get experience because nobody gave me the job, but nobody will give me the job because I don't have the experience. So you need to find subtle little ways to gain that experience. And it doesn't mean that you're going to take on a full big task all at once, but if you find small projects or aspects of different projects that give you little bits of experience, all that adds up so that you can work your way up in leadership. And one thing that I've realized that I don't always do very well, but I think we need to talk about doing it, is just simply showing up and being present, all right? We've talked a lot about how surgery isn't on the agenda of the Ministry of Health, the World Health Organization. Nobody talks about surgery. But I think we need to ask ourselves, how often are we showing up at those meetings, showing our data and advocating? Or are we leaving it for somebody else to do it? Oftentimes I want to complain about everything that happens in my division, and then I realize it's probably my fault because I didn't show up to the meetings to either talk about things, understand things, and make change happen. So that responsibility lies on me. And I want to point out that picture on the side there. That's me getting a ticket to go to the World Championships. And the reason I got that, when so many other people could have gotten that ticket, is because I was the one there that day. So, show up, it helps a lot. It's half the battle. It goes without saying that having a great team is so important. Surround yourself with success. A lot of these business books talk about hiring the right people for the job, and I appreciate that I'm not in a position to hire people. That's not within my scope of practice. But what I can do is cultivate those around me so that they are great. And that means working with the students and residents, teaching them so that they become great, working with your nursing team, your anesthesia team. I'm quite certain that when Dr. Beelman did his pancreatitis management, one of the key things is to get a good team of support around it to help it so that you don't have to carry that whole burden all by yourself. And obviously multidisciplinary, it's been great actually at this meeting to see how much multidisciplinary representation you guys have had. Throughout all this, obviously goal setting is important, and you can probably have an entire talk about making goals. But once you've got a clear vision of where you're going, set goals for yourself and make sure that they're SMART goals, right? You've probably all heard about the SMART mnemonic here. Make sure that they fit with that so you can actually track how you're doing. The other thing that's important to think about when you're setting goals is there's process goals and there's outcome goals. So a process goal is like me saying, I'm just going to run 4 days a week. And if I consistently run 4 days a week, I have a good chance of meeting my outcome goal, which is to run the race in a certain amount of time, right? So process is how you're doing it. Outcomes is what the end result is going to be. And you can break this down with, thinking about how you might think of process goals for clinical or research metrics versus outcome goals for each of those. Once you've got your goals and your metrics in line, you can easily put together a plan of how you're going to get from point A to point B. I think we all know and are familiar that it's not going to be the straight line that you imagine it to be. It's going to be a very circuitous point, but you can get there. Another key point is think about the brutal facts. We talked about data and how it's important. Sometimes we come up with goals, but the data doesn't necessarily support that we can actually do it, all right? I'd like to think that I can run a 3-hour marathon, but if I think down and break down how fast I'd have to run, I can't actually turn my legs over that fast, so that's an inappropriate goal to set for myself. I need to look at what I'm doing now and have something practical that I can reach. And then, of course, if you're going to do all this, you need to have some way of following yourself and tracking your progress. Gawande talked about count something. Again, this is how you know if you're getting better or not. You actually have to have a metric that you're following. Other things that you can actually do is ask for feedback. It's not something that we think of doing. You might do it as a trainee, but as faculty to take the time to ask, and it might be your superior, but you might also ask the nurses or other clinical staff if they have any other feedback for you. The number one thing that actually helps you in Ironman training is consistency. So it's not the people who do some epic workout, it's the people who are managing to consistently do the work and put in the time. And I think that goes for surgery as well. Showing up day after day with a steady routine will get you where you need to go. The book over there on the left is actually about writing, talking about kind of developing a daily writing habit, because this is how you get to be a good writer, is just sitting down. The title, Bird by Bird, is the idea that somebody's kid waited until the last minute, had to write an entire book about birds, and they're like, oh, how do I do this? Well, bird by bird, you just work through it. She also talks about what's called the shitty first draft. And it's the idea that you're not going to be perfect the first time around, but you got to get pen to paper, you got to get stuff out there. So just start somewhere. I don't know if you guys are all familiar with the 10,000 hour rule. It got popularized by Malcolm Gladwell in his book, The Outliers. And the idea, the premise being that the median amount of time that it takes to become an expert at something is 10,000 hours. Now that really oversimplifies it, and Anders Ericsson is actually the researcher who came up with this, but it's not just 10,000 hours. To be more explicit, it's 10,000 hours of deliberate practice. So if I go out and just run for fun, that's not necessarily deliberate practice. What deliberate practice is meaning, well, today I'm going to do a tempo run, tomorrow it's an easy run for recovery, and then the next day it's going to be sprints or intervals or things like that. So being specific and targeted in what you're doing and what you're trying to achieve. And furthermore, his data also showed that having a good teacher or coach matters quite a bit. So think about that when you've got students and residents on your service. Giving them dedicated, specific feedback helps them quite a bit to become a better surgeon. Hopefully, I don't know if everybody here knows the gentleman there on the left, Michael Jordan, NBA basketball player, quite accomplished in his career. But I think this is one of these important quotes to keep in mind. I've missed more than 9,000 shots. I've lost almost 300 games. 26 times I've been trusted to take the game-winning shot, and I missed. I failed over and over, and that's why I succeed. So it's important to remember that, all right? You don't become better because you do everything perfect the first time. You get better every time you fail. Now, obviously, that's a little bit hard to take as a doctor, and obviously we need to be circumspect about how we're talking about failure, but learn from things. All right, so taking this all together, what would I think about if I want to be an expert in my field and as I want to progress as a surgeon to be the best surgeon? So if I have particular interest in clinical care, I want to talk about breadth versus depth of experience. And it seems like most people, to become expert, they really go into depth of experience. And while breadth, you can still practice depth, most people end up focusing on something that gives them good depth. Now, you can obviously accomplish this through doing a fellowship, but I don't think that's the only way to do it. You can do an apprenticeship model, or you can, if you don't have that opportunity for somebody to apprentice with and shadow, you can certainly get expert status just by seeing a high volume and repeatedly doing things and working to do it better every time. Obviously, you can do things like read videos, podcast, everything to get that knowledge base. And then I'd also recommend finding ways to make yourself known so that everybody starts to recognize you as an expert in your field. So doing things like presenting at conferences to show people the volume of your work and your outcomes. Similarly with research, again, if I want to be an expert in research, I need to kind of develop my steady habits, all right? The cornerstone of research is going to be writing and publishing, all right? So even if it's a small project or anything like that, get familiar with the idea of publishing, follow through on things and put it out there. And as you do more and more things, more and more opportunities will come and you'll be able to build on what you've started with. And then if I want to be the master educator, I think I put reading there first, and that's because I realized to be a great educator, you need to be on top of what's coming out there because you need to teach your trainees the top of the line stuff, the cutting edge stuff, what's new in the literature, right? You can't be teaching what you learned when you were a resident a decade or two ago. You need to keep up with the times, so you need to read more than your trainees do. There's a lot of different teaching methods. I don't necessarily think that you have to be great at all of them. Find what you're really good with and start with that. So maybe you're an excellent clinician bedside teacher, and maybe you don't like giving didactic lectures as much. That's fine. You can start there. I do think it's always nice to have in your wheelhouse some didactic talks that you can fall back on at different times. Constructive feedback is something that I think all of us should learn how to do, particularly though when you're working with trainees. And then if you're going to be an expert in education, you need to make sure that you understand the education basics and kind of participate in those activities. So things like building curriculum and particularly exams. I think everybody who's been through the exam process appreciates how important they are to write the questions, but how burdensome it can be. Only a couple more things here. This is kind of a general point that I think we all need to think about, and I'm, again, not always great at this, but the idea that you need to be prepared to sell yourself, right? Nobody else is going to do it for you. Maybe you're lucky and somebody will do it for you, but be prepared, right? So I don't know if anybody's familiar with the idea of an elevator pitch, but the idea is if I ran into somebody in the elevator in those few moments, can I sell them either on myself, my work, my research project, and come off in a great light? Similarly, you know, I can't tell you how many times people are like, oh, can you send me your CV? And you're like, oh dear, when was the last time I had that updated? So I do think this is something that you should take some time and make sure your CV is updated, or having a short bio or profile ready if somebody were to ask. And at the end of it all, take time to reflect. I do this a couple times a year, at least once a year at the least, thinking about, are things going well? What could be better? Am I happy with how things are? And if not, what needs to change? What can I do better? And I think that is all. Thank you for your time. All right, thank you so much.
Thank you so much, Jennifer. This was quite interesting, especially for a time like this. After lunch, I think this was one of the best talks. Something that caught my mind was when she said we have to be present. And I want to say thank you so much, everyone, for being present. You know, being present reminds me of a certain old friend of mine. We are now enemies anyway. But that friend used to tell me he wants to become a pastor every day. The trouble is that he never used to go to church. So I always wondered how this person wants to become a pastor, yet he hates church. But anyway, thank you so much for being present, and thank you, Jennifer, for that wonderful talk. So up next is another good one from Mr. Eutychus Gichuru. Eutychus is currently a PhD student at Makerere University. That is doing a PhD in education and management medicine. He's actually here to speak, to give us the intersection between education and medicine. So Eutychus, you're welcome.
Okay, thank you very much. And today I'm going to give a talk about how can we leverage education, management, and surgical business. Because there has been maybe the perception that, for example, medicine cannot be interdisciplinary. But I went and researched among OECD countries using secondary data and showed that actually one of the reasons as to why one of the reasons as to why surgical business is not sustainable is because there is no leveraging of some of the management strategies, both at the training level and at the practice level. And how is this the case at the training level? It is so because at the training level, the surgical schools have not learned about how to differentiate instructions, whereby they teach all the surgical students as if they are the same. And so as a result of this, some of them end up becoming pseudo-surgeons, and that is why we see some of them leaving scissors inside when they operate the brain instead of the leg, and so and so. And so I came up and also look at why is it that countries such as Uganda, Kenya, Tanzania lose much on medical tourism? Because we see countries such as India, they are benefiting very much from medical tourism. And it is because not that the surgeons do not have the skills, but it is because of the perceptions of the society that these surgeons, they are not fully baked, and if they are fully baked, it is expensive because these surgical businesses, they are not benefiting from economies of scale. And because they are not benefiting from economies of scale, because many people are going to India, the middle class and upper class, that leads to the pushing up of the cost of surgical business in these countries. And because of the surge in prices, because of partially of poor management, that is why surgical business is no longer being sustainable. And also I came and looked at why is it that it is not sustainable also. And I saw it is because some of these schools have come up and positioned themselves that for us, when we are practicing surgical business, for example, we are going to use only management by objectives or performance management objectives. Yeah, and so. So these are the methodology of systematic literature review, and mostly it focused on the OECD countries for the period between 2015 to 2023. And also, I came up and saw that another reason is because this positionality, you see that for us as Mulago, we have positioned ourselves that we are only, for example, using classical theories in our surgical business. But I came up and saw that some of those theories cannot work in these developing countries. And so I came up and proposed that some of the theories that can work, for example, you surgeons can integrate to come, but it's still a conceptualization, and I hope to develop a grounded theory, is because I saw you can integrate total quality management, the systems theory, and also transformational leadership in your surgical business. And if you combine these three elements, we are going to see improvement in economies of scale in your surgical business. And as a result of the improvement in economies of scale, the cost of surgical business is going to be low. And also, as Uganda, we are not going to lose much from not enjoying medical tourism. We are not going to take money every time to India. And that was some of the few takeaways, and I will be sharing the paper with you in the due course. Thank you.
Thank you so much, Eutychus. I think he has still had a lot to teach us, except he was really brief. And before I could begin to get to understand and enjoy everything, the talk was done. But thank you for keeping time and being precise. So we are moving on well, and we shall be moving on to the next speaker, who will be speaking about evolution of a surgical career. Now, one thing about the next speaker is, before I met him, I had a lot of good words that were being spoken about him. And then when I met him, again, people were speaking good words about him. And then when we parted company for a few years, the good words continued. Now we are meeting again, and I'm sure the good words are still being spoken about him. We are so much honored this evening to have a great teacher, a mentor, and a great inspiration to many of us here. Reverend Professor Woga, you're welcome.
this one? Good afternoon. You know, as I was trying to get up the podium, I remembered one time when I was going down steps, and the steps were going this way, and I looked this way, and I started going down one at a time. And a young man ran to me and said, "Tell me something. Why do old people go down sideways and one step at a time?" So, yeah, evolution. Of a surgical career. I took a lot of learning from what you said, and that was be present. I have hurt myself by not being present enough among the surgeons, and I have ended up being eclipsed from information. So, going forward, I'll be present, okay? Does this work? Okay. Huh? This way?
Sometimes it freezes.
Ah, okay. So, this one. So, the first question is a no-brainer, because the answer to that question is you just point to yourself, who is a surgeon. But some people have taken the risk of defining who a surgeon is. He's a medical specialist who uses the knife. You know, once upon a time it was unethical to treat anyone using a knife. And when we started using knives, we were excommunicated from being doctors. And that's why we became misters. But a surgeon uses a knife and manipulation. He's actually changing the human body physically. When I was in the medical school, I learned something about wait and see, and that defines a physician. And then let's open and see, and that defines a surgeon. And I have many great friends of mine among the physicians who say surgeons are reckless. How can you just open to see? but why are you sitting there with the patient deteriorating? So when I was in medical school, I was very, very impressed that somebody could come with a lamp and go home without it, okay? Surgeries can be done to diagnose or to treat. And I'm impressed that it is the one profession that cuts across both communicable and non-communicable diseases, okay? When you are in theater, you are the leader of the team. And this is a very happy situation to be. Surgeons want to be leaders of the team. They call themselves captain of the ship. But recently we have discovered that we cannot do surgery without a multidisciplinary team. And the surgeon can be a great surgeon, and the nursing care may fail him. So who is to blame for the nursing care failing the whole enterprise? So we can have another day when we debate whether we want to be responsible for the mistakes of the other people on our teams. Importance of surgery. Of course, that's another no-brainer. All of us are convinced of the importance of surgery, but it has been regarded as the neglected stepchild of global health. So much money is pumped into other things. The other day, I looked at my ATM card and said, what does this mean? And I was surprised it actually meant AIDS, tuberculosis, and malaria. And when I looked at it, I said, hey, is that so? In Lusoga, there is a saying that yomurwaire agedia mulamu. A sick person will make a healthy person grow fat. The amount of money people have earned from the deteriorating patients suffering from HIV is staggering, and it is almost unethical. As much as 90% of the surgical needs is found in developing countries, but only 3% of surgeries happen in developing countries. I actually, when I was young, before I joined medical school, I saw somebody who had a cancer of the penis. And it was the one that eats the penis away. And this man was, through all embarrassment to the wind, and since I was his friend, he would tell me, he would show me, and he was just, his penis was disappearing. And he did that until he himself disappeared. One of the reasons is that we have a great shortage of surgeons in the developing world. There are many subspecialties, but all those are undersubscribed. So I say, what is behind these numbers? Limited access to surgical services, especially in emergency situations. If you are, I have gone to Mulago Hospital a couple of times as a tourist. Can you imagine that? I go at night just to see what happens. And the beehive of activity is like a ghost town. What happens? Are hospitals supposed to be 24-hour operations or not? Then how can they be 24-hour operations when there are no people there at night? Low numbers to serve a population which is surging. When I went to medical school, the population of Uganda was 15 million. Now it is 48 million, and I'm still here. So the surgeons have excessive workload. These numbers are an expression of the potential damage or impact on the health of the surgeon, and the surgeons know that. As if that's not enough, I think it looks as if surgeons hate themselves with a passion. They moonlight in several hospitals. Some of them leave their assistants closing up when they run to another one. But when they do that, they hit traffic and are stressed to the hilt. This is not good for you. I mean, I know money sounds as if it is good for you, but it is costly, okay? This is a distribution of surgeons. There is such a heavy overload of surgeons in Kampala, to the extent that one day I admitted a patient in a private hospital, hoping to operate on that patient the following day. When I got there in the morning, the patient was already operated on. So we are in Kampala, almost fighting each other for patients. But out there are no surgeons. The message from the map is that there is a clear, unfair, and maldistribution of surgeons. The regional variation in access to surgical services is glaring. Surgeons are few, the demand for their services is high. But surgery is hard work. Surgeons are perceived to lead poorer quality of life. Yeah, I sometimes do part-time marriage counseling. And one day I was being counseled by, having to counsel a couple. And the gentleman was a surgeon. And he sat there almost motionless as the lady was expressing her concerns of hardly ever seeing him. And at the end of her narrative, he burst out with anger. I'm saving life, lady. You know, when he's operating, I'll not tell you what he operates on, but as he's driving a needle, it is as if he's driving it through his own heart. He has passion for these patients, which overrides his own concern for his own health and that of his family. And I tell people that you are not the Messiah. You are not born to save the world. You can try, but you still won't manage. I tell of a friend who almost became a surgeon because he enjoyed it so much. But he ended up being a very brilliant, successful physician, almost world class. Why? Because whenever he operated on 5 patients, he didn't sleep. In the morning, he woke up early and ran to the hospital and sighed relief if he found them alive. And a physician on the 5th floor in Mulago Hospital who was working all day and all night. And in the morning, his seniors were demanding even faster action. And poor lady, as she tried to stumble between labor suit and the theater, she collapsed and has never regained her full use of her brain because she got a shock. Why is there such a severe shortage? There is a shortage of individuals choosing to do surgery for a career. Why? Partly because of what I have said already, but there is also a limited training capacity. There is a time when we used to admit 2 or 3 people for M.Med. You can't do that. We did some analysis and agreed that at that rate it will take us 500 years to get enough surgeons for the population as it was then. There is inadequate remuneration for the work surgeons do. I mean, their salaries have been enhanced, I hear, and they had to wait until I quit. But anyway, I hear they have been enhanced, but for the work they do, they are hardly paid. There is reluctance to work in rural areas and remote places, as we have seen on the map. Surgery demands long, hard training, long hours of work, little private life, poor income, and considerable physical demand. These factors reduce the appeal of surgery as a career. I did some research, and I'm surprised that the Association of Surgeons is totally uninterested in that paper. And the paper was analyzing the job description of a surgeon in Uganda, and we don't have any. In fact, there is somebody who is doing lots of surgeries, and his highest qualification is that of a medical officer, MBCHB, and there is nothing to stop him. Okay? And although we graduate with MBCHB, we do surgery at our own discretion. If we did not do surgery, no one can take us on. And therefore, people choose malaria. I mean, what do you do for a patient with malaria? Even the mother can treat this child. Yeah, it is right. Training is for many hours. MBCHB is 5 years. And you finish it around 27. At least I did. And then you have, that includes internship. And internship is the only legalized form of slavery. At least it was then. These days I can see interns even going on strike. I don't know how they do it. And then you don't come back for M.Med until you have done 2 years of clinical experience, although some people these days jump that requirement. And then M.Med is for 3 years, plus fellowship. And then in Uganda, retirement is at 60. You know, you people, you should have seen me when I joined medical school. At my first lecture, I had that great big table in the Department of Anatomy, and I owe my survival to that table. I was behind it. It hid the fact that I was shaking like a leaf. And then I stay and gain experience, and by the time 60, I can talk to a classroom of 3 million people. And then I'm asked to retire. Really? By the time you retire, you have hit something called diminishing returns. At that time, you are weaker. You know, weakness disappoints. I mean, you just can't understand why you are weak. You spend that day, like today, I go home and I'm tired and say, why? Because I sat down? And then you are slower. I had a friend called Fred, and we used to compete with the elevator from floor number 1 to floor number 6. He would take the elevator and I would run upstairs and get there before. Now, you are not only slower, but you have less income when you retire. And surprise, surprise, you have fewer friends. Fewer friends. You know, every surgeon here knows that whenever I meet him or her, I say, why haven't you called me? Why? And everybody is fed up with me saying this. But it is because I am running out of friends. I need you as my friends. And in fact, maybe I'll not have another chance to tell you that as a remedy, I'm building a nursery school. And the nursery school is to buy me some noise. Because you can imagine where all of you who love me and not visiting, what will happen? Everything will be quiet. So I have built next to my bedroom a nursery school. You lose visual acuity. Actually, long ago, I was actually a handsome young man without spectacles. And actually, I dreaded spectacles. I just couldn't understand how I could put on spectacles and lose my charm. So I put on strings, and whenever I saw somebody I cared about, I put them down. But whenever I leaned down something, I crushed them and broke them. So eventually I decided that I had better put them on. But when I was newly graduated as a surgeon, I could do a herniatomy and split with a naked eye those membranes and inject between them with a naked eye. Now, and then you have tremors. You know, we used to compete with Fred, whose surgical wound would be the neatest. I mean, we used to repair these wounds so that you don't even see the line because we did not perforate the skin. But now you want to aim at and you know, the speed of thought and process of decision making also slows down. You know, there is a time I was dean for some time, deputy dean for some time, and we discussed a very emotive topic in the faculty board. And there was this gentleman, wonderful young man, and at the end of the discussion, which took about 30 minutes, he raised his hand and made the same point, raised an issue that we had just finished discussing, which means he was there but not there. And when we went back to the office with the Nelson Sankam, we said, to imagine we are headed there. Surgeons are disproportionately exposed to physical and other types of risk. We commonly use sharp and complex instruments. Risks of accidental injuries are real. We are close to our patients for a long, long time, and therefore they can pose a risk of infection. Operating theater is a dangerous place. Did you know that? It is a dangerous place. Stabs and cuts are possible. In fact, I have mandated that in our house, at least me and my wife, we are not allowed to walk barefoot in our house because we don't know whether we have diabetes today, not diabetes today, but diabetes tomorrow. We don't want a pinprick on our feet. But in theater, it is a sin to walk barefoot because you get injured. Burns and scalds are possible. Electric shocks, acute backache. I helped start a hospital, and it had a wonderful operating table. And one day I wanted to do an operation at 9 and then run to the airport and catch a plane at 2 to go to a meeting in Nairobi. The operation was supposed to be simple, but when we got there, the table couldn't turn. So we had difficulty seeing in deep corners in the abdomen, and the operation took us until 12 o'clock. By that time, my back was hurting, and I had missed a flight. Noise is a real problem, and many surgeons are becoming deaf by that day. So surgery is risky. We have mental stress and burnout because we feel a direct responsibility for this patient. Due to stress, night shifts, overwork, family strains are real. There's something I make presentations on. Maybe one day you'll ask me too, if you remember my name. They are called medical marriages. Medical marriages are a real different animals from ordinary marriages. Okay? Exposure to severely traumatized patients. Patients can be very difficult if they are anxious and angry. And then you get multiple victims. There's a time we had a bus knock down a lorry. Both of them were full of people. The lorry was coming from a funeral. And they hit each other at Chebando. People were brought by everything that could move to casualty, wheelbarrows and all. And many people were dying as we were looking. There was an achievable fire. And we got so many casualties. In fact, by the end of the exercise, many nurses had to be given days off, months off, to clear their nose of bacterial and antimicrobial resistant staphylococci. So we have this post-traumatic stress syndrome. I almost excluded this, but doctors die young. Doctors die a whole 10 years younger than the general population. Maybe the second bullet was there by a mistake. Female physicians are at higher risk than male physicians by over 250%. That can't be right. I see all the ladies here are very happy people. Men physicians are about 70% higher among men in general. They commit suicide very often. Surgeons have the greatest number of suicides, followed by anesthesiologists. Why? Surgeons, I think we had better do something to save ourselves, okay? I have a few ideas, but maybe this graph is not good. It shows that surgeons are at high risk. So I think we need to rebrand surgery. Today's surgeons, which means you, need to attract medical and postgraduate students to join the profession. I mean, the assumption is that if we are more, we'll share out the work and we'll work less hard. Surgeons must create enthusiasm for surgery by being good role models and mentors. The session this morning about bad behavior of surgeons in Mulago wasn't good hearing. But we need to change that narrative and be good role models. In fact, somebody was being asked, who is your role model? And when they said that, I ran out of the room because I didn't want all the kids to choose role models and I'm not chosen. We need to create a sense that young surgeons are recognized members of this community. There's a surgeon who was introduced to a senior surgeon. And he came and shook his hand and says, oh, so young man, when did you qualify as a surgeon? He said 5 years. He said, oh, so you are really not really a surgeon. You have not made enough mistakes. So this ties in well with the presentation we had about medical errors. Surgeons come to terms with the fact that you will make mistakes, okay? And do something about it so that you don't die from your mistakes. Recognition by other medical students. When you are a surgical student, you should be recognized as superior. After all, a hospital which does surgery is seen as a better hospital than a hospital that doesn't. We did some work with Dr. Galukandi, and I came to the conclusion that the situation of surgeons in Uganda is such that we need to recast the role of surgeons in Uganda. One, for only a third of the time, a surgeon should be a clinician. That means evaluating patients and making diagnoses and taking them to theater and operating on them. A surgeon needs to keep in touch with his profession. That is a message to Sam Ruboga. A third of the time should be a trainer. No surgeon should even flinch when an opportunity to train somebody else in the art of surgery comes along. Train all the doctors, train the graduate students, general physicians, non-physician clinicians. Many countries like Mozambique and Malawi have benefited from training them to do simple things. Supervise the management of the 80% of cases that non-surgeons can deal with. I mean, there is so much work. We needn't try to keep all of it to ourselves. And the last third, we should be leaders, managers, and advocates. We should attend those meetings in ministries and put in a word for surgery. Address the system-wide factors that are limiting the quality of surgery. Expand the opportunities. This expands the opportunities for the surgeon, because the surgeon then becomes a multi-purpose machine. In order to prepare for life after surgery, because after all, if your tremor is worse, you are not going to, nobody's going to allow you to do surgery on their brains or their neonatal hearts. So you need to have a vision of what life would be like, what you would like your life to be when you are no longer a surgeon. Have a vision. And a vision is simply defined as what success will look like. Okay? Set your goals. Some people want just to sit on the porch and watch grandchildren play. But you need to have a big sack of money for that sort of thing. I had a friend, he sat on the porch, he read a newspaper, and his wife came along with a broom to sweep the veranda and said, "Sir, could you move while I sweep here?" So he moved his chair to another place, and no sooner had he sat down than his wife arrived. "Sir, can you move? I want to sweep this." You don't want to do that. You don't want to have time you don't have anything to do with. You don't want to be financially dependent, even on your children. You know, I had a story of my friend who asked his child for some more money, acknowledging that he had received some. And the young man beguiled him by saying, "You waste money. You have no consideration as to how hard it is to make this money." And when the young man moved away for something, the old gentleman told me, "You can imagine the money he's abusing me for. It is 30,000 he gave me last month." So you don't want that to happen to you. And for your social, psychological, and physical health, you need to be ready. My career also evolved. One day I was a medical student, and when I finished, I did internship. And then when I finished M.Med, I was very self-assuring. But later, at that time, Professor Sebufo had come to me and said, let's train others. So he took me to the Department of Anatomy. So I moved to anatomy. For some time, I held both jobs. I was operating in the hospital as well as teaching in the anatomy. I started as assistant lecturer, and I'm on record to have been among the only 3 assistant lecturers Makerere has ever appointed. When they finished appointing us, they abolished the position. And later, I became a lecturer, then senior lecturer and associate professor by the time I left after 38 years of slavery. Then I went and taught myself something new. I taught myself several things, including leadership and management. I do facilitate many seminars, workshops in leadership and management. And actually, I'm now on the faculty list for the Civil Service College in Jinja, because I do that. I became a reverend in the Church of Uganda. Before I became a reverend, I thought it was going to be easy, but it isn't. And currently, I'm chairperson Education Service Commission. I do a lot of speaking engagements. I mean, I'm a surgeon, but that did not mean I'm so specialized that when I can't do surgery, I expire. Okay? So in conclusion, surgeons are important. Surgeons are in short supply, but are in high demand. Surgery is hard and exposes surgeons to many risks. Surgeons are known to ignore their own safety as they seek to ensure that of their patients. You know, there's a story of this lady who ran out of food, and he decided that the food she had better feed her 3 children, and she goes without. And soon she died before the 3 kids died. But later the 3 kids died, and when the 4 were found, the kids had died on her. The message is here: don't die to save the patients. Survive to save the patients. Surgical risk can be prevented or at least managed. A well-protected and supported surgeon serves better and for a much longer period. So the message here: strive to remain relevant even after active surgical practice.
Once again, thank you so much, Reverend Professor Luboga. I think he has really walked the talk. So we thank you so much for walking the talk. And most importantly, for those words of wisdom. Like I said, for me, I started hearing good words about him even before I met him. And I think even after this talk, somewhere in the corridors, I should hear good words. Thank you so much, Reverend. We are grateful for that. We will be having our last speaker, who is also a guest speaker, and that is Dr. Peter Ntumba, who will be speaking on Afrocentric surgical research and universal access to safe, affordable, and timeless surgery. Dr. Ntumba, I really have a lot to speak about him, but I will try to make a